and drawn on the blackboard. And asked the students, start practicing this diagram, I will come after 5 minutes. Okay? So meanwhile, I will get the time to refer the book and come back and by God's grace could complete the class. Yes? That was the situation. Then, now, the present scenario. So the topic of lesson plan is allotted to me for this BCME. Then I also have started thinking how to go about. So all this you have already learned. So what is a content, you know? Audience. So audience should be considered first or content should be considered first. That was another doubt. Then the TL methods and media. So has to be related to content or audience or both. That was also a doubt. Agree? Then how to assessment. Okay. So because these are all mature audience. You are all very mature audience. Okay. So how to assess you? How to assess you? That is the thing that has started working in my brain. So now let us see how to define it. How to define the lesson plan. It is the title given to a written statement because writing a lesson plan is ultimately you are going to do. So, which should state achievements or educational objectives or learning objectives, whatever you call it, or goals to be realized, specific means by which these can be reached or attained, smallest unit of educational experience that can be provided to specific group of learners on a specific topic or lesson. So what is the condition here? Within the available resources and allotted time frame. Okay. So it's a teacher's guide, not teacher's notes. Agree? This is how you can define the lesson plan. Then there was an association of neurologists, so in which basic science people are also included because I am an anatomist, I am also included. And there are university people also there, neurologists, neurosurgeons all were there and including paramedical nursing. And they asked me to explain them in a simple way that should be understandable to all the people, the definition of learning and memory. Okay. So, is this picture giving information of learning? Yes. When he has seen it, he has seen the burning candle, he has turned aside. So, what area of brain? So, the time given was only 5 minutes for that. So, I could do it. That was OHP 1 and I gave the definition. Recall experience consciously or unconsciously. So, the simplest definition, keeping the lowest cadre, okay, of student, okay. So that also keeping in mind I have to do it. It may appear very superficial, what is this anatomist taking this type of picture and defining, okay. It may appear to all those gurus who are good at anatomy, okay. Yes. So now what are the things we have to think? So you know all of you KYC? Know your customer. Here also we have got some C's. What are those C's? The class, the content, the coaching, okay. Then the calculation, okay. There are alternate names. You should recollect which we have used. So what is the background of the students, okay, from the previous, and what is their attention span, and what is the prior knowledge and learning experience they are having, and what are their learning preferences, that also we have to keep in mind. Then regarding the content is subject matter. So what is required for a nursing student, what is required for a paramedical, for a physiotherapy, for a MBBS, for MS, like that you have to think. Okay, same heart, you have to deal differently for each of these categories of students. Then when you are teaching, what method you will use? Large group, small group, one-to-one, online, offline, all these things we have to consider, and what are the machines you use, material you have to carry, those things also, and how to assess. self-assessment, asking the peers to assess and the student to assess. These are the things. So look at the image, okay. So all of us are adult learners. Aptitude to learn connected is. And we are learners and mutual educators. Success of a learning mission depends on the learner's joy of learning. So now, what message are you getting from this picture? Coordination. Even if you want to identify the letter A, we are asked to write A repeatedly when we are younger. Okay, so that coordination is there, and neurons also they get coordinated like that. Okay, so collectively only it is there in our body. Okay, in our systems it is there, and we have to imbibe within us also. Okay. Then yesterday Ramya Ramakrishnan madam was asking about what generations and all. Okay, so we can check we are in which generation also from this picture, and I know I belong to this generation. Okay, why we are called is boomers is after World War II everyone is relaxed and they used to produce more children. Okay, so I belong to that family. Okay, so bigger family. We are 4 in number. Thinking, all those things. Then we made something like that, okay, for that generation. Okay, so then should Gen X and Y teach Z and Alpha? Because these are all having enterprising skills and they are very much oriented to the skills and quite practical generation. And self-learning tools are there, media, methods, AI enabled, so AR, VR, all those things are available for them. So what is the role of teacher? Everyone has to think for themselves. So, and you know what are the different types of lesson plans. So knowledge oriented, that means what domain? Cognitive domain. So I have given examples, urinary tract infection, types of road accidents, they can enumerate. Then skill oriented, what domains are there? Psychomotor. Is communication a skill? Skill or not? Yes. So that's why I put it under this skill oriented. Okay, how will you explain all these examples you know? And procedural skill. What is a procedural skill also? All of you know it. And Madam has told about the SMART objectives, which I also like that word, I use it. So, in the educational spiral, whatever the triangle, pyramid, whatever these things. So, all these things are required. So, they should be specific. Clarity should be there and measurable. You should be able to measure it, assess it. And it should be feasible also, you should be able to do it. You cannot ask for a difficult machines and all to do it. And it should be reasonable also, reasonable and within that prescribed time, that's also important when you are selecting it. And when you are selecting the objectives, what you have to consider is what is the course you are dealing, which I was telling you with my examples. And is it a small number or large number? And then is it a lecture demonstration and what type of classroom and whether it is bedside or in the laboratory, that also you have to consider. And what M's you should have. Okay, there are some M's are required. Okay, money is required. Okay, for all these, for certain of them. So what material you can use, what TL methods and what media you can use, what minutes, management of minutes is, motivation, that is the most important thing. If that is there, all can be overcome. And this is the recent clay model which our students did, first year students, for what they have understood about the epithelia. This is the one. So clay is simple and non-toxic, so they have used it. Then when you are TL, materials and methods are there. So under that, what are all the material you can take? So the ultimate gist is you should have tips, tools and techniques. That's what I wanted to tell. And regarding the TL methods, whatever method, a lecture, tutorial, whatever name you call it, okay, what is role play, workshop, all you have seen, simulation, okay, that TL method should be polished, powerful, professional presentation. That should be there. And why I have shown the picture of eyeball with, you can see the layers of retina. Sometime back, even the ophthalmology basis, they were asking, retina, which layer will be inside, which layer outside? That doubt is there. Then I thought, better to keep the layers of retina in their position and show it to them. Okay. So what one requires is intellectual lens and moral retina to formulate any of their ideas. And what are the tips for steps in preparation? So learning objectives, all of you know. And you should develop an introduction. Okay. So planning the activities, how you present. Okay. Then the check for understanding the formative assessment. And you should come to a conclusion, and there should be a take-home message should be there. And so create a realistic timeline. Within that you have to do it. And this is the other day our students, they have done one activity wherein they have used the clay model on the skeleton, to identify the layers of muscles. So with a polythene paper in between. So that activity, what they have done, we have seen it. It's taking time to open up. Then we have assessed. So assessment also can be done when they are asked to do the model, how they are doing it, origin correct, insertion correct, and in between the layers, nerves where they are putting. Those things we have assessed them. See them.
Hold it at the insertion. Yes, good.
So they could show it, demonstrate it. Okay. Then, all of you must have received this one check. This list is available with you. Yes? Yes, please check. Because you have to ultimately tell. This is the lesson plan. I am going to show you how I have formulated for the topic lesson plan which I am talking. Okay, for this class. Okay. So did I do all the components? You have to check. And this copy is also available with you. Agree? You have to comment on that. Can you do it quickly? Up to what level I have come from my lecture? Otherwise keep it and tell at the end also. Okay. So what is the purpose of lesson plan? Okay. So it should have a purpose. So I have to communicate with myself first. That's what I did. What is content, what is audience, all those things. Then how to plan each step of it. How to go about in the class also. Okay. So it should be a GPS for me. Okay, or a Google map, whatever you call, to organize my material, and myself also to achieve the intended learning outcome. So then afterwards, self-reflection, as was told yesterday. Okay, what happened? So what next? All these also should be there. So when we have to show the kidney section for a student to understand what are the components in a cut section. So if we show it methodically, they will be able to understand. And we cannot make so many cut sections of kidneys. So we make one and make a list of it, label it, and take a picture like this and show it. Okay, one or two we can do it, physically we can do it. So this is one method. Then self-assessment, okay, how to do it. So what are the things you have to address? What are the major components in my lecture? And strength, what is my strength, what is my weakness? And what are the areas that needs improvement? That I have to do self-introspection, okay, every time. So that it helps me to plan for future lessons. I can plan for the future lessons, and any other extra material can I collect. This also I will think over and analyze between what I wanted to do and what I have done it. Okay, I have attained assessment. Then there can be gaps to be identified and improved.
Good evening. Now
We asked the students to plan for extraocular muscles
by
action.
placing my finger in front of his eye, and I am instructing that to see the tip of the finger and follow it. Don't move your head, okay? Now, from the center of the eye, now first we are testing the right side of the eye. I am going to test medial rectus muscle, which shows adduction action. And from here I am going to test superior rectus muscle, which shows elevation and intorsion. Again, coming back to medial rectus position, we are testing inferior rectus muscle, which shows depression and extorsion. Again, coming back to normal position. From here I am going to test lateral rectus muscle, which shows abduction action.
So
and from here we are going to test
made them into 75 groups,
elevation and intorsion.
and each group they have submitted, and wherever it has to be repeated, we made them repeat till they attain perfection. That is the one. Then sometime back, okay, you are seeing a beautiful face. Agree? All of you? See what I did for that. I have put some questions to the students also to get the answers. Okay, so I have helped them to showing these components and making them understand the development of face and contribution for the development of face by the pharyngeal arches and the cutaneous innervation of face. Okay, ophthalmic we will tell, maxillary, mandibular divisions. So comparing it towards the developmental components. This is one exercise we have done it, and the students, they will remember that face when they are writing the answers. They said we could remember that face because it is a beautiful face. If it is my face, they won't accept it. Okay, so that's why I have chosen one face. Is revision of lesson plan required? Yes or no? Yes. So based on self, peer and student evaluation, honest feedback is required, not to please me or please someone. Okay. So anonymous better because it's without fear. But if it is open, yes, more responsibility will be there on the giver. Okay. So we have to justify why you are wrong. Yes, that is another thing. In that process you will learn better, and if you are commenting on me, I will also improve better. Okay. So what are the advantages? Agree, it helps the teacher in planning, presentation, perform, remember, remind, yes, what to take. Then management, I have to manage the time and students also. Evaluation, self and students. Then the improving, teaching practice, that also. Sometime back we used to do practice, first class, usually when I had to take first conference, international conference of genetics, I had to present. At that time slide projectors, slides we have to get it prepared from Chennai and get it, and in that 5 or 6 slides only they will allow. And I used to practice looking in front of the mirror. Okay. And then asking my children to sit in front of me and giving them some tips, chocolates, and practicing. Then the department faculty also, I made them sit and listen to me, because I don't want to be get a bad name there. Better if I get a bad name here. That is the thing. Okay. Then the message also should be there. So what are the phases in the classroom teaching? Always keep the end in mind and the listener also in the mind. What is pre-active phase, interactive phase and post-active phase. All these phases which I have already dealt, so that you have to find out. Okay, this you have to design for yourself and then prepare for it. Now the activity. Yes, you have got all the material, start acting. Give your comments on the general information in my lesson plan which I have given. Open your WhatsApp, you will see it. Is it opening? Yes or no? And now you note down what is the activity of each group. Group red, group yellow, group blue, okay, green and orange. Yes? Yes? You know? Now I keep the what I have sent you. Now give your comments. Yes, now it is yours. What's your comment? You have listened to the lecture also. My lecture is also over. Now you have to give your comments only. Huh? General outline, did I mention? Yes? Yes or no? Then did I mention the objectives? Setting teach extrahepatic biliary apparatus, okay, to students. It was not given as a separate competency in the competency table, but it was given in a general one, abdominal organs under the following headings, like that it was given. So group red, yellow and green focus on this part, and the other two on bedside one. I have given that part also. You have to focus on that. Okay, keep focusing on that. Keep focusing on that. And I need your comments. I have sent those pages. You can take it onto this one. You are seeing on the computer? Okay. Now give your comments, because that will help me. Okay. This why we have done previously. What we did is for the last batch, the university exams, they have preponed it. They have preponed it. By then, we were pending with abdomen and pelvis, major component. Then we divided the students into 3 groups. One will be in the histology. So there, that gross specimen, stomach, whatever organ will be shown, and histology also. One faculty will deal with that 50. Another faculty will deal with the already recorded cassettes are there. Okay, I have got the videos that I have spliced it. And what is required I have focused. One will teach that part for the gross. So that is dissection of rectus sheath, inguinal canal, those things. And another group, 50, we will show the dissection. Like that we divided into 3 groups and rotated it. And like that we could complete it within the time. And that students appreciated because they were in small group, and we have taken extra care also. And when we have asked them to do the dissection also, dissected parts we have shown. The extrahepatic biliary apparatus we have shown, and then we have given, what are they? Clinicians should be able to tell. I think anyway I have written ERCP and MRCP pictures also we have shown. Okay, along with one more diagram which we draw in the class, that also we have shown, and asked them to draw the components of extrahepatic biliary apparatus also. So when they have gone through all these things, they are able to draw the diagrams. Then when we are asked, so there was a horizontal integration is also there with physiology and biochemistry on this liver function test. At that time also, they said we will give you 10-15 minutes time, because clinicians also they have wanted to include. So then I have to complete. So what I did is like this to understand the extrahepatic biliary apparatus. You can see the animation moving here. Yes. So like that we simplified it and explained each one of it for the students for a integrated teaching. And now I want you to focus on that extrahepatic biliary apparatus which I have given to you. Yes? Is it clear? You are able to see it? Yes, the steps. Then, what are the 5 E's? There are E's, M's, C's, so many are there in the lesson plan. Okay, so what are these 5 E's? All of you are aware of it? Okay, so engaging, drawing attention, exploring, that is the present knowledge. Then the explaining, content presentation, elaborate, application, also we should tell them. Then the evaluation, that is feedback. So what's all those components there? In the competencies I have mentioned for extrahepatic biliary apparatus, because there are several competencies are there. I have to group them, something related to that extrahepatic biliary apparatus. Gallbladder, histology, one competency they have given. ERCP, one competency. Cholecystography, one competency. So I have to pull up something related to that. That also we have to keep in mind when we are preparing for our lectures. Don't go away blindly looking at one competency. Whatever related also we should focus. Because anatomy means we have to add histology, then the developmental anatomy, radiological anatomy, surface anatomy. All those components I try to bring them together. Because there are competencies for that. In general, they will give abdomen competencies. Okay? So that is also another work one has to focus. Then, for the blue and orange, yes, whatever is entrusted to you, you have to give your feedback, and afterwards, individually you have to do the other activity. No, whatever, I will tell you. So, in that next activity I will tell you, give your comments on the bedside teaching plan. I have given one topic. For you I will give. Wait. Don't be in a hurry. So, activity 1 is a comment on what I have presented today. Okay, that I have also given in a format. And I have given a handout also. Whether I teach all those components or not, you have to check. Okay, you have to evaluate me, assess me. Okay, yes. And very frank assessment is required. For me, nothing will happen. Even if you say frankly, okay, I can go and relax at home. Okay, nothing will happen. Don't worry. Give a honest feedback. Okay, that is the thing. And activity 2 also I have given the extrahepatic biliary apparatus. Give the comments. For 3 groups I have given, they have to comment. And activity 3 is I have prepared one for bedside teaching. I don't know, I am not a clinician. I know only one bed, stretcher bed or death bed. Okay, being an anatomist, we know that end only. So that's why you are at a, you have to comment on that also. Okay, whether anything has to be added and all, you have to give. Okay. Then sometime back, you remember your general embryology class, how they used to struggle to explain you the fertilization? Yes? And blastocyst. So I also struggled, like at the 2 ends. Now it is easy. with the embryoscope photography, time-lapse embryo, I could show it. Now they will believe it and appreciate it. That is another thing. You have to think of this learners, learners' mind, to make them believe is also important. Okay, so that is one other one. Now, individual plan and submit. Start working. Yes? Emma? Em cheddam? And already you have got the competencies, TL methods. You have worked on. On that only you plan. For that same topic you plan for it. Agree? Already your table will be there. Oh, okay, okay. So you are working? This group working? Unless you complete the activity, it will not close. Whatever you have already prepared, you have worked on that yesterday, day before yesterday and yesterday. Same thing you give a lesson plan. TL methods. You know the TL methods. Take anything and how you will plan, how much time. Okay, small group. Even if you plan for small group also okay, whatever. Ante. So that's why prepare a lesson plan for the competencies selected on day 1. Anything? TL methods also you know, assessment you know. Take only 1 year. Take only 1 year. 1 year also, one topic only. And 10 minutes or 1 minute, 1 minute preceptor also you can take. That is also a lesson plan. 1 minute preceptor also a lesson plan. Do it. Everyone has to submit it individually. Don't worry about questions, plan. TL methods. Take your competency. General class and all, I have given all the things. They have started. Set induction is more important. How? 5 minutes. Topic. Yes, are you able to get an idea? Yellow? Any difficulty? Make it a simple one, whether you know, you have understood or not. Okay, we don't expect you. And you can make an elaborate one and later submit also. You are able to? Even 1 minute or 5 minutes plan also okay. 1 hour only? Okay. So madam said prepare for 1 hour.
One teaching learning method you take for the competency, how are you planning that 1 hour or 2 hours?
Yeah, depending. Because in my extrahepatic biliary apparatus is 1 plus 2. 1 hour theory, 2 hours practicals. And in that practical 1 hour, SDL 1 hour, so that they will practice and write assignment. Yes, you are able to get it? Methods, TL method, what to do? Because ours is elaborate one. So even if it is elaborate also, how to do we plan. Okay, you can do sample for 1 hour, anything. You are able to get it? You have to start presenting. 5 minutes. Who is ready? Who is ready? You can use the flip chart also faster. If you want, you can use the flip chart also. Yes, which group is ready? At what time it has to be closed? ప్లానింగే చాలా టైం పడుతుంది. ఏంటి ready? Another advantage of already prepared lesson plan is I have seen it. So if I give it to my faculty, what I have prepared for one topic, if I am on leave also, I can give it to them. These are the components, you have to complete it. And if they have the same topic also, they will use it. That is the advantage. Okay, we can share it to the others. In our absence also, that class can be conducted as per our lines. Okay, that is helping the other colleagues also. And the same thing in the form of an SDL, I will give it to the students. So how much time it will take for reading each of it. So within a framework of 30 minutes or so, you can complete reading this topic. If I give it, they will do that after the class. That's how it also helps. Same material planning, if you prepare, you can give it to a faculty, to the student also. We give it in their group, handouts. They will go through it. Ready? Yes, this group is getting ready. Others be ready. They are going to present. You are ready? You are ready? What about you? Ready? Huh? We'd like to hear you.
Thank you, ma'am.
Wait. Control. Yes. Okay. Then we go up.
Competencies in the
PPT. And you should tell competencies.
You tell.
starting from
Yes, the blue kada?
Yes.
The blue group, they have started presenting. All of you can listen.
Competency.
Yes, what is the competency you are having here only?
yes.
Read.
Our
What is-
competency is PH 1.5. Describe various routes of drug administration, their advantages and disadvantages, and demonstrate administration of subcutaneous, intravascular, intramuscular, sublingual, rectal, sublingual, intranasal sprays and inhalers.
Oh. So it is for a group of
150 students.
150, you will ask them to demonstrate?
First hour we will tell only about describe.
Okay, describe. You will ask, okay.
Our model lesson plan, subject is pharmacology, class belongs to second year MBBS, name of the faculty assistant professor, student strength 150 members, venue lecture hall gallery, time 1 hour, topic is various routes of drug administration, general objective, learner should be able to understand the various routes of drug administration and its advantages and disadvantages.
Okay.
Coming to specific learning objective, at the end of the session, the learner should be able to describe the various routes of administration, drug administration, discuss about the advantages and disadvantages of various drug administration, describe the various steps in drug administration via IV and IM route. Set induction, case scenario will be presented to the student.
Okay. Then?
Coming to content, describe the various routes of drug administration.
Yes, that is already mentioned.
Yes, ma'am. Method is via lecture.
So, only lecture with your PPTs. That's all.
Through audio visual
okay.
aid and PPTs.
Okay.
Duration is for 15 minutes. We will be evaluating by MCQs and theory questions.
Theory questions. Okay, what are your comments for that? Any comments? Any comments? It's a lecture class for 1 hour. Different
15
methods
minutes.
of drug administration. Okay. So only by PPT they will be teaching. Okay.
Audio visual
aids. Okay. Handouts also they will give. That's all. And assessment is by
MCQs and short answers.
Okay, that's for a theory class. Okay, good, thank you. Then what about this batch? Small group or something like that for you? No?
30
So
minutes,
for which
ma'am.
group? Small group or large group?
Large group, 30 minutes, ma'am. That is theory part. We are taking lecture. And 30 minutes short group discussions. And 30 minutes skill lab, ma'am.
Skill lab.
And 30 minutes we are role play and video, playing videos, ma'am.
Video. Okay. How will you assess?
Um,
So our specific learning objectives, at the end of session, the learner should be able to do define BLS, describe the sequence of steps in BLS, demonstrate effective chest compression and ventilation, explain the use of an automated AED, automated external defibrillator, perform BLS on a mannequin during a simulated scenario.
So you are going to demonstrate first?
Yes, ma'am.
Yes,
Explain
you are
the
going
steps, then demonstration, and ask the students to perform
They will,
at last.
they will observe
First,
first.
Yes.
Then
They'll
will
perform.
Okay, what do you call that?
dope.
Okay. So how will you assess?
Set induction.
Set induction?
A 50-year-old male collapses suddenly at his shopping mall. You confirm he is unresponsive and not breathing. How do you proceed in this situation? So specific learning objectives, define basic life support, content definition, indications and importance. Method through lecture, media chalk and board. Duration of this 5 minutes. Evaluation through group discussion. And second specific learning objective, describe the sequence of steps in BLS. Content is describing the steps of BLS. Method is through lecture. Media is through AV8s and PPT. Duration of this session is 10 minutes. Evaluation through group discussion, short answered questions, role play. And third one is demonstrate effective chest compressions and ventilation. Our content is like location and location and depth of compressions, compressions to ventilation ratio, chest recoil and its importance. Method is through DOP session, media, mannequin, ma'am. Duration is 15 minutes, evaluation through role play. And explain the use of an auto AED. Content is function of AED, method of placement of AED pads, and placement of function of AED. Method is through DOP sessions, media is through media mannequin, and our duration of this duration is 10 minutes, evaluation through role play. Lastly, perform BLS on a mannequin during a simulated scenario. The content is perform the steps of BLS effectively on a mannequin in a simulated environment. Our method is like DOP sessions on mannequin. Duration of this is 20 minutes. Evaluation is through observation and immediate feedback.
So total how many hours you are taking?
1 hour, ma'am.
1 hour. Okay. Good. Then?
Yeah, madam. Ours is that for interns to perform a slit skin smear on a mannequin.
To perform a?
Slit skin smear
Okay.
on mannequin. So you need only strength for 4 members. The time is 1 hour, theory 20 minutes and the practical 40 minutes we planned. Basically we divided the steps, components into indications of slit skin smear and steps in slit skin smear and demonstration on a patient and next the perform of a slit skin on a mannequin by the students, by interns that we planned. For the indication of slit skin smear, we use the method lecture or small group discussion just for or through PPT.
For 4 people.
For 4 people, just in the demo room itself. For the steps in slit skin smear with the audio visual aid for the 10 minutes or the steps, and the demonstration, I'll in the patient I will do it and I'll ask them to tell the steps. What are the steps? That is for 10 minutes. And another 30 minutes DOIP session we'll plan session. And the follow-up, depending on the assessment, we'll ask them to repeat. Like self-direct on a mannequin learn.
Okay, good. You are ready?
Our lesson plan is about pleural tapping aspiration, ma'am. So
Plural?
Pleural tapping aspiration. We give a skill lab demonstration on mannequin. So faculty, student strength around 30 students. Venues are in skill lab. Time duration is 2 hours. A topic is pleural fluid aspiration demonstration on a mannequin. So objectives is the students should be able to demonstrate the procedure of pleural fluid at the end of the section on a mannequin. An interaction, so plan is around, set induction is first pre-test for of around 10 minutes.
No, pre-test.
Yes, ma'am. Of around 10 minutes, then case-based scenarios for 15 minutes.
15 minutes, case-based scenario.
Audio visuals for 15 minutes.
15 minutes.
Then teacher demonstration on mannequin.
How much time total?
2 hours.
2 hours. Okay, okay. Otherwise they are talking. Listen, listen.
So first pre-test was for around 10 minutes, then case-based scenarios for 15 minutes, then audio visuals for 15 minutes, then demonstration on mannequin by teacher for around 15 minutes, then dividing students into groups and setting a mannequin for 5 minutes. Then we ask the students to perform for 40 minutes, ma'am, performance. Then we have post-test for 10 minutes and feedback 5 minutes, ma'am.
How many mannequins are required?
3 mannequins.
3
30 students, 3 mannequins, 3 faculties will be divided, ma'am.
So, how many times you can allow them to do?
Single time, ma'am, mostly
Still.
once.
Ask you.
Ask.
2 to 3 times.
40 minutes we have allotted for that.
So, if they are slow learners?
That's why faculty has assigned, ma'am, to teach them.
Okay. And if they need extra time and extra attention, are you going to give or no, come after 1 year?
No, we'll provide an extra time. Feedback also,
Yes.
ma'am, based on the feedback.
Okay, how do you feel? This session, all of you did wonderful. Give an applause to ourselves only. Okay? Yes. So, is this session useful? Did you learn something to add up to what already you know? Yes? So, the philosophy of life is how well you prepare for an event and how well you organized for success will decide the outcome. Do you agree? Yes, because you have prepared very well for the 5 topics which we have given in advance. And though we have given short time, you are able to do it. And if you are given more time, you will do wonderful job. Okay, I thank you for giving me this opportunity to make a delivery of the content. Okay, so hope this picture will speak to you. Okay, yes. So this is an MRI picture of delivery. Because the students will not get an opportunity. They will be asking, how will be the fetus in the womb? I have got a specimen, pregnant, full-term pregnant cadaver we have got. I have opened it and kept for exhibition. So there are a lot of crowds. So much of crowd were there for that. So that was the response. Then they have a doubt how it will be labeled. So we can't take them to the room. There is an MRI picture, okay, so which can show. And most of the obstetricians and my friends, orthopedicians, my students, they have given me a lot of material, okay. So we should be good with the clinicians. That's what I'm trying to do it now, okay, to make friends with you so that I will get some material, not as my personal property, so to be given away. Okay, I'm not going to take anything. Whatever I got, I'll give it here. Okay, so with this message, I say thank you to one and all.
Thank you for the session, madam. I personally would like to thank you. Ever since from my first year where I was wetting in my pants to now, I'm still admiring you. I don't know, ever since, I mean, for the first few minutes, I was not able to concentrate on the class and I was still thinking that how can someone be so dynamic and charming yet, even after 16 years of... Thank you so much, madam.
Ten minutes tea break. ఓకే చేయండి కలెక్ట్ చేసేయండి, కాపీ చేసేయండి, మన ఫోల్డర్ పెట్టాం కదా ఇందులో పెట్టేయండి. కాపీ చేయాలి అక్కడ రాకుండా ఉండాలంటే నేను లేదో అందులో live just visibility.
Good morning, everyone. All of you have assembled? Yes. So today we'll proceed with the next session, that is how to assess skills. Yesterday we learned how to teach and how to learn skills. Today we will see how to assess skills. So at the end of this session, we should be able to explain the methods, the various methods of assessing skills. Assessing cognitive aspect or theoretical part we all know. There was an exhaustive session yesterday about how to write MCQs or how to give questions. So today we will learn how to explain the different methods to assess skills, describe the methods of skill assessment at the workplace, how to use a skills lab to assess competency of skills, and how to design a skills assessment station. There will be a very interactive activity. You can do it. So what is the whole purpose of assessment? Why do we have to assess something? To improve ourselves and also to improve the outcome of the student. Anything else? One is to improve. Yes, to improve the performance. Yes? It serves as a motivation, yes? Capability. See, every time we assess, we are learning something. So there is learning, there is improvement, again there is assessment, so it's a cycle. You learn, we assess, get the feedback from that assessment, improve again there is learning, again there is assessment. So to discover the worth and also to improve the quality, like one of you said. So that is the whole purpose of assessment. Why do we need to assess? So what if the student fails? So what if somebody is getting distinction? Why do we have to assess? We are doing our part. Some of them are learning, whoever is interested. Why do we have to assess them? Okay. Okay, so there is a standard and you have to achieve that standard. For that, you keep on improvising. Yes, thank you. Anything else? Slow learners, excellent. To identify different types of learners and to see what we can do for them. Very good. To divert them into the correct path. There must be somebody who must be putting in a lot of time and effort, but they might not be doing the right thing. So to guide the students. Any other thing? Approach. Yes. Yes. How to do smart work. So you guide them in the right direction. Okay. So first thing, to achieve minimum standards. That is why we assess. We do all these, we conduct exams, we say pass percentage and all the rules. To ensure competence. To know that the student, when they finish the exam, when they qualify for a certain degree, when they are out in the society, they should be competent. For qualification or for licensing. Isn't it? Somebody might be very good at driving, but they might not have a license. So it is still not legal. So for the purpose of qualification or licensing, and also in medicine to ensure safety of patients. This is the first important thing. So this is why we need to assess. What do we assess? What do we measure? What all aspects how do we measure? What do we measure? Skills. In medicine, in medical skills, what all do we assess? In what? Precise and accuracy. So tell some skills in medicine. Yesterday there were so many medical things. I said no medical. Today we'll talk only about practical, clinical skills. What do we measure? We measure their clinical skill. Or if practical skill, how you make a peripheral smear, how you are able to draw blood. These are all some important skills which are performed on patients. So that is what we need to measure. How well the student is doing a clinical examination. This is another example. How well they interpret clinical data. This is also a skill, isn't it? So we can measure all these. Already we have learned how to teach these skills, so today we'll learn how to assess these skills. Management of emergency situations. So this can be done in a simulated environment. Communication skills. By far, I would say these days, this is the most challenging skill. We all say we can teach, but can we teach communication skills? We can teach, it might help them, but then eventually you have to learn it by practice and by observation. So where does these are the various methods of skill assessment. So now we are coming to the topic of OSPI and OSCE. What is OSPI? Objectively structured, practical, or CE is clinical examination. So at the base of the pyramid is the recall type of questions, that is the nose. What pyramid is this? Miller's pyramid. It shows the levels of competence. After that it is knows how, and then it is shows how. So now when we are assessing skills, we are assessing this component of shows how. We have to see how the student is performing. So these are the various skill assessment methods. First is OSPI or OSCE. It is a structured clinical or practical examination. And then we have OSLER. It stands for Objectively Structured Long Examination Record. Then there is mini-CEX, that is a clinical evaluation exercise. Then there is DOPS, direct observation and procedural skills. So what is OSCE? So today I'll focus only about OSCE. The last two methods, Ramya ma'am will take over. So what is OSCE? Obviously, as the name suggests, it is a structured examination where the student performs and there is an examiner will assess. So a student has to perform step by step. Each step is given a score. So how does this differ from the traditional method? Exactly. You only see the outcome. You are sitting somewhere else, there is a patient, when you go he will say this is a patient of cardiac failure. Somebody else would have told him. But you are not looking at the exact steps of examination. Individual course and individual faculty, individual department, depending on how many people you have. So that is highly subjective. So here the main objective is examiners don't ask them any question. What do the examiners use? Checklist. They use an already approved checklist. So whoever is the examiner, it doesn't matter. So the objective main thing, examiners use a checklist, a standardized checklist. And this checklist is beautifully structured. It will be structured. For example, greeting a patient has got half a mark. Introducing your name and familiarizing with the patient has got half a mark. So you have a structure. So every trainee sees the same problem and performs the same task within the same time frame. So there is absolutely no place for any bias. Everything is same. Okay? So it can be practical or clinical. If it's practical, you call it as OSPI. If it is a clinical skill, you call it as OSCE. So like you all said, traditional examination, these are the disadvantages. There can be student variability, or there can be patient variability, examiner variability. What do you mean by student variability? Exactly. So here, see, imagine the question is the same. Question is the same. So what do you mean by a student variability? Each person might think it is something else. They will approach it in a totally different way. Examiner variability, sorry, patient variability. Some patient might be friendly to somebody. A beautiful girl is coming to examine, he must be very nice to them. A very strict boy comes, he will not say anything, please go, I am tired already. So that is a patient variability. Then you also have examiner variability. I think we all agree upon that. Okay. No offense. So to avoid all this, so in the traditional method, the final conclusion is given importance, rightly said. So to avoid all this, we have now improvised to use OSPI and OSCE. So the traditional exam, it is usually subjective and it mainly tests the cognitive aspect of knowledge, the cognitive domain. How about OSCE then? These are performance based. You can also have cognitive OSPIs where you give a set of questions and then ask them to write. But again, the questions are the same. The marks allotted for each question also will be the same because the examiner has got the answer key. Only if that point is there, they will get this many marks. Okay? So how to do OSPI or OSCE? What is the whole structure of this arrangement? Some of you must be doing in your departments. So how do you design it? Case scenarios, okay. Workstations, yes, that is the word. You have workstations. Again, how many workstations? It depends. Depends on the whole situation. So you create what is called as workstations. So what type of workstations? So you create stations and it's mandatory for students to rotate through all the workstations. That is how we create an OSPI exam. Different types of workstations are there. It can be a procedural station. So procedural station means what? They do some like? Okay. Blood grouping. Yesterday they did something. What did they do? They gave an IM injection. That is also a procedural station. Any other example for procedural station? Peripheral smear. Yeah, making a peripheral smear. That is also a procedure. Anything else? Measuring BP. Yes, measuring BP. These are all some basic stations, procedural stations. There can also be a response station. Meaning? Yes, they can see an image or they can see a case scenario and answer the questions. You can give an X-ray. But they don't play videos as long as you display images. Usually in physiology, there are some charts and you number them and write what is 1, what is 2, what is 3. So these are all some sort of response stations. I would say a better version of spotters, something like that. Then there is a must-pass station. The student has to go through that station. That means that is a very, very important competency which has to be assessed. Otherwise also there is nothing like a choice. There can be rest stations in between. Say 4 stations and then there is a rest station. Then again there are, like how we do in the traditional spotters, there is a rest station in between. So these are the different types of stations. So this is an example of what type of station is this? Procedure station. What is he doing? Something related to the lab. Okay? So this is an example of a procedural station. How much time do you think is ideal for each station? 5 to 10 minutes. 5 to 10 minutes. Okay. Is it feasible? Is 5 to 10 minutes feasible? Of course it is feasible. We only have to plan and organize it in such a way that it can be done. So minimum of 4 minutes up to 10 minutes. Each station can go up to 10 minutes, not more than that. So number of stations ideally is advisable from 15 to 20. So 20 maximum. Each station can be allotted about 4 to 5 minutes. This is, I would say, ideal situation for us because in exams we get 25 students. Not more than 25, but maximum of 25 students per day. Rotation through all the stations has to be compulsory and it has to be designed in such a way that the students don't get confused. Okay, so that is one of the disadvantages of setting up an OSCE station. What is it? So you have to make them move in order. Allotted for that also. They will have to read the instructions first, then go inside where the examiners are sitting with the checklist, perform and then come outside and rotate in a very structured fashion. So this is also another example of an OSPI station. So what is this? What is she doing here? That is a rest station. So depending upon if you want to give them any refreshments or water or anything. This is, what type of station is this? Response. It is a type response station where they are analyzing an X-ray. This is OSPI or OSCE? Clinical? Practical. Clinical, it can be clinical also if you say it is in a simulated environment. Okay, so don't get confused. OSPI or OSCE, it's okay. This is an example of a OSPI question. So what is the question? What do you want to test? Examine the specimen of urine for protein. We have done this in biochemistry, isn't it? So normally we used to tell and say yes or no. They will come and ask some questions. I remember in my exam I had discarded. I didn't know that I have to wait for the examiner to come. Then I was pleading them. I said, no sir, I did. Okay? So these are the steps in which we assess. So half a mark is given for what? Whether the person has taken adequate urine sample or not. Does he or she boil the upper 1/3 of the column? So for that, 1 mark is allotted. You see 1.5 marks is allotted for what? For the last one. Does she compare change in the top layer with the bottom layer of the urine? See, this is subjective. If you frame a question, you are independent to allot marks. For the most important steps, you can give more marks. For the least important steps, you can give less marks. But again, if you're doing it in a department, all the members of your department have to agree that this method can be followed. That is what we say a standardized checklist or a checklist on which everybody has already agreed upon. So this is another example of a model OSPI station. So what is the question? There's a parent of a sick child. A written case scenario of this child is provided, and read this carefully. And write a prescription for the above case scenario in the sheet provided to you. Is this clear now? Is the question adequate? Clear? Yes. See, if you want to ask for counseling, then don't ask about the recall aspect. A prescription is given. Counsel the mother how to give the medicine and what to look out. So this is fine as long as you want to assess. What are you assessing here? How to write a prescription. Diagnosis has already been provided. You only want to know how the student is going to write a prescription. So this is an example. This is a model OSPI station. Another case scenario is there. Please go through this. And tell me what all questions can be added in the checklist. So there is a child who has fever and a runny nose. Okay? There is no cough or ear discharge, weight is normal, exclusively breastfed. He's playful but has a blocked nose, his lungs are clear. Is this a risky case? It's not a risky case. Now what all steps you want to assess? Now this is the case. Diagnosis is already given. You want the student to prescribe medicine and tell some instructions to the mother. What all questions can be added in the checklist? What is the first step? Introduction. Familiarizing with the parent, because obviously it's an infant. So you make friends with the parent. Then examine. Next. History. Okay. See, it's already given. It is a low risk case. You already know the diagnosis. You examine then. Write the prescription. Yes. Write the prescription. That's all is left in this. Write the prescription and then counsel. Counsel. Tell the mother that it's okay. Nothing will happen. Your child will be fine. So this is an example of the checklist for that case scenario. The first one is you greet the patient, speak in a professional manner, you explain the illness, what could be the probable causes, and you reassure that nothing is just a common cold, nothing is going to happen. How many marks for that? If it is done completely, you give 1 mark. Partially done, half a mark. Poorly done, quarter. See, these columns are again, if you want, you can include or you don't have to include. Instead of 1, you can straight away give half. Maximum mark is 1. How much ever they score, you can give that many marks. What is the next step? You explain the prescription. You explain how to give the nasal drops. Explain possible complications. Say if the fever doesn't come down, please come back again. And lastly, you say, continue breastfeeding. Don't give anything else. Don't listen to others. You can do. So you have these many steps. So you have total of how many marks? 5 marks. You have allotted 5 marks to this station. Once you give marks for each step, you have to add up. So total out of 5, how much the student has got. So like this, if there are 20 stations, individual station marks the student has to know. So that is another important aspect of OSPI or OSCE, wherein the feedback is immediate. You can give them the feedback and you can tell them which step he or she has gone wrong. Okay? So what are the first, I'll just take you through all the steps very quickly, steps in setting up an OSPI station, because you will be doing that later. So what is the step 1? You should have a clear objective. First you should know what you are expecting out of the student. For example, the student must be able to diagnose and treat a case of hypothyroidism. Is this clear? Pretty much. Pretty much. But then if you make a checklist, it's going to be exhaustive. Either give a patient of hypothyroidism straight away and ask them to write the treatment, or say just examination. So whenever you're framing an OSPI station question, your objective should be very clear and crisp. Measure the BP in resting position, or measure the BP in supine position. Okay? Whatever it is, it should be clear and specific. The next step, you identify the practical aspect. That means break it down into steps. Okay. Where is step number 3? Okay. Yes, this one. You select the task. Yeah. Yes. Okay. So then you select the task for assessment, break the task into subtasks, assign scores. depending on importance given for each steps, and then you set up stations. In the station, what is required? You need to have a clear set of instructions first. First make a clear set of instructions, then should have the necessary material. Should have the necessary material in each station. If it is a patient or a simulated patient, train that patient properly. Like how yesterday ma'am was training a patient for hyperthyroidism. So train the patient beforehand so that their response should be the same when any candidate comes. Assessor. You have to instruct the assessor. Usually most of the time what happens, we also conduct OSPI exams. Somehow every time the external examiner goes on and on and on and on and on. So we tell them also that you just have to see whether they are eliciting knee jerk or not and give them marks and let them just go. They will make them sit and what is the root value of knee jerk? What are the other positions? How are you holding the hammer? So it becomes like a clinical case. But that is not the way. You have to give clear instructions to the assessor. They should only observe, give marks in the checklist. When the time is over, let the student go. So this is another example of OSPI stations. What is this? Simulated patient. Okay, OSPI station in which there is a simulated patient. This one, they are performing BLS on a mannequin. So this is the design of OSPI stations. So you see station 1 is a history means there can be an objective telling elicit the history from the patient. That's all. So that is one station. Then you have a response station followed by a procedural station, then rest. So you see for every 4 stations there is a rest station. So if we have 15 or 20, we can have rest stations. If we have only 4 or 5 stations, I don't think a rest station is required. Okay. What are the advantages of this OSCE now? Very good. There is no bias. Student bias, examiner bias, no bias at all. So there is no scope for any bias. Yes. Stepwise you can grade. We used to fight for marks in mathematics, no? I have written everything, but only answer is wrong. Out of 5, you give me 3.5. So like that. You can judge them on steps, not only the final conclusion. So, you know what? Students don't fail at all in this kind of exam. They somehow, all of them get good marks. Definitely greeting everybody will do. Whether they know the subject or not. Hi, hello, I'm so and so. So 1 mark there, they will definitely get. Now if you say BP examination, at least the cuff somebody will tie. Half a mark for that. So I don't know, some students might not even know where the radial artery is, but then most of them will know. So mostly they will manage to pass because they will know the steps. The same person who greets the patient very well, you ask him normal BP, he might not know. But at least in the other stations, maybe they will perform well and they will get through. So what are the advantages? First thing is there is no bias. Then it is structured. Next. Time. Okay. Yes. Effective time management. Yes. Any other advantages? Yeah, that's what. There is no bias. There is no bias. It's not easy to plan. It's not. Once you plan, it's easy. Yes. Exactly. Yes. So planning is exhausting. But once you plan, it is there as a record and it can be used for subsequent years. That's the point. Anyone? Any other advantages?
Deficits in the student can be to the point, can be...
Exactly, sir. And it can be given immediately, then and there. Feedback can be given then and there. It is there on record. So you don't have to be scared of the examiner or you don't have to be ashamed as a student. So it's all there. They will know that you have not done this step, so you have not got this many marks. Excellent. This group? No bias. Over. Maybe. Still, some bias might be there. Scoring, no? Again, out of 1, examiner might give half for somebody, 1 for somebody, so minimal. Any other advantages? Yes, very good point. Once again. Yes. Exactly.
Both practical and responsive type can be assessed at a time.
Not only practical and clinical skill, even your knowledge-based questions also can be assessed. Yes. Reasoning type of questions you can give and critical thinking skills can be assessed. Yes. So.
This can also be strict on the teachers because we need to teach.
Definitely, sir. Definitely, it is. That will come in the disadvantages of OSCE. It is exhausting on the part of the teacher because we also have to update, we have to create these questions. So it's not easy to create a checklist. We have to first sit and go through the material and get approval from everyone. So we also have to improve our standards. So first thing, the advantage is it is individual competency based. We can assess each competency. The scoring is objective. It's not like 15 marks question. Each step has got a different score. It's objective, that means anybody, any assessor can come and sit. If they go through the checklist, they can allot marks. Simulation can be used for acute cases. Can we keep acute MI? Planning is exhaustive. Manpower, resources and logistics. You will need a room, you will need cubicles, and you will need a room, you will need cubicles, and a lot of printed items and a lot of things. If you have an X-ray station, you need a, what do you call that? Box. If you have to assess for BLS, you need mannequins, a simulated patient, everything. It is quite time consuming and tasking when you have to organize these stations. So you have to organize it very carefully. Breaking clinical skills into individual competencies is also a task because you have to critically know which point to which point is one step. Observer fatigue. Imagine the students are moving, they are happy. Imagine the plight of the examiner sitting in that station. 50 students into 50 minutes. Even if you say 1 minute. How much time? More than 2 hours, no? So this thing will go on for 4 hours or 5 hours. So imagine the observer. So there can be an observer fatigue. We can change the examiners, but again you will be subjecting the student to bias. Logistics problem, as rightly pointed out. For any small thing also you need to make 1,000 phone calls. Sometimes you say you do it better than asking someone else to do it. Okay, I think I'll stop here. Madam will take over the other technique, that's OSLER and mini-CEX. After that, each of you will be given a competency. You have to design an OSPI station, create a checklist, and do a demo. One of you will be the observer, one of you will be the student, and all that. Thank you. Any questions? No questions? Thank you.
Thank you, Dr. Ramya. Okay, everybody wants to stand and stretch. Do yesterday's exercise like Kishore did. You want to please stand and stretch. I know it's, we're going to keep you in place till lunch at least doing something, but the next, after my small talk, you will be having a lot of activity to do, so that time you will also be busy. So just, we are distributing 2 sheets, just keep it there with you. Vijay is doing the exercise, see, diligently, more than all of you. He is also sitting the whole day here, okay. Tell me when you are ready, then I will start. Just keep the 2 sheets that has been given to you with you. Just keep it there with you. Don't look at it just now. When I come to that, I will ask you to refer to that. Okay? Okay, shall I start? All okay? Toffees are there on your table today? Okay. Water if you want, you can take a water break. Okay, so now we saw 2 important methods of skill assessment. One is OSPI, which is practical, and another is clinical skills. So we have, Dr. Ramya has taken through the steps and what are the advantages, disadvantages. All of you were nicely given your inputs. So we will look at 3 more types of skill assessment, which can be used for UG, interns, as well as PG. Okay. So next is what is called as objective structured long case record, or OSLER. It's basically nothing but a modified long case examination. So all of you, if you remember your MBBS and your MD days, MBBS rather, the long case, what happens? You're the first student in the roll number, poor soul, okay? Examiner is fresh after a nice breakfast, nice hotel he stayed and he's come, he or she, avladhan, 1 hour long case questions. And then as the day proceeds, by lunchtime he is tired, he's worrying what time he'll be able to get back to the hotel, or she'll be worrying when to catch the taxi back to the hotel. Afternoon session fellows, jolly, or towards the end of lunch, gada gada gada, 10 minutes, long case is over, right? So this is not fair on the student, neither is it fair on the first student, nor the fair on the last student who may be bursting with energy, waiting to exhibit his or her knowledge, and hardly any questions are asked. You know, sometimes you have this enthused student coming and crying to you, ma'am, he didn't ask me anything, I don't know whether I'll pass the exam, he just asked 2 questions, first candidate is asking 15 questions. How is it fair? No, nowadays students are very, very sensitive to all these issues. They are not happy if you do this kind of a biased examination. So this is something called a structured long case examination. You give whatever half an hour for them to examine the long case. After that, there is a timer there on the table. 15 to 20 minutes only you can take. In that, you should have a 10 items that you are analyzed as a student presence. So this is more objective, it is structured, and it's more fair for the student, easier for the examiner to mark, right? After some time, you all have been examiners, I'm sure. After the 10th candidate, you don't know what they are talking, what they are saying, what you have registered, whether to give marks. Same as see, we always compare, no, same as a first candidate, second candidate. That is a halo effect yesterday sir was talking about. You are impressed by the appearance, impressed by the English, impressed by the spelling and the writing, but whatever they are talking is rubbish, but anyway you give marks. So that halo effect will also start coming. So if you do it in a very structured fashion, even a long case examination is a nice exercise both for the student as well as the examiner. So you just modify it into history taking, you have 4 steps, okay. Then physical examination, 3 steps. Management, if you want to ask, there are only 3 things that you test. Each one you give one, whatever preordained marks, depending on how much is a long case mark in your university examination, whatever the rule says. So if you, as the student is examining itself, you can mark how he is taking the history. What happens here in most exam, student is taking history at the end of the hall, examiner sitting under the fan and the AC nicely here. You don't know what he is asked or what somebody has come and helped him. So this is directly you are observing as they are taking the history. It's more authentic and you can quickly mark them even before they start presenting, how are they taking the history. So it is very, very structured, and each one you assign the marks according to whatever the total marks you can divide it. So even in the university examination, there is, for long case, 5 divisions are given. History taking is one big chunk, they give some 5 marks. Then case sheet writing, differential diagnosis, investigations and management. But you don't know what kind of questions you have to ask. So each thing you can ask what are the appropriate investigations in logical sequence, clinical acumen. So it is more structured than our arbitrary long case. So this is something that you can devise in your own department and use it for your long case examination. So the next one is called mini clinical evaluation exercise. So this actually started way back in the 1970s by the American Board of Medicine. They had what is called a clinical evaluation exercise. Just like what of the student is examined on only one case, one long case is given, and then 1 hour the examiner is there with the patient, with the student and the patient. By just one case, that's what happens in most of our exams, right? That one case decides your future, whether you're going to pass or fail. So that particular performance is going to determine. So slowly they said this is not a fair way. So they broke it into what is called a mini clinical evaluation exercise. That is like formative assessment. Throughout the 3 years of or 5 years of undergraduate or 3 years of clinical medicine they come for posting, or throughout the 3 years of their PG course, in small bits, small cases in different locations. It can be in the OPD, it can be in the ward, it can even be in the procedure room, in the theatre, or it can be in the emergency ER as a patient comes in with MI or whatever, some sweating or pain abdomen or gastroenteritis or obstructed hernia, whatever it is. That time, if the patient is comfortable and safe enough, you can ask the student to interact with the patient, and you do, if you just see the form that I have given, mini clinical evaluation exercise, there is a score sheet. Okay, so there it tells the name of the student, name of the examiner. Okay, what is the setting? Is it OPD? Is it ward? Is it theatre? Is it emergency? Is it ICU? Whatever it is. And what is the level of complexity of the case that you are given? So if it's a first year, if you take a final year student, you will give only a simple case, right? You won't give a case that you're going to give it to your PG. So what is a complexity? Is the student has been exposed to this or not? That grading is also there. So that will actually help you in judging the student. If it's a very complex case and they do fairly or below average, still I think it is good for the student. So the complexity of the case, the consultant has to note down. And then you have various headings under which you can assess. You can't spend 1 hour in the ER assessing the entire history, physical examination, investigations, management, post-op care, etc. Today you will say, okay, I want you to assess only on history taking. So for that, there is grading. Okay, satisfactory, unsatisfactory, poor, there is range of gradings are there. So if you want physical examination, again there is a range of grading. So whichever you have not observed, you say not observed in this mini clinical evaluation exercise. This episode I have not observed physical examination, I have only observed the history taking. You mark alone the history taking. And what does it say at the end of the form? What is the last line? Comments. So comments means comments from the examiner. That is the feedback that you're giving to the student then and there, saying this point you left, this point you have said it, that is why I've given you the score. So just like Dr. Ramya said, the student needs to know why he failed that station, or the student needs to know why he has got full marks. You say that you did all these steps correctly, you asked all the questions correctly, therefore I have given you satisfactory or excellent. So you are justified in giving the marks, student is happy. At the end of it, what does it say, the last line? The student also has to sign that he has accepted your feedback and that he agrees to the score that you have given, and the examiner also signs. So it is kind of a mutual agreement, and this can be done anywhere. It is not only in the summative exam, it's more like a formative. You can keep on doing it throughout the course of study, and it need not be by the same examiner. That is where you eliminate bias, right? Today I am the DAS, duty assistant surgeon. I have examined this first year PG. When he examined an obstructed hernia in the OPD, he is asked the history. Tomorrow in the OP, he may be asked to present a thyroid case. The unit chief or the professor may be assessing only the physical examination of the thyroid and giving the marks. So you see, lot of competencies are covered by different examiners under different situation, but the student remains the same. So he or she will feel very good that without any bias, people have examined me and given. They honestly will take the feedback and try to improve. And you also know who are the slow learners. You can help them practice these clinical skills much better. So this, if you think it is a little difficult or at a higher level for an undergraduate student, all the PG teachers, PG departments here, you can apply it for the first year PG. You can even apply it for your interns if you want to test some clinical skills, because interns are going to be soon let loose on the community, right? You need to find out whether they are okay to treat a patient. So you can use it for your interns if some of the interns are willing to undergo this, because they are not an honor bound for any exam, right? It's difficult to convince them to come for any examination, but your final year MBBS, first year PGs, second year PGs, best to use this. Just try it out in your own department, you will find how useful it is, okay? So, any doubts in this? We'll have a small demo now. I will, Deepti, can you just call Dr. Swarup? The time limit is, this will take, it should not take more than 15 to 20 minutes. Again, I tell you, there is yesterday I was talking to you about feedback. Okay, any exercise, it should be 1/3 of the time should be spent on feedback. If it's 20 minutes or 25 minutes, you spend 15 minutes in examining and marking, 5 minutes for debriefing, ask him what went wrong and all that stuff. At least 5 minutes to 7 minutes you should give the feedback. So the time limit will be 15 to 20 minutes, not more than that. For OSCE, what Dr. Ramya said, 5 to 10 minutes. There also one point I wanted to add was, you'll be in the OSCE station, you'll be doing different skills. One is interpreting an X-ray. That the person may finish in 2 minutes flat. Or interpret the lab report of thyroid function test. It just takes 1 minute to tell whether it's hypothyroidism or hyperthyroidism. So they'll be done with it. But the same student, next station, he may be asked to demonstrate skin suturing on a suture pad. That is going to take at least 7 to 10 minutes. So whichever skill has got the longest time to take, every station should be timed the same. Because after 1 minute, he'll jump into the next guy is not yet over. You understood? OSCE stations, when you plan the time, whichever skill of the 10 OSCE station takes the longest time. Suppose it is 10 minutes, every OSCE station should be for 10 minutes. The instruction is, once you finish the task, please sit quietly inside the room till the bell rings, then you move to the next room or the next station. So that is how the time is very important, so you can use an effective use of time. So here it is 15 to 20 minutes. For a long case, I said maybe 20 to 30 minutes maximum. That also, if you finish by 20-25 minutes, you will be able to cover more. Okay, any other doubts on this? Swarup, you can come please. Rendu chair podu oru mic extra kodu. Okay, so we are going to request our surgery PG, Dr. Swarup. He is going to, I am going to assess his, what are the skills there? Okay, I am going to assess his counseling skills in this encounter with a patient. Okay, so this, I am busy in the theatre. I have deputed my second year PG to break a bad news to the patient. Okay, so that is what you are going to observe, and each of you are going to mark Swarup only on the counseling skill number 5, and grade him, and you have to tell me why you graded him. That way each group I will ask you. Okay, so I should thank Dr. Swarup, and Dr. Gayatri, who is one of the participants, has volunteered to be the patient.
Good morning, ma'am.
Good morning, doctor.
Myself, Dr. Swarup, junior resident. On behalf of my chief, today I am attending you, ma'am. My chief was stuck in surgery today, ma'am.
Yes, sir. Yes, sir. Proceed.
Ma'am, the report has been taken 1 week back. The samples has been arrived, ma'am.
What reports, doctor? Is everything normal?
Ma'am, be calm. The reports has been just arrived, ma'am. I'll let you know what has been happening.
Okay, sir.
Do you want to call someone else, ma'am, from your family members?
Yes, sir. I want to call my relatives near and my parents to come along with me.
Okay. The sample which has been taken 1 week back, the swelling on the neck, suggestive of some.
Is it cancer, doctor?
No, ma'am. Just listen. Some kind of abnormalities suggestive of some kind of malignancy, ma'am.
Is it treatable? Whether is it treatable or?
Yeah, ma'am. There is no surgery. There is no surgical intervention as of now, ma'am. This is treatable with medications only.
Okay.
And there is and also the disease which has been diagnosed in you is been treatable with medications only.
Okay, doctor. The same informed to my family members also. That's all.
Madam.
Okay.
Ma'am, it's treatable, ma'am. The stage which has been diagnosed is treatable, and it's not no surgical intervention is needed as of now, ma'am. It's treatable under the medication and radiotherapy.
Is it really treatable, doctor? Like whether I have to?
Yeah, ma'am.
take
It's
some
no need to
other
worry. It's
measures,
treatable
like-
only. It's the stage which has been diagnosed is very treatable, and it's in early stage only.
Okay, doctor. Are there any measures I should take or?
Yeah, ma'am. There's some precautions have to be taken before the surgery has been starting. Before the medical intervention has been starting.
Okay, doctor. I hope that doctors give the correct, sufficient treatment so that I can perform well
Yeah,
further.
ma'am. We are all there here for help you, ma'am.
Thank you, doctor. Thank you for your support.
Thanks, Bharti. Thanks a lot. Big round of applause, please, for both Dr. Gayatri and Dr. Swaroop. Okay, now just take a minute in your mind and grade, not Dr. Gayatri, only Dr. Swaroop, okay? Grade the PG. Thanks, Swaroop. Bye. Okay? No, you may not agree with your friend. If you have all come to an agreement, it's fine, but if you think you are different, then you do a different grading. It's okay, everybody. I'll just ask 1 or 2 in each group. Take a minute and grade, and I want you to fill the form the way it has to be filled. Go back to the slide. இது போரும். Done na? Go green is first. Very good. Then orange, yellow. Amy, ready? Red and blue. Yellow is ready. Orange is ready. Okay, we'll start with go green. First time I'm calling you. Okay. Okay, who wants? All of you have scored the same or differently? Almost same. So who wants to tell what score you are given? Why you are given this score?
We have given satisfactory, ma'am, around 5.
Okay. So why you didn't give superior? Okay, they have given satisfactory. How many of you have given satisfactory?
I thought he didn't introduce properly, and he didn't explain the condition of the patient properly, ma'am. He has told some malignancies, he didn't mention what malignancies, where. Yeah. I got that. No, he asked cancer. So it's,
What did he do good? What did I tell you yesterday? Feedback should start with or your comments should start with positive comments, negative comments.
he was patient and he was listening to patient properly, ma'am. I mean, he was in a patient. He listened properly. He was not angry. He told her. No, because she was excited, ma'am. She was in tense state. I thought.
More so because of the diagnosis, the doctor more so because he wants to tell the diagnosis fully out.
She was interrupting. I thought she was.
Okay, so I think this group is kind of justified saying why satisfactory and why not superior, but definitely not unsatisfactory. Okay. Monica, quickly.
He did not stage the cancer, he is staying early stage, and no surgical intervention, he's worried about surgical intervention. He did not see the modalities of chemotherapy. She asked whether this is the kind of Yeah, that's what he said. There was a query that the patient asked, is the same protocol followed outside? That was not answered. The queries of the patients are not answered. He couldn't, he said it in about be calm and did not respond properly. I think he should empathize and give the treatment modality options, and precaution wise also I think there was no answer. So I rated unsatisfactory.
Okay, justified. Okay, so I am not trying to justify the student, but very rightly she said, that is why that spikes protocol, last is summary and strategy of whatever management or whatever the condition. What the student should have done is, he's after all a second year PG. And this case actually was supposed to be a lymphoma. He may not know all the chemotherapy protocols. What he should have said is, my chief will come and explain to you again. We will refer to your medical oncologist, a specialist who is good at this cancer injections and treatment. They will explain everything. But he kept saying all treatment is available. I think why he said as a surgeon is, many patients will ask, is there surgery involved? Are you going to operate on my neck? But before the question asked by the patient, he already said, no surgery, don't worry, it is only by medical treatment. He was trying to reassure. I got your point. Who marked him unsatisfactory? Anybody? Add one more point. Why not superior? Why not superior? Why satisfactory?
Satisfactory. Because he did not confirm is the patient relative or not. The patient relative, he did not confirm with the relative that which patient, the patient name, details, confirmation.
First of all, like somebody said, he didn't introduce himself, and you have to ask your name and if possible your OP number or IP number, whatever it is, because patient identity, you can't tell the wrong patient that you have got lymphoma, right? So that is the key step that he didn't do. Okay, very right. Yes.
Quickly, if he uses that when he discusses with the patient the condition and all, the patient also will be satisfied that the doctor knows about my condition.
Yes. Okay. So, but he was very nicely said, my chief is stuck in the theatre, she's asked me to come and explain. Whatever little he knows, he's explained. But he should have reassured saying, some senior doctor will come and talk to you again. We'll give you an appointment, or you wait, he will come, and then the medical oncology specialist also will see. So all these things. So the take home message is, we are all very good at assessing. Are we teaching like this? The question is, are we teaching like this even to PGs? They observe how we behave with the patients, same way they will behave with the patients themselves. If I don't introduce myself, because I'm sitting in a big chair, they assume that I am the senior most doctor because I have so much of grey hair. But that's not the way, no. I should introduce myself and say that I am so and so, you have come to me for consultation and I will explain to you to the best of my knowledge. So please remember to teach your students how to interact with patients, and then once you teach such things only, we should assess it. But I am very happy with all your judgment. Even I would have given maybe a little unsatisfactory towards it. You have given 5, no? I would have given maybe 4. Okay, and commonly this is the spikes protocol I showed you at the background, which is used for breaking bad news. All those 6 steps should be followed, and we should teach them first the spikes protocol before assessing them. Okay, thank you very much for your very active participation. We'll go to the slide changer. One more technique which we don't have time to demonstrate, okay. So 10 to 20 minutes, I already say that, okay. What did I do? You didn't criticize me. I didn't give feedback to the student. I said, bye Swaroop, you carry on. I have to give instant feedback. I should have taken your comments, everything, made him wait here, tell him. So these are the feedback from all the teachers. So please try to correct all these steps. I'm sure I will call him on the phone and tell him instant feedback. You have to tell it immediately. Though this was a role play, but this is what he is doing day in and day out in the OP. So he should know the feedback also, and you should also realize he is a student after all, and he is faced by about 40 odd faculty. So he is a little stressed even though he is a postgraduate, but feedback will be given, and that's what I didn't do in front of you. So my apologies for that. Okay, this. So next one we can use is DOPS. DOPS is directly observed or observation of procedural skills. So this is not on mannequins. This is not on a skills lab. This is on actual patients. So when you look at the Miller's pyramid, the last part, what does it stand for? Does or performs. That is, you can test maybe interns and PGs using DOPS, not for undergraduate students. But still you should be aware of it. It can be carried out at the workplace. Assessor observes the trainee and the structured checklist which I provided to you for a surgical school checklist I have given again because I am a surgeon. Okay, that is a DOPS checklist for any procedure, surgical procedure that you do. Depends on what procedure. It should be a short procedure. I can't ask him to do a thyroidectomy and then do DOPS on that. Okay, it has to be maybe suturing of the skin, or excision of a lipoma, or giving local anesthesia for a lipoma. Small things you can do. 10 to 20 minutes should be the procedure. Feedback for 5 minutes. Feedback should be given immediately after the procedure is done. And this has to be always along with you. That is, whatever it may be, a pleural tap, it may be ascitic tap, it may be doing an FNAC on a patient. When you're teaching the PGs or making the PGs do, the faculty should be standing next. In case there is some problem which has occurred, they should be ready to take over. So when the person does a surgery and I am assessing, I should be ready to scrub in 1 minute time or 2 minutes time and come and join the case in case he goofs up something. Okay, the patient safety is very primary in this purpose. For the same thing, anesthesia, if you're making your PG do spinal anesthesia, you should be ready to don on a glove and immediately do it when he's not able to get the spinal correctly, or he does something else, or there is bleeding from there. You should be able to take over immediately. So that is why the importance of DOPS. So interns also, if you want them to start IV line, draw blood, take an ABG, you should be ready to help them, and at the same time you can assess them. So DOPS checklist, you please keep it in your file for future use. It's all readily available on the net. And again, DOPS, same thing, more than one examiner at different situations. It can be in ER, ward, labor room, theatre, OP, wherever you have time you can. But you should tell them that you are going to assess them, and the student should volunteer saying, okay, I am ready to be assessed for this procedure. And sometimes they say they can choose the assessor. But if they choose the same assessor, because like very sweet people, all of you gave satisfactory, we have to keep shifting the assessor because you should have a unbiased judgment of the student's performance. So at least they say in the PG training, the first year PG training, at least 3 to 4 DOPS on basic procedures. Second year, the level of procedure increases. Third year. So all that goes into there. The next part, what is called as portfolios. So all the mini-CEX and DOPS sheets, that is evaluation sheets, one copy is given to the Okay, so you also put in the evidence for whatever your achievements in the form of copies of certificates or mark sheets or whatever that becomes a portfolio. So all of you can have your own e-portfolio, and it's very exciting to keep adding something every week or every month to your e-portfolio. The third thing that we can do is called multi-source assessment, which is 360-degree assessment by peers. Peers means their own colleagues or by other members of the clinical team. It could be assessment by patients also. So this is what, I don't know how many institutes in India do it, but many institutes abroad do it. So the nurse can assess you, the housekeeping can assess you as a doctor in the ward, the theatre nurse, everybody, the patient's attender. So that will give a very good idea to because I always remember in the previous institute I worked, there was a cardiology PG. He was so toxic in the sense he was so rude. He was not only rude to patients, to other PGs, to other faculty, to his own HOD. And we were all so upset because of his marks in the university exam, he got the gold medal. You think that's a person any medal should be given? Should be shown the door actually. So that kind of assessment, if you do a multi-source assessment, he may be very knowledgeable, but he may be a poor communicator, poor in manners. You don't want such kind of doctors to be given gold medal, right? So that is the thing that makes me feel very strongly that this multi-source feedback is very effective in assessing a doctor or assessing a student. It can be done. There will be elements of bias, of course. If I fought with a staff nurse, of course she's going to give 0 for my assessment, right? That also tells you what problems you encountered. So it is kind of weighed by the other people's comments, and you can put some kind of a judgment on the student. Okay, I'll stop here and I will give it back to Dr. Ramya for your activity. Okay? Thank you. If you have any doubts, anything, you can talk to me during lunchtime. Okay. Amy? DOPS only, I didn't go into detail. That is for a surgical procedure checklist, but this is at a higher level for a postgraduate maybe. So you have a global... Sorry? For the postgraduates. You're supposed to do it. I've sensitized all your HODs that you should keep a mini-CEX evaluation, because NMC first batch exam, definitely they're going to ask you, how are you doing formative assessment in your department? We had a meeting with the HODs. We have sensitized them. I hope it percolates to all of you. You can do it. Mini-CEX is very much doable. DOPS takes some time, but mini-CEX is very much doable. You can do it for PGs easily. For interns also, if you wish, you can do it. So it's be good if you use it. Thanks, Dharani, for that question. Yeah.
Thank you, ma'am. Okay. Now we will go to an activity. You must have received the sample checklist, which I had already displayed. So now each group is assigned a type of OSCE station. We have given a competency. So station 1 is for group 1 or group yellow. So that is, it's a competency taken from physiology, record blood pressure and pulse at rest. So each of you have to design an OSPI station. One of you must be a student, one of you must be an examiner. You can have 2 observers, and the necessary equipment you will have to procure. It's all here. We'll give it to you. And you have to make a checklist, and you have to do a demo at the end of 20 minutes. So group 2 or blue. Group blue, we have taken a competency from general surgery. So perform basic surgical skill such as suturing in a simulated environment. We will give you a suture pad and the necessary material. You have to design a station. That is just a sample checklist. Sample checklist. Station 3, that is group orange. We have taken an ADCOM module for you. You're 4, okay. You're 3, or group red. So for group red, you have administer informed consent to a patient who is about to undergo a surgery. Station 4, orange group, educate and counsel the mother for immunization of her newborn baby. And the green group, we have taken a competency from anesthesia Demonstrate the steps of BLS in a simulated environment. Any doubts? So what all you have to do? Set up a station, make a checklist, and do a demo. Yeah. Okay, you have to make a checklist with instructions and marks. All these four. That hard copy we have already given the checklist. Instructions.
At least they will know that they have to write the instructions.
Write the prescription and instruct the mother. Same thing. Same PPT. The 27 model station. You just put it in slideshow. The instruction is there. The question is instruction, and then this is the instruction. What exactly you have to do? This is the instruction, and they have to write similar instructions, and they have to create a checklist.
So you have to write instructions. Each of you is required to create a set of instructions, make a checklist, and allot marks. So we'll give you 15 minutes. Okay. One of them should be a student. One of them will be examiner. So they have to create the steps. And then one person student and 2 observers. Once you finalize the instructions and checklist, please write it down on the flip charts. You can write it down on the flipboards, the checklist and the marking. Please write it on the flip charts and then you can present it. Google. సరికాదు ఓకే ఇదే చెక్ లిస్ట్ ఇదే కదా ఇదే చెక్ లిస్ట్ ఓకేనా దిస్ టాస్క్ ఇక్కడ దానికి మార్క్స్ ఇక్కడ ఇప్పుడు వన్ ఆఫ్ యూ విల్ బి ది ఎగ్జాంపుల్ వన్ ఆఫ్ యూ విల్ బి ది స్టూడెంట్ ఇంకా మిగిలిన వాళ్ళు అబ్జర్వర్స్ వాళ్ళు చేస్తారు ఎగ్జాంపుల్ విల్ గివ్ మార్క్స్ దాన్ని డెమో చేస్తారు ఫైనలీ విల్ టెల్ ద స్కోర్ అదర్ ప్రొసీజర్ సో ఫీడ్బ్యాక్ కూడా అప్పుడే ఇవ్వాలి కదా దిస్ థింగ్ వన్స్ యూ ఫినిష్ ఇలా ఉంటుంది ఇక్కడ రాసి పెన్స్ కావాలా సార్ ఇస్తాను ఇక్కడే ఉన్నాయి ఇక్కడ టేబుల్ పెన్ దిస్ వన్ ఇదేదమ్మా Can we make less noise, please? Please start writing. Three minutes remaining. Please complete your checklist. I request all the groups to please hurry up. You have to assign scores for each of the tasks. Another 2 minutes, last 2 minutes. So decide among yourselves who will be the student, who will be the examiner, and who will be the observers. Please assign roles to yourselves among the group members. Okay, shall we start the demo? So, are we good to start? So, shall we start with the demo with the group blue? Group blue, are we good to go? Who is the student? Examiner? So you all are observers. You will do the marking, sir. Okay, all of you please be seated. Only one person can write on the flip chart. Others, please be seated. We can start the demo from first group. Okay, group red and green group, please be seated. BLS mannequin is here. Okay, we will ask the group blue to present now. You can start your presentation, group blue. So I think you can all come to one side. The student and the examiner can be seated. You can all come to one side. Come this side. Okay, now we are having the demo of group blue. They are ready with their OSCE station. The question is, performing basic surgical skill such as suturing in a simulated environment. So all of you please pay attention because then you will have to give your comments. So 5 minutes. The steps. Come and start. Yes, so they will perform suturing in a simulated environment.
Good morning, sir. My name is Dr. Ashish. I'll be a doctor for today and I'll be attending your emergency. So basically, you just have a small cut on your left leg. Nothing to worry. I'll just suture it and everything will be fine. So will you give me the consent to suture your wound? It's just a small wound.
Please observe the steps.
No need to wear gloves. Okay, he's worn the gloves.
I'll just give you a small local anesthetic, sir, so that you don't feel any pain.
He's going to talk, hold the mic.
Okay, I finished giving you the anesthetic. Can you feel this, sir?
No.
Okay, I can proceed then.
Very good anesthetist.
Silence, please.
So, sir, I'm done with the procedure. You have, I have put 2 sutures on your skin. So I'll give you some medication from now, an antibiotic for the next 5 days. And I would suggest not to pour any water over the wound. You can come back to us after 2 days so that we can do a wound dressing under observation. Thank you.
So this is our checklist. We have awarded marks for greeting the patient and introducing the doctor. So we have given half mark for that. We have given half mark for explaining the condition of the patient. Next, the procedure should be explained and its complications, for which we have given 1 mark. For taking written consent, half mark has been awarded. For creating a sterile environment before the procedure, we have given 1 mark. For administering the local anesthetic, we have given 1 mark. And suturing the wound, we have given 2 marks. And dressing the wound, half mark. reassuring the patient after the procedure, post-procedure reassurance, we have given 1 mark. And finally, 2 marks for post-procedure treatment precautions to be taken and the next follow-up visit. We have given 2 marks and total of 10 marks have been awarded. For this, we have given 9 marks for this. The reassurance has missed post-procedure reassurance.
Okay, any comments on the checklist alone? Any comments on the checklist before we move to the next group? So what was the objective? What was the competency is?
Suturing the laceration.
So any comments you want to give quickly? That is a theory question. Need not be tested in a skill station. You should keep up one line, choosing the appropriate
Suture
for
material.
the given task. So actually speaking, we should have given epilon or silk, but we gave only white thread to it. If he are kept and he chooses white thread, then he doesn't get marks for that. So you put it into the action. Your question, you translate it into an action and give half mark or 1 mark for it. Yeah, that's a good point. Anything else? Ravi, quickly. Huh?
Consent in patient online.
That's assumed. Yes, he did it in less than 10 minutes because he's an orthopedic surgeon. Yeah. 10 minutes is more than enough because he wants them to demonstrate one suture that is enough, not the entire line of incision on the suture pad. So one suture is more than enough. 10 minutes is enough for demonstration. Okay, if that is so, that's not part of the thing. That everything consent has been taken. Actually, you can make this differently. You can say consent taken, local anesthesia given, parts painted and draped. Only break down the steps of suturing. Does he hold the needle holder correctly? Does he lift the needle out of the suture out of the thing without touching the needle? Does he put it at right angles to the first half a centimeter away from the 1 centimeter away from the skin edge? You can make OSPI checklist only for the skill of suturing. But this the whole activity is given. So we assume other things are being checked. You can add it if you want, but it will be lengthy checklist, more marks. That's fine. Thank you. Big round of applause for your group. Very well done. It was helped by the fact there are 2 surgeons in the group, but still very well done. Thank you. We'll go to the next group who's ready to do it. Yellow group.
So I'm Dr. Pallavi. I'm here. My competency is to record a blood pressure and pulse at rest. Dr. Sindhuja is the student here. Assessor is Dr. Noble sir and Anil sir. 2 assessors.
Myself is the patient and she is the student.
I am the student. Good noon, ma'am. I am myself Dr. Pallavi here. I am assigned to check your blood pressure and pulse rate. Can I please do it? So it will create a little bit pressure, but it don't harm you, ma'am.
Other groups you can observe.
So, thank you for your cooperation, ma'am. And her pulse rate is 74 beats per minute. Your pulse rate is 74 beats per minute, and your blood pressure is absolutely normal. It is almost 124. Sorry, it's 124 by 74 millimeters of mercury. Thank you.
You tell the scores. You were the assessor, so you can judge them.
Yeah, I am giving 5 out of 5, madam. So, yeah. Yeah, for a greeting half mark. And yeah, so patient positioning and preparation half mark, madam. So BP measurement. So ideally it should be checked on both sides, but here due to lack of time, we planned for on one side. So for accurate recording, 1 mark given. So yeah. Accurate recording, 1 mark. So pulse rate measurement, 1 mark. So documentation and communication, 1 mark, ma'am.
So any comments? They have given 5 out of 5. We all agree with that? No? If no, why? Sorry? No, the competency is very straightforward. Just measure BP in resting state. Ideally, yes, 3 readings should be taken. Yeah, okay. Fine. See, according to what checklist they have made, the scoring is correct. You agree? Okay. All of you agree? Yes. Okay. So, big round of applause for Team Blue. Thank you very much. So I want all of you to preserve these checklists. You can post these in the group because these are all actual OSPI stations which we can use in our exams. Okay, next we'll go to group orange.
Good morning, everyone. Topic for ask is counsel the mother for immunization of her newborn baby. Sairam sir is observer. Dr. Mona ma'am is mother. Good morning, ma'am.
Namaste.
Myself, Dr. Karthik.
Namaste.
Are you Mona, ma'am?
Yeah.
Just to confirm, are you aware of immunization, ma'am?
Yes, I am.
Earlier?
Yes, I am.
Immunization is very essential to prevent all the fatal diseases. So you are well aware. So there are minimal side effects, not for everyone, expected 1 to 3%.
Okay, what are the side effects that we can expect?
Mostly fever. We'll give a prescription for the side effects, and we'll give a check list of the things for you to observe.
Okay, doctor.
There are some conditions. If any rash, if it is serious, you should come to hospital immediately.
Okay, doctor.
So as she's okay, so you are okay with the vaccination?
Yes, doctor.
Thank you.
I would score 3, ma'am, because because the explanation is not proper. The route of administration, the site of administration, so those things were not discussed. But one thing the patient already knows, so that's why he has taken it as yes. But ideally, we should explain the site of administration, the route of administration, and the schedule, madam. And we should counsel the patient when he should come for next follow-up. So I'll score 3.
They have scored him 3 out of 5 because he did not follow 2 important steps. Okay. So now we have given the student the feedback that he has got 3 out of 5. He knows he has not performed this. Can we just quickly retrospect why he did not say?
Because the mother already knows about the...
So that's an assumption. Mother might know, might not know, but then it's our duty to tell it to them. So maybe he was anxious? Yes, anxious of this setup maybe. Maybe if it was an actual hospital in a one-to-one patient setting, they would have done it. So quickly we can give a feedback. Yes? Any comments from other groups? Because they've got 3 out of 5, all are happy. Yes. Any other comments? So according to their checklist, introduction and greeting was 1 mark. Explaining the importance of immunization was very well done. They had given 2 marks. The route and the immunization schedule was not told. Then the post-vaccination care also was not explained. So he has got, this group has allotted 3 marks out of 5 by the assessor. Clear? Thank you very much. Big round of applause. Ma'am has...
Or it's a patient? No, it's an OSCE station, right? So it was a simulated patient or a real patient? Because if it is a simulated patient, we have to give some more information to the simulated patient saying that she doesn't know about the immunization schedule, so that the student will tell the immunization schedule. So we have to prepare the stimulated patient also. That has to be done.
Thank you, ma'am. Thank you for that valuable input. Thank you. Yes. So group red, ready?
Ma'am, we got competencies about informed consent for a patient who administer informed consent to a patient undergoing surgery. So here the materials which we need were informed consent form, 1 table, 2 chairs, pen and patient. The instructions which are given to the student, that is Dr. Gayatri ma'am. So 35-year-old patient diagnosed with multinodular goiter is posted for total thyroidectomy. Take the informed consent from the patient to perform the surgery. So time given was 10 minutes and marks will be 10. Patient will be Ramya ma'am.
Good morning, Ramya Garu.
Good morning, ma'am.
I am Dr. Gayatri, Assistant Professor in General Surgery. So I'm your treating doctor. May I know what language we will be convenient to explain the further procedure?
Tamil, ma'am. Ma'am, patient's own understandable language. No, ma'am, to just to highlight that point, ma'am.
Okay. I'll be continuing with the English, ma'am. Is English convenient for you, ma'am?
Yes, okay.
Are you Ramya Garu, 35 years from Chittoor? I hope, yeah, yes. So after your examination and investigations, like the condition has come as multinodular goiter. So the plan of management regarding your reports is total thyroidectomy. So the procedure will be done under general anesthesia after pre-anesthetic evaluation. So the complications can be there can be injury to the adjacent vessels which can lead into loss of voice, or there can be respiratory distress or something which has chances of treating in ICU setup. And there are other treating methods like emergency procedures like tracheostomy and all. So there are other modalities of treatment also other than surgery, which can be radioactive iodine therapy or ablation methods. So have you understood, ma'am? Is there any doubt regarding your surgery?
Will I be having pain during the surgery?
Mostly it will not be painful, ma'am, because it will be conducted under general anesthesia.
Will I be aware of the surgery, ma'am? During surgery, I'll be knowing what has been done.
No, ma'am. It will not be that apprehensive. You can be very cool during the surgery and post surgery also.
And you told that there are chances of injury to my nerve. Then suppose if some mishap happens, what are all the complications that I might encounter?
So you can have some sort of stridor or restlessness or respiratory distress post surgery, but it can be treated by alternative methods like immediate tracheostomy and all, which will be monitored and treated accordingly according to your complications, ma'am.
Will I lose my voice during the surgery, ma'am?
No, ma'am. 99% it will not be. If there is something like that, there are alternative methods which are better treatment.
What will be done, suppose if I can't breathe after the surgery, as you told? What are all the things you will be doing, ma'am?
That's what, ma'am. Immediate tracheostomy is the one of the alternative methods. After that, we'll go for redo surgery and you'll be fine. So after surgery also you'll be fine. Post treatment, post surgery also we'll be treating you with medications which are all needed, so that you can live a normal life as prior to your surgery.
Okay.
Please sign the consent form if you have clarified with your doubts, ma'am. I hope everything goes well, ma'am. Thank you so much for your support.
Yeah, madam. The checklist we made for 10 marks, 10 minutes. First of all, greeting the patient, off mark, and introduction, off mark, and confirming the patient details, off mark, and explain the condition in the patient own language, 1 mark, and explain the plan of management, 2 marks, and explaining the complications including the procedure and the prognosis, 2 marks, and the alternate modes of treatment, 1 mark, and regarding any queries, doubts, clarification, off mark, and getting the consent form signed, off mark, and reassurance, off mark, and the thanking the patient, off mark. Okay. I think all will give 10 marks, madam.
Yes. I think it was very well done. It was very well done. Like ma'am said, the simulated patient also was very well trained. Big round of applause. Thank you very much. Thank you. We'll go to the last group. Who's your presenter? Who's the student? Who's the observer? Quickly. Quickly, quickly.
Good morning, ma'am. I was asked to demonstrate CPR and write the steps of it. I need another person to help with the ambu bag, ma'am. I've checked for no pulse, no heart rate, pupils dilated, start CPR, all clear. 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, So the cycles come. Time is less, should I? And then I need a nurse to administer IV drugs, atropine and adrenaline, ma'am. And then next, I can see there is a flat line. I want to shock, ma'am. All clear. Thank you. I put my hands in the position and I. Thank you, ma'am. I myself, ma'am. Priyanka, ma'am.
So the instructions given to the student were to, first thing is, know the scenario, assess the vitals of the patient, write down the steps of BLS, demonstrate the steps of BLS, and then wait for 10 minutes for the response. The checklist is scenario. So understanding the scenario and activating the emergency services, 1 point. Assessing the response of the patient, airway, breathing and circulation, 1 point. Performing chest compressions and rescue breaths together, 1 point. And then medication, administering medication, half mark. Continuing CPR, half mark. And final, counseling the attender about the position and further shifting of the patient further care, 1 mark. Total 5 marks. 4 marks.
Right, thank you so much. I give big round of applause. One more point I wanted to add is, this OSCE station is the most difficult to design. You will have to subdivide it into more steps because this OSCE station is an all or none phenomenon. Even if one step goes wrong, they fail the OSCE, they have to go for remedial because it's a life-saving one. So there is no, if I get 4 marks out of 5, I pass. If she's got 4 out of 5, she's failed the station, she has to go for remedial. And most important step, she didn't call for help. And IV drug administration is not part of BLS. BLS is only CPR, at the most AED if it's available. So no need to call for the nurse to give, that is ACLS. So BLS is what we teach undergraduates. It is only the steps of performance, whether the number of compressions, depth of compression, did she wait for recoil, all that should come into your steps. Because this is a all or none phenomenon, this checklist should be more in detail, but overall you have covered everything, that's very good. And 4 out of 5 means the remedial station has to be done. Students should be assessed after being taught again and practice again. That is the only difference between all other stations. I think they did an excellent job. Thank you so much.
For assessing vitals, it is half mark. Editing coded, half mark, which I failed, so half mark here. Theory and procedure steps writing is 1 mark. Demonstration, patient position and compression ventilation ratios, half mark. Effective compressions depth is half mark. Ambu mask resealing and checking if there is a leak is half mark. Reassessing ACLS I added, ma'am. Placement of AED, okay.
BLS is only BLS.
Placement of AED and delivery of shock is half mark. Number of cycles performed is half mark. The counseling is another half mark where I lost. So it is. No, ma'am, not like that. He's rescued and I'm shifting the case to ICU. This is an emergency. Okay.
Performance of BLS means only the steps, starting with scene safety. Okay, so this is a very important thing you should know to structure it, but very well done, demonstrated, done.
So the 5 marks can make it a 10 mark checklist also. So at your liberty. Thank you very much.
Thank you, madam. Yeah, I think you're all more enthusiastic with smiling faces for one more session before closing for the lunch. Are you all active or you need to stretch a while? Yeah, active, right, good. So, apart from these, this is a little interesting topic. Probably you will boost yourselves before going, have one chocolate, and then let's start with the topic. I want to keep one African proverb here, just go through it. So if you want to go fast, go alone. And if you want to go far, automatically what we need? We need to talk, chat with others, and then move far. So you'll not know the time, and then you will be learning something when we are going with others. So if you want to go far, go with others. So why I am asking this is, what do you mean by this? Probably you might have seen what topic I am going to talk, and you might assemble it and then think of what exactly is this. What do you mean by this? What is happening here? Yeah, there is certain connections, right? You are seeing some connections which you need to have certain networking. Networking strategies. I think Anil should come out with good networking strategies. Where and all it can be used.
Communications.
Communication, good. Yeah, generally we see them like we can see here, whatever the networking that is being done right from the system, you have various networks which go into clouding system. So we have clouds, right, where information is being, so whatever the mails that we are having, the photos, the Google photos that we take up, all these is being in the cloud. Yeah. So this is what actually a networking system where it happens into where we are seeing. Is networking required in a medical education and healthcare? Is it required? Yes, and how? Because of the networking, this is happening. So what do you mean this BCME is happening here? Good. Of course, we'll come into that. Any other? Medical education, what I am going to tell is, while we are not only this, even for teaching undergraduates or postgraduates, so is networking required there? It helps out in integrated teaching and integrated learning for the students. Good. Any other? For healthcare, definitely we are now doing healthcare. So we need to know where this networking is helpful in healthcare. For referring the patient. Communication with the other doctor. Latest methods of treatments can be known with the networking healthcare. Okay, good. Any other? Personalized? Personalized medicine, okay. Yeah, a networking will help taking bonds with various institutes, right? So various institutes can help. I think a word can be used there which you can call as telemedicine, right? Telemedicine can be used there, actually where institute levels of thing can happen. So networking in medical education and also in healthcare, where you see one part is nothing but telemedicine that can be done, and even it helps in this networking, also helps in using certain AI technologies by robotics in treatment, robotics in patient care, and this actually comes with my topic which talks about the educational networking. Okay, let's move to the topic. My objectives are, at the end of the session, you all will be able to understand or know about the avenues of growth in medical education. So what are the avenues, various avenues to growth in medical education, and educational networking in medical education, advantages and disadvantages of the use of networking, create networks for you and your institution, and also finally create network among medical education units. So what we are here teaching you or facilitating you is nothing but as a medical education unit here, giving a development kind of program for the faculty. So let's now understand about what are all the avenues of growth in medical education. One, so what happens actually, so there is a board called as National NAT, I think it is NAT, right, which conducts the exam, NEET exam. So this NEET exam helps you out to cream the layer of the students who are eligible to go. So you get the cream layer of the students to enter into the medicine or otherwise the post-graduation. And also there is the curriculum that has been given now, the CBME curriculum, which also helps you to have a good innovation of curriculum. The various teaching learning methods that we are learning about, not only the same, various other teaching learning methods that we are knowing. And community-oriented medical education like what you call family adaptation programs and pandemic modules and interprofessionalism, and also CMEs and workshops that are being conducted, which also help you. These are all various avenues where it helps out in what you call medical education, which helps out to have a growth in the medical education. Student support services, a newer pattern of assessments like OSPI, OSCE, DOPS, and quality assurance in medical education. Even this is now you need to have a good quality assurance, where I think, if you all know, there is a board called as MARB. Do you all know that there is a board called as MARB? Medical Assessment and Rating Board by NMC. So it assesses the giving rankings to the medical institutes. Faculty development and capacity building. So all this collaboration between medical schools, application of information, communication and technology in medical education, educational administration and leadership, and finally an accreditation like where the MAP looks into NIRF, National Institute of Ranking, and also NAC accreditation. So these kind of all things help out in the growth in the medical education. Sorry. So what do you mean by SWOT analysis? Strengths, weaknesses. So everyone as an individual also you need to know what exactly is a SWOT analysis. So ourselves also has to know, which helps out to understand. So what are the various strengths? SWOT refers to strengths, weaknesses, opportunities and threats. Okay. So the strengths, what strengths we have as an institute, what strength the institute has, or otherwise as a personal, what strengths we have. Okay. So what resources we can deploy, what are the advantages that we have, and what's working well. So what's working well about it. So these are the strengths what we have, and we should list out so that we can accommodate in such a way to perform a particular thing. And weaknesses, what abilities we are lacking, what are we starting to struggle with, and how we can overcome these. And opportunities, who might most value our strength. So if at all you do some work and give it or do it, so who are the ones who are more valuable to give that work to be done? What trends of work in our favor, and what prizes? If at all we do it, what kind of ranking or whatever it is, what kind of prize we get from that about. Okay. And threats, what headwinds do we face, what might challenges, and what could go wrong. So if at all it is being done, so what happens ultimately, so what are the obstacles that we have when we are doing this, all has to be analyzed before going for anything to happen. Okay, so let's understand its growth, the educational networking for the growth. If you look into the evolution of the technology, so initially in the good old days, so the communication used to be given in the form of what you call writing on the leaves, or otherwise writing on something what you call, I think I have seen one written thing on a leaf there. So this can be used for communication. And later the evolution showed some inland letters, telegrams. Now telegrams are not there. I think telegrams has been closed. And telephone, what you call a TV, and satellite, and finally what we are seeing now is computers and internet, which had a greatest impact. So this is the evolution of technology that we are seeing, and of all which now what we have in our hand is smartphones, right? Smartphones. So the internet has reached to a near ubiquity where each and everything, so right, even with a single touch we are able to understand, or we are able to do things to be done with a smartphone. So with these things that we have in mind, so we need to understand what exactly, how a networking should happen. So the definition of this networking goes like this: the art of creating interdependent or interconnected groups, systems for the mutual benefit of all members of the particular system. So it might be whatever it might be. It might be a healthcare system, or it might be an educational system. So whatever the system it might be. So how a networking should be is, it should be creating an art of interdependent, interconnected groups, systems for the mutual benefit. So both the sides has to be benefited to have or to benefit and then get the things done. So what are the functions of the educational network? Is mainly to identify the areas of expertise. So what expertise we have, the areas of expertise has to be first identified, and then decide what is to be shared for the expansion of existing knowledge with the existing knowledge. So if 3 people are there with different knowledges, so a sharing or a networking of this thing will help out in such a way so that you can expand by sharing of existing knowledge and creating a new knowledge. With that particular thing, you can create a new knowledge. For example, if I say a medical college with an IIT college had a collaboration or networking, so the AI technologies or the engineering technologies of them help out in understanding to improve the healthcare skills that can happen here. Whom you want as members, so you need to understand who are all the members you need for it, and then finally operating modality as a team. So you need to operate the modality as a team. So these are all the things that one has to have in an educational network. So you can just have, if people are like neurons on a brain, so you have n number of neurons there, where more people and more interactions and more what you call diversities will help out to have more intelligence. So finally, to get a good impact or good output, you need to have interactions with more people. So what are the advantages and disadvantages? So before going to this, I need to have an impact or to understand, because there are certain things that are being seen as social media which help out in this networking in the mobile, right? So what are the advantages and disadvantages of social media in medical education? What are all the various media, social media? Those are coaching classes, okay? But, oh, okay, good. Any other? Artificial intelligence, good. Any other? Social media, the regular social media that we use. Insta, some blogs, right? YouTube. Anything which help out in medical education? Okay, so let us see certain advantages. So this helps out in your career growth. Okay, so this social media, not exactly, but the networking system will help out in your career growth, your professional development, your confidence levels certainly increase, and also you will have good communication, like good networking and communication will be there between different people. It also helps you out in good communication skills, and you'll get the answer that you wanted to have. The question that you have, you get an answer if you have a good rapport or with networking. Okay, it can promote the critical thinking, problem solving and global participation, and also creates teacher-student communication, a good teacher-student communication, provides medium for class announcement. So these networkings can help out to provide certain media to have an announcement to the classes, and also creates forum for peer tutoring, reviewing, and also communication. And there are certain disadvantages even to use these kind of communication kind of things. Can you have any disadvantages? Wrong information, good. Certainly, sometimes we get a wrong information. Distraction, right? Can't it be a distraction? this is one distraction, or otherwise probably with what you call after using for a long time, they might get asleep. So times change to chatting or otherwise distract themselves to move to other things. Sometimes this will overcome you and then almost wind you up so that you will be completely close that up and then move to some other thing. So privacy, and if I say there will be an inappropriate relation, if you see mainly to a teacher-student, sometimes it happens like an inappropriate relationship between teachers and students, inappropriate materials being viewed online by the students, and a text language sometimes. Generally I see sometimes in my paper when I am correcting, when they are writing, they write the text language which you use in social media. Instead of you, they write just you. That they write like that, they write the text language which is being often used, that is being used in the social media. As I said, the social networking sites like blogs, microblogs, X previously used as Twitter, collaborative projects which are being used by Wikipedia, content communities like YouTube, virtual game world, World of Warcraft, all these various networking things that are being seen, which are being utilized, and these social media can also be utilized in the educational networking. Where and all this can be used? So even we see parties are using the social network for their growth, right? Various parties are being used. National parties, politically also even this networking is being used. If you see the world leaders, I think this is 2019 stats. So even the Twitter followers are in 2019, so you can see there are things, I think I have missed it. This is latest, the 2024 Twitter, where Narendra Modi even hit the 100 million mark in X. So these are some of the things where we see and we appreciate looking into these things. There are certain even journals that are being available. Can we use it, these all social networking things or the networking things in our institute? Yeah, websites or domains that are being used. This is our domain or our website. So where we keep things and then we need to upgrade and give a networking kind of thing where things can be used like LinkedIn, Google+. These are all medical attached kind of things where these can be used. So in Insta you have Syncy radiology, especially for radiology, which they use this in Insta, Skype, Moodle is one that can be used, Docs+, Plexus, and then LinkedIn SlideShare, Live Health, especially for diagnostics, and Medscape, Curify, YouTube, and MedicalTube. All these are Google Classroom, which is one of the most easiest part where especially which can be helping out to use for mainly the medical education in the classrooms for the students. Even WhatsApp. You say WhatsApp can be used. Are we using it for our treatment purposes? Sure or not? Yes, somewhere and somehow we are using it. So if you see, WhatsApp is extraordinary growth in users, so of all the other social networking sites. Something around 87%, and I think very much less in US and UK. Yeah, this slide is an interesting thing. So there is a similarity between WhatsApp and diaper. What's it? Yeah, you have to keep checking even if there is nothing. Right? So no message though, we check very frequently the WhatsApp. So we need to have an anti-WhatsApp tablets. Yeah, okay, right. So with this, I'll just wind up with certain small things like which is very, very important. So how many know how many medical colleges are there in India presently? 700, yeah, good. Any other number? $600. Okay, so let me see, there are approximately about 706 medical colleges. So you're up to date. Of which approximately 358 are government, AIMS. Of which approximately 358 are government, AIMS institutes are about 26, JIPMER 2, and then private to deemed medical colleges, deemed universities are something around 320. Approximately every year, 1,07,000 Indian medical graduates come out. So with this number, approximately 1,07,000 Indian medical graduates come out. And if you see, creating network among medical education units. So we have medical education units in each and every college. So to understand or to educate the students or to teach the students, we need to have a platform of creating a networking system for all the educational units. So previously it was MCI which has recommended for establishing the medical education units in each medical college with the apex body, which is nothing but MCI previously, now it's called as NMC, National Medical Commission, since 1997. So NMC, the body, mainly the academic cell body from NMC has networks regarding to the nodal center. It has various nodal centers where faculty development programs will be happening from the nodal centers. And you have also regional centers where the nodal centers will look over into. And these regional centers will look into the MEU, that is the medical education unit. So each and every medical college will have a medical education unit, and medical education units will be looked into in the medical institutes, and there mainly the faculty development programs happen. Okay, so like how we are all sitting here for this 3-day workshop kind of thing. So it's none other than the faculty development program kind of thing. Okay. So, this is the distribution of government and private medical colleges, last year's one, where various states have various medical colleges, both the red says the government and the blue or green says the private medical colleges. Okay, let's look into this. NMC has an academic cell. There are 13 nodal centers all over. So if you see the networking system for all these 706 medical colleges to be taught the faculty development program, NMC academic cell has 13 nodal centers all over India, and these 13, there are 24 regional centers, of which all the 706 medical colleges will be monitored. They will be monitored with a regular pattern of what you call the faculty development programs to happen. The roles and responsibilities of the medical education units in the respective medical colleges are: one is a faculty development, which organizes seminars, workshops and conferences and CMEs, along with which help out to faculty develop their teaching skills. Curriculum development, it also nourishes or coordinates with the curriculum committee. There will be a curriculum committee in each and every institute, so which help out and coordinate in the activities of curriculum committee to develop the UG and PG curriculum in accordance with latest NMC guidelines. And even for research, conducts research in medical education, mentoring. It also helps out in mentoring, developing the faculty to mentor them to become as a good role of competent, effective teacher, administrator, researcher, and also mentor. Training, trained faculty in especially the educational science and technology and postgraduates and faculty in research methodologies and ethics. Information technology updates faculty and students in using modern information technology tools. Coordination So coordinates and facilitates NMC activities. It also helps out. This ME also helps out to coordinate and facilitate the NMC activities. And finally, it can supervise and coordinate the overall functions or the educational research developments in that particular institute. So these are all the things, mainly the roles and responsibilities of the what you call the medical education unit. I just wanted to give this slide so in order to understand. You are at level 1 now, where you are all completing today the BCME course. Probably there are some other things where you can grow if you are very much interested. So this is a voluntary kind of thing. So if you observe to have an interest to go into the medical education technology, so purely there are certain things like this is the BCME where you are understanding about the basic course in medical education. So CISP is a parallel kind of thing which is being happening in every institute. So this also is, CISP is nothing but curriculum implementation support program. So everyone has to understand about it. And a course called as an ACME is there, which is none other than the advanced course in medical education. So this is a higher level kind of education. Previously it is a 1-year course, and now it has been reduced. This NMC's course where one can understand. Now it is a 6 months course. There is another course called as FAMER, Foundation for Advancement of International Medical Education and Research. Madam, can you just give some light regarding this FAMER actually, where the centers are and then if they can understand.
Thank you. So this FAMER, we have how many centers? 1, 2, 3, 4 centers in India. Okay. So this is Foundation for Advancement of International Medical Education and Research. There is one in CMC Ludhiana. There is one in GS Seth Medical College, KEM Mumbai. There is one in PSG College of PSG Institute of Medical Sciences and Research in Coimbatore, and there is one more in Mahe, but it's not exactly FAMER. That is slightly a different course that they do. But these are the 3 centers that offers FAMER. It's a 2-year program. We have to do a 1-year research, medical educational research, and there will be 2 contact sessions at the beginning of the first year and the beginning of the second year. At the end of the first year, you should be ready with your educational project, and you have to do a poster presentation in the beginning of the next year. That is a contact session. And then the remaining is online discussions. Every month there will be one topic, and everybody has to contribute minimum 3 emails related to the topic under discussion, not saying, hi, how are you? I have got promoted to assistant professor. That is called social mail, but academic mails minimum 3 per week. So it is a little intensive, but it's spread out over 2 years, and it's very, very interesting. You learn so many things other than medical education also. What sir was telling, how to network, how to collaborate, how to be a leader, how to develop professionalism, a lot of things you can learn. And it is tough to get in, but once you are there, it is quite a doable thing that many of you should think of doing it. So thank you. Advantages is you go to the next level of teaching, assessment, education. You learn a lot about educational research, which is quite different from biomedical research. So you maybe you can become a faculty in one of these centers. They choose if you are. They have their own criteria. You can continue to be a faculty at the center where you did the FAMER. So you can go and teach and facilitate other people who have come there. So it basically makes you a little more in-depth in education, which may lead to other opportunities for you in other institutes, or you can be an advisor to somebody, some institutes. You may become the vice chancellor of another university with all your qualification. No, truly, it gets you to the next level in your career, more towards administrative as well as a teacher. Thank you.
Actually, to tell, probably what we are taught and what we have learned when we were as undergraduates or postgraduates, probably while we are practicing, we are little different now. So it all depends upon the years pass or the ages pass. So you have to acclimatize to the things that are happening at that particular period. So these are all the things that are happening. Madam, I just want to have a few words regarding what exactly the Nodal Center does, the job with the networking system with our medical colleges.
Thank you, sir. Actually, the nodal center, we have around 40 medical colleges under the nodal center. So, the BCME courses are monitored by the nodal center as well as the regional centers. There are some colleges under the regional centers, around 22 colleges are allotted. And NMC makes sure the curriculum committee, medical education unit in all these colleges are formed. The qualification for the members to be in the medical education unit and the curriculum committee members formed properly and maintained. Is it the same? Because in some colleges you know that it will be formed. By the time the next time you look into the curriculum committee, half of them won't be there in that committee. They would have gone to some other colleges. So they make sure that this is happening. And through the curriculum committee, only they are implementing the curriculum, new CBME. The new CISP S3, CISP, now they will be, most probably CISP 3 also will become mandatory, where you all have to come again and do the CISP 3. And it's based, it will become the awareness that integration and alignment, what all newer things which is coming up. So the NMC trains the nodal center and the regional center, and they wanted to pass it on to the colleges. The main thing is this one. They wanted to make sure it keeps going on and reaches the end users, the teachers in the different medical colleges. And also monitor if it is going on very well. So that is the main idea behind it.
Thank you very much, madam. So I think this almost finishes my topic. Please stay updated and stay connected to the things that are happening in our future. So closing with the last proverb. So if I could time travel into the future, my first port of call would be the point where medical technology is at the best. Because like most people in on this planet, I have this aversion of dying. So if I want to live, so I need to go cope up, run with the thing of the medical technology, how fast it is growing. Thank you. Please disperse for lunch, and it's a quick lunch or 2 o'clock? Yeah, okay, thank you. Be back at 2 o'clock.
కడప వస్తే కడపలో జాయిన్ చేద్దాం. వాళ్ళ మదర్ అక్కడే ఉంటారు, మదర్ హైదరాబాద్. సిరీస్నే మెయిన్ మేడం, అంటే 50,000 వచ్చింది ర్యాంకు, కొంచెం స్ట్రెస్ తీసుకోలేదు. మంచిగా ఫ్యామిలీ ఉండాల్సిందే. ఇక్కడ మేడం చాలా తక్కువ CMC SRMC రెండు ఎక్కువ నాకు కూడా ఎక్కడికైనా వెళ్దాం అనిపిస్తుంది కానీ నాకు కాబట్టి ఎంఎస్ ప్రిపేర్ చేస్తారు కదా
మాత్రం పర్సంటేజ్ ఇస్తారు కదా మేడం. ఎంపీఎస్ వాళ్ళు నాకు 53% మేడం, అంతకు మించి 55, 60 దాటి రావడం చాలా కష్టం. వాళ్ళు మార్క్స్ వేయడం కూడా చాలా తక్కువ వేస్తారు కదా. మంచి వర్క్ ఎక్స్పోజర్ దొరికింది కదా. నాకు మెడికల్ ఎడ్యుకేషన్ చాలా ఇంట్రెస్ట్ మేడం. అట్ ది సేమ్ టైం కొంచెం వర్క్ లైఫ్ బ్యాలెన్స్ కూడా ఉండాలి కదా. మీరు 4 గంటలు పని చేసుకుంటూ కొంచెం ఇంప్రూవ్ చేసినా బాగుంటుంది, కానీ ఇది ఇంప్రూవ్ అవ్వదు. కొంచెం పే స్ట్రక్చర్ ఎలిజిబుల్గా ఉంది. చేస్తారండి, అంటే లోకల్ క్యాంపస్లో ఒక బిల్డింగ్ కడతామని చెప్పారు. తిరుపతి
Yeah. Good afternoon all. Post lunch. So we give some work to you right now. The workshop which we were continuing from day 1. Please open your laptops. So in today's workshop, this 45 minutes or 1 hour thing that you do is to the competency that you have selected previously in the day 1, that whatever the competency that you have selected, you have derived your the objectives on day 1, specific learning objectives. And yesterday you have written various teaching learning methods where elaboratively assessment methods were being taught yesterday, and today the skills, various skills that have been with certain demos that are being done. So now for the same objectives, you will be deriving or you will be going to which kind of or which tool you can use for assessment in detail, or the same thing has to be done in that worksheet that you are going to do in the laptop, and right from the beginning to the end you will be presenting. Everyone will present on the what you call the PPT mode. I think 20 minutes is enough, huh? So right from beginning you need to present. Oh, it's a Word document, so present it showing the Word document. I think if you can, entire thing, if you can just make a PPT, it will be more comfortable to see. Word document, okay, Word document is enough. Madam, 20 minutes? Enough. Yeah, they are actually yesterday only ready. 20 minutes time. Facilitators can help. Also just check into the teaching learning methods yesterday then to improve yourselves. If you have finished, send to the mail. Yeah, go. Green is ready. Sent. What about you, red? Group yellow? Last point. We want the volunteer, those who have not come onto the stage. We are enthusiastic to see the volunteer coming from the group, those who have not come onto the stage. From that group. Volunteer who comes, no? I want. We go in the serial, how it came. First, I think again orange has sent it. What about group blue sent? మీరు కూడా పంపిలా ఇంకా sent. Okay, madam. Yeah, shall we start, madam? I think they are ready. We got the mails. Yeah. Group orange, you can come forward.
So good afternoon. The competency that we had chosen was from General Medicine 2.2. So it is to perform and demonstrate BLS in a mannequin. So objectives. So mainly there were 4 objectives. So at the end of every session, the student should be able to, for the first objective was to define BLS and its physiological basis and its importance in emergency situation in a classroom. And the second one was to explain the physiological basis and the importance of BLS in emergency situation in a classroom. And the third one being the student should be able to outline the steps of BLS, followed by the fourth one. So the student should be able to observe and describe the steps of BLS in a mannequin. And the last one, so he should be able to perform correctly all the steps of BLS on a mannequin. So this was the table, so representing, so along with the competency, the objectives, the behavior, that is the ABCD, so audience, behavior, condition, degree, TLM, that is the teaching and learning method, and lastly the assessment tool. So for the first objective, for definition of defining the BLS, so short essay questions and Viva can be done.
What is the teaching learning method?
Tell the TLM method first, then the assessment.
Okay. So for the first one, to be able to define BLS, so the teaching learning method that we opted was to use a lecture method by chalk and board. So the assessment tool can be by doing the short answer questions, so and using the Viva that can be assessed. And the second objective is to explain the physiological basis and the importance of BLS in emergency situation. So again the TLM method which we have used here is the chalk and board method via the lecture. So the assessment tool is by MCQs we can assess that, followed by the short answer questions and the Viva OC again. And for the third one, so to outline the steps of BLS, so a lecture using audiovisual aids. So the assessment tool here is short answer questions, so or an essay, long essay question can also be asked. So coming to the fourth one, so that is to observe and describe the steps of BLS. Again, so the TLM, here is demonstration. So in a small group teaching method in a mannequin. So again it can be assessed using a essay as a essay question or a short answer question. And lastly, to be able to perform the steps of BLS in a mannequin. So here the TLM method is the dope session that can be used, and OSCE, that is the objective structured clinical examination, can be done, sir.
Okay, now it's open to the other groups for comments first before we give the comments. Other groups, can you just keep that tabular column alone? Yeah, minimize it. Yeah, that's fine. Yeah, great. Yes, quickly. Which group you are? You are
orange.
Orange. So other than orange, others can comment, and finally we'll come to orange group. Yes. Positive criticism means feedback means positive points first, negative points next. Yes, madam, you can tell.
I have nicely prepared it, ma'am. But that 4th point on the mannequin, they told that they will perform on the mannequin and show it. They wrote only assessment tool as essay question and short answer question.
To describe the steps
to describe
of
and
BLS.
observe and describe the steps of BLS
For
and
observing,
Yeah, okay, so you have a point, it's basically syntax. If you say only to perform the steps of BLS, which is the next objective, then it becomes same thing, mannequin only, DOAP session in a small group, and the OSCE is a correct method of assessment. But because the objective says describe the steps of BLS, actually the condition need not be mannequin here, no need to put condition. You observe and describe the steps of BLS, it's demonstration small group session in a mannequin, because the objective has used the word describe. So it could be a short answer question, it should be a 2-mark question also, just enumerate the steps of BLS. So that way the assessment seems to be in alignment, but the next objective is what we are looking at is to demonstrate the steps, see, able to perform the steps of BLS. Instead of saying performing, it will be better to say able to demonstrate the steps of BLS in a mannequin in a simulated environment. And correctly, obviously, DOAP session is demonstration, observation, assistance and performance. You can use the word, no problem at all, but it's in a simulated environment and therefore there will be an OSCE with an OSCE checklist, just like a Go Green group had developed the OSCE checklist. So you can use it as a completion for your group activity. They have done the OSCE checklist. So that way I think it is correct. Because the word describe is there, it seems to be appropriate. Otherwise, I agree with you. Demonstrate means it has to be only OSCE because it's a skill demonstration. Any other clarification? Okay, so they want to go back to ancient era of chalk and board. What is the size of your class?
this is a small group teaching 10 members.
No, you have written lecture, chalk and board, lecture, chalk and board. How many students in the classroom?
Ma'am, actually here,
no, you have to decide. If it's a small group, you can still use a chalk and board.
Yes,
if it's a large group, it's kind of difficult to keep the audience attention because, you know, the visibility from the back, there may be a light glare, they may not be able to see, still you can use it. There is no harm. Instead of that, you can write these boards. What is it called?
Flip chart.
No. The marker pen board is there, no? What is that? Whiteboard. Whiteboard marker may be better visible. It still can be used. I'm not saying it should not be used, but you should know the pros and cons of each teaching learning method. What will be the difficulty you will face? Here the best, no technology, nothing is required. Only you have to be there, the board has to work, the chalk has to work. Right? So this is the best. But you should be aware that sometimes the backbenchers cannot see it properly. So that is one of the things. Otherwise, I think it's well written. Any other comment?
Actually, they have written only one method. It's a chance where you can
think of other methods also.
Multiple methods.
That's okay. Yeah. So okay. Good job. Give a big round of applause. Thank you.
Adiga sir wants to talk.
Sorry? Adiga sir wants to say something.
Can you refine it a little bit? Because correctly will sound different to different people. Like,
yes, sir.
Because you are going to...
Sir, but in all the objectives, correctly is not necessary, but since the table was there, we had filled it and we didn't modify that. But otherwise, it's not required for all the objectives.
No, you can make it number of times.
Number of times. In case of
able to perform for the last one, we can do it, sir.
Yes.
Yes, sir.
And with respect to knowledge domain, this thing, first three, you can mention how much scoring is you are going to expect at the end of the class, something like that. If you want to improve upon.
Okay.
Correctly is obviously understood
correctly.
Because the column should not be empty, and I will pass some comment, so she's worried about that. No, I think this is quite all right, except for the last one, as sir said, you should be able to demonstrate steps of BLS correctly at least two times at the end of the posting, something like that you can add for the degree. Okay, Dr. Sachi? Thank you so much. Very good. Group Orange. Well done. Next, who's going to come?
Group Green, madam.
Group Green? I thought Dr. Guru Sridhar is going to present. Okay, we'll ask doubts to you, sir. Priyanka is presenting, please.
They can share. They can share, no, to people.
Good afternoon, everyone.
Yeah, please.
Chalo. Sir, our competency was from General Medicine 3.10. At the end of this session, third year MBBS student should be able to demonstrate technique of pleural fluid aspiration on a mannequin correctly. The objectives were, at the end of the session, third year MBBS student should first thing enumerate the indications and contraindications for pleural fluid aspiration, describe the procedure of pleural fluid aspiration, demonstrate accurately pleural fluid aspiration on a mannequin, analyze and interpret the biochemical parameters of the pleural fluid, and describe the complications of pleural fluid aspiration through small self-directed learning like an assignment, and followed by assessment by viva and immediate feedback. Next, obtaining consent for a pleural fluid aspiration in a simulated environment through role play. By using a Kalamazoo checklist, we can assess them.
Table.
Okay, sir.
Okay, it's open to comments from other groups. Other than Go Green, everybody else can comment. Go Green, any comments? Dr. Sridhar will add. Yes, anybody else? Anything you want to comment? Don't worry about your group presentation. First you comment here. Everybody's mind is on your own group. Hey, pa, perisa pannu pa. Pa, maximize karo. That page alone, that tabular column. Fulla theriyano. Yes, quickly. Anything that strikes you? Adallappa, the tabular column. Vijay. Konja kammi pannu. Konja kammi. Reduce it. Some more. That's enough. No,
One more is there.
It will come on next
bring
page.
it down.
It will come on next page.
Yeah, it will come in next page. Yeah, okay.
Describe the complications of pleural fluid aspiration can be a short answer, can be asked as an MCQ.
But since we wanted to give some assignment to them, we did that.
Still be a short answer at the end of the assignment. Yeah, or a viva. But see the words you have used at the end of the lecture. SDL you have put. SDL is self-directed learning. There is no lecture involved there. So just again a semantic and language. So you can say at the end of the given assignment, the student should be able to, what is that? Describe the complications of pleural fluid aspiration. And you have given a self-directed learning. You can use a viva, and as she suggested, you can even give a short answer question as an assignment. That's great. Anything else? Again, you see, automatically you've written at the end of the lecture for everything condition. But your method of teaching for the fourth objective is small group discussion or jigsaw. That means at the end of the session, if you write is enough, no need to write condition for everything, as we just said. And quiz, MCQ, extended matching item. See, analyze and interpret. You can also use an OSCE station. Somebody said, no, critical thinking, interpreting the report, an unobserved session, some report is kept and you have to interpret it. You can even OSCE. OSCE is for skills that you cannot test by just pen and paper. That is theoretical knowledge illama anything else. It can be communication skill, it can be psychomotor, it can be critical analysis skill also. You can use OSCE station. So OSCE can also be used, though I agree, even the quiz, MCQ, extended matching item can also be used. And then there is a very good quiz that is available. Sometimes you have to subscribe for it. It's called Kahoot quiz, poll everywhere. So many online tools are there that you can utilize for your classroom. Slido is there. So a lot of things that you can make the quiz very interesting instead of just putting MCQ as quiz, no? They will give pictures, it will be very colorful, they can answer on their phone, the reaction of the class will come on the screen, Kahoot quiz or poll everywhere, Slido, everything. So it's very interesting. It's interesting for the teacher as much as for the student, not boring. No, we don't have. We will go towards it. If you are all going to use it, definitely I will go for it. I have been wanting to do it.
No,
Kahoot quiz.
actually we are using for our association actually.
So you won't give it to us, no?
Yeah,
Your
yeah.
association.
It
Oh,
can be.
you'll give it. Okay.
With the help.
There, you can ask Kishore sir for that ID. Okay.
Yeah, madam wants
Otherwise, any other comment? Madam, please.
Poll everywhere. Mentimeter is there, which we can use for classes. It's all free. And
Mentimeter
it's
is
easy to
also.
use. You can include into your PPTs.
Number of participants for the Mentimeter?
Yeah, we have 150 students, so in a lecture
No,
class.
actually this Kahoot also, it is like, it gives about only 40 students or 20 students without
Free.
subscription.
After that you have to subscribe.
After that you have to
but
subscribe.
I think poll everywhere is free maybe.
Okay. Mentimeter and another is a poll.
Yeah, Kahoot is good.
Okay.
Okay. I think overall well done. Thank you ma'am for your inputs and thanks Priyanka. Bigger round of applause to team Go Green. Next. Which team next? Red.
Next I think it is red. Red. Adama.
Good afternoon. So we have chosen the competency DR 9.3, enumerate the indications and observe the performance of a slit skin smear in patients with leprosy. So the first objective at the end of the session, second year MBBS students should be able to describe at least 3 indications of slit skin smear. We have taken lecture, SGD and SDL as teaching learning method, and then assessment we'll do through MCQs, short answer questions. At the second objective, at the end of the session, third year MBBS students should be able to enumerate the steps of slit skin smear correctly in an order. Here teaching learning method, audio visual aids and SDL. Assessment was done through MCQ and short answer question again. Third objective, at the end of session, fourth year MBBS students observe and describe the steps of slit skin smear being done on a leprosy patient, bedside teaching, and then assessment through OSCE and mini-CEX. Fourth objective, at the end of session, interns should be able to perform slit skin smear under the guidance on a mannequin. Here dope in a skill lab and assessment through DOPS. Fifth objective, at the end of session, intern should be able to perform slit skin smear on leprosy patient under the guidance in minimum 3 attempts. Here assessment will be done with the help of DOPS, and immediate feedback will be taken as teaching learning methods.
Okay. Can you just show the whole table? Just reduce the font size. Yes, any comments from the groups other than red? Sorry? Third objective? Yeah, you can comment.
Just describing the steps, so OSCE is not required.
Okay, since it can be used, but whatever I said, no, what can be tested cannot be tested, otherwise you should use OSCE for that. So describing the steps can be done as just a short answer question. So you need not do observing and describing the steps can be bedside in the OP when they are doing it on a patient. You can also show a video. You can also show PPT with the steps being shown one after the other.
I think the third objective can I think the third objective can be made into 2 different objectives. One as describe and another as observe.
Yeah, again observe, how are you going to measure? That's why we said we'll do observe and describe the steps. We discussed it the first day. So it is okay.
Yeah.
Observe and describe the steps, which you can even do a viva. Ask them to tell all the steps. You need not have a bedside teaching, but it's okay. But since it is description OSCE may be a little overused here, not really required. You can have a short answer question also. See, because OSCE we said, no, it's very resource intensive. It's, you have to prepare checklist, everything. So which you can be tested by some other means, you test it by other means. Anyway, you can test it. So that is the change. And the last one, anybody else? Yeah, Mauna. So I didn't, yeah, right, I was about to say that. That is, you show it as a teaching learning method. At the end of the session, intern should be able to perform slit skin smear on leprosy patient under guidance in minimum 3 attempts. That is the objective. So how are you going to teach them?
Ma'am, since they are doing here, the student does.
No, before he does, you should teach them. No, you can't let patient, let the student lose on the patient.
Yes, ma'am. The fourth objective, when the interns come into the department, the first day they will be teaching, ma'am, under the guidance on a mannequin. And then after that, they will be giving, under the guidance on a leprosy patient, they have to do.
So the teaching method would be here. When in the skill lab itself, the same thing will be the teaching method. Or they observe, and when a faculty does it first, that is the teaching method. Actually, when on the patient he is doing it, that is what they are supposed to observe and describe, and then next they do it. Assessment and feedback, you can't show it as a teaching learning method, you understand? Or you repeat the same. You will do it in the skills lab, or they will observe the faculty, and if you are doing it the other way, Ravi, you have to stop doing this. No, DOAP you can show, Pa. That will be actually the DOAP is when you are doing it on an actual patient in the OP, they observe, then under your guidance they do it later. That is the teaching method you are using. Feedback and assessment is through DOPS. As they are doing it on the patient, you assess them and give the feedback. That is correct. This column should shift under DOPS, and the teaching method you can just put, as Ashish said, DOAP. That's it.
Actually,
is it clear?
Fourth and fifth objectives.
Monica is not happy, I know that.
Fourth and fifth objectives will be done for the same set of students, ma'am.
That's okay, Ma, but when you put it as a separate objective, you have to really show the teaching learning method and then the assessment. Assessment is correct. You have written it correctly. Yes? Okay. Good. Thank you very much. Big round of applause to Group Red. Now who goes next? Yellow or blue?
Please do the changes that are being said,
and please post it in the BCME group, WhatsApp group. It will be active for the next 48 hours. If you wish, we can continue the group also. It's up to you guys. You can share some learning resources, everything in that. Which group is this? Yellow, please.
మళ్ళీ పంపించారా ఇది కదా
మెయిల్ మళ్ళీ చేంజ్ చేస్తారా
అందుకు ఇలాంటి ఆప్షన్స్ పెట్టారు
See, yellow and blue groups, no? Clever fellows. As others are being corrected, they are quickly correcting and saying, corrected version number 1, version number 2 is coming up. No. Srinivasa, learn to take a joke. Thank you. I'm just joking, don't worry. I know you guys have worked very hard, done very well, and I'm extremely happy with the interaction and the group work being shown. So just to pull your leg, sorry.
Good afternoon, everyone. Yeah, today we have chosen the competency from the subject of pathology, that is 5.3, define and describe shock, its pathogenesis and its stage. So coming to objectives. So at the end of the session, the second year MBBS student should define shock, describe pathogenesis and stages of shock, and describe the treatment of shock correctly. So the teaching learning methods, for those things we are including lecture, SDL, jigsaw puzzle methods, and small group teaching, role plays, and teaching aid here is PPTs, videos, and we can use board and chalk or stick pens, and giving materials, study materials, and asking chart presentations or seminars, And assessment here is by giving short answer questions or MCQs or modified long answer essays and even Viva also. So for the objective 5.3.4, so final year MBBS Part 2 student should demonstrate resuscitative measures here in a simulated environment within 3 correct attempts. So the teaching learning method here is skill lab, we are doing in skill lab, and over the mannequin under the guidance of facilitators and supervisors. So here the assessment is OSCE or OSPI.
Anybody? I think they are. Okay. Kishore, you want to comment?
Teaching learning method for 5.3.4.
Yes, sir.
5.3.4.
Yes, sir.
Skill lab.
Okay, so what do you want to do? What do you want to change it as?
It's not a method, means its aid is actually.
Aid is a skill lab. You can say a DOOP or demonstration on a mannequin in a skill lab. The DOAP is also okay for that.
Yes.
Demonstration is enough.
The skill lab goes to the teaching aid.
Teaching aid, yes.
Yeah. There you written mannequin anyway, so that okay. Anything else? Okay, so she has, see, sometimes it's good if you club the first 3 or the first 2 objectives, you can finish it in a lecture class. You can even club 3 objectives because it will be overlapping. You have 45 minutes, you can finish it. So they have done the first 2 together, lecture. See, sometimes when you want to define shock, describe etiopathogenesis, you follow with a lecture.
Yes,
you can do SDL as a revision.
Yes,
In the beginning itself, definition of shock, if you do SDL, they'll go to all patient information site, and shock is when you faint and fall down in the road. You'll get different definitions. Better to take a lecture class, give SDL down the line as a revision class or something.
After the completion of class, ma'am.
Yes, exactly. Then you can give some assignment at the self-directed learning.
Yes.
Correct. Okay. So, the second thing you have written is describe treatment of shock. Okay, at the end of the lecture, I assume, right?
Yes,
but you have written small group discussion and role play. Now, how are you going to do role play as a teaching learning method will come of use for something which is very kind of abstract? It is difficult to show in a role play. Small group discussion, I absolutely agree with you. Give a case scenario and you can discuss various aspects of management of shock in that particular patient, and then you can give homework, whatever it is. So your thing will be small group discussion and a teaching aid, maybe
By
a
sharing
video
the
also.
teaching material.
More important is case scenarios. You can case-based discussion you can have
Problem-based learning.
Yeah, problem-based learning you can have. Role play is not suitable for something which has got so many abstract in the sense, so many things that you cannot really show in the role play, right?
Yes, yes.
So I don't think role play is the correct one. And the 5.3.5, you've written teaching learning method is role play and videos. So how will the teaching aid become students? You don't call students teaching aid. Students have to take part in the role play.
Yes, yes.
But the component is the videos is the one. You're going to show a video how somebody is counseling, and based on that they're going to do the role play. So your teaching aid will become videos, and the teaching learning method will be the role play. And for that you can use OSCE, you can use mini-CEX, you can use the Kalamazoo checklist as part of your OSCE checklist or as part of your mini-CEX. So that you have told very nicely. Okay, OSPI, as we understand, is for practical things in the lab. That means checking the urine for sugar or checking something, Rotaras test, all that is OSPI. So here what you want to do is only OSCE. Okay, so that is a slight change in terminology.
Yes.
Otherwise, very well thought out. Thank you. Big round of applause. Yellow team. The last team to come is blue team. Yeah, please. Srinivas is going to present. Please post the final corrected version in the group today itself before you go home.
Or a small group teaching. and teaching aid is audio visual aids and PPTs. Assessment method involved here is MCQs or short answer questions. And second objective, discuss advantages and disadvantages of various routes of drug administration. So lecture and SGT will be the teaching learning method, teaching aid is PPTs most probably, and assessment method is MCQs or short answer questions. And third objective is describe the various routes of drug administration for IV and IM routes. So TLM is lecture or SGT, teaching aid is using mini-CEX, audio visual aids, assessment method, short answer questions or OSPI. And then fourth objective, demonstrate the various routes of drug administration for subcutaneous. DOAP, using mini-CEX will be the teaching aid, and assessment method is OSPI and checklist. So last objective is able to counsel the patients regarding the adverse effects of different drug routes. TLM is role play here, and teaching aid will be audio visual aids, assessment method, logbook and checklist.
Very good. Now any comments from groups other than blue? Yes, Hemant has got a comment.
The 1.5.3, ma'am, lecture and mini-CEX.
What we will do actually in our so first initially we will describe the steps. Just we will show in PPTs steps. We'll describe just like theoretical point of view, and then we'll go for skill lab, that is in small group teaching, and there we will using mini-CEX we will demonstrate.
Okay, so he's got a kind of hybrid class. So you have to shift the audience.
Shift.
150 students you want to shift to skill lab, huh?
Actually, to be frank, 150 we will divide. 3 batches will be the practicals, 50, 50, 54.
Okay.
So it will be easy for us to do.
Okay, so I think the question why Hemant was asking was, describe the various steps. Wouldn't a lecture be suffice? Is his question, I think.
That means we'll
right?
just give for 50 minutes, ma'am, 10 to 15 minutes.
Okay.
And we'll utilize time like that.
So for the lecture component, you want to give short answer questions. For
that mini-CEX we are using, while demonstrating if the answer we can use as OSPI.
OSPI is what? But here we're only asking them to describe the various steps. OSPI is overused here. No need at all. No. Go to 5.3. You are saying describe the various steps. You may demonstrate using a mannequin, you may use a lecture, you may use a small group discussion. But the assessment method for the describe is only the knowledge component. So short answer questions is enough, I'm telling. Okay. OSPI is not required for that objective. Okay. You have correctly written it for the next objective, which is correct. Yeah, that's fine. Demonstrate means it has to be a skill that you can check by OSCE checklist.
For that objective, you should edit that OSPI.
Yeah, OSPI is not required, I'm telling. Okay. And then when you say audio visual aids, you have to tell me exactly what aid you're using.
Videos.
You have to mention videos.
Okay,
anything is AV aid. No, even PPT, you need a LCD projector as an AV aid. So you have to tell exactly PPT, videos. Yeah, that's what I want you to mention. Anything, Dr. Kishore or anybody else?
No, that competency, objective number, I think I can just have a look. 1.5.1.
Correct.
No.
And that is 1.5 itself PH, because to put
No, which is what is the competency number?
PH 1.5.
Then it's correct.
PH 1.5.
Yeah, you have to put PH 1, that's fine, 1.1, and then each objective will have 0.1, 0.2, 0.3. That is fine. That is all. That's correct. Okay, excellent. Thank you very much. One more comment I want to make is, when you're doing a small group discussion, you have written PPTs. You can also say a case scenario or a case-based discussion. Handouts can be used for them to understand the advantages and disadvantages of various routes. So you can have a case-based scenario, handouts you can discuss case-based scenarios. That you can do in your PPT also, both ways. But just you can add an element to your small group discussion. Okay, big round of applause for Team Blue. And again a big round of applause for the entire batch. Before that, Madam would like to make a comment.
Actually, it was a well-planned and well-designed teaching, learning, assessment methods. Few points to add up to this. In none of the classes, the time duration was mentioned. Most of the time, they gave us only 45 minutes for the class. So we need to make clear whether it is a 1 hour session which we are going to take or the 2 hour session we are going to take. Yeah. It's okay, but we have to plan. When you are planning, you just need to add it to it. And then, usually the first class, we can't have a self-directed learning, as ma'am said. We have to give an introduction to any of the topics and then ask them to read it and come back. You can always have a plan made the previous day itself. Tomorrow we are going to do a case on a respiratory system. You just look into the anatomy, physiology and come back. Or give them the material, ask them to do it and come back. Those things can be included into the lesson plan. It will make your things easier. Next day morning, you just come, ask 4 or 5 people to answer. Maybe it's the well answered who are always active. You can ask them to do it, which makes your things easier to go ahead with it. And as ma'am said, problem-based, many other small group discussion. There are many small group discussion planned here, but the thing zigzag and all, it's not that easy that you can do it for a 150 students. It needs lot of facilitators. Facilitators has to be then. So usually when we write the lesson plan, we say who are the facilitators for the lesson. The lesson plan has to include it. Then only you'll know whether you'll be able to run that lesson. And flipped classrooms, which is now coming up. You give the material before itself. As the ma'am was saying, they all go for the prep ladder and marrow and everything. Even in our setup, they say that we don't want lecture classes. You just show us the cases. That's what we wanted. That is what the students' current mentality is. So they know the materials. You give some more additional materials. Ask them to read it before. That's a flipped classroom. Let them come and present it. We can just do the assessment. We can finish it, ask them and give them the feedback. What is reminding? What else they have to do it? And most of the places you didn't give the OSPI is there, OSCE is there, but you should have given the feedback there. No, what went wrong, what was right, whether the procedures which they did was correct. If they have to modify, that end part has to come in all the sessions. The feedback has to come. Even after the test, we need to give a feedback. What happened? And feedback is not only for the students, it is for us, the teachers also, whether we took that correctly. So that can be included. And that role play is mostly for the communication skills. Or some procedures which is not an invasive procedure. It is like a first aid we have to teach them. How they do a bandage, all those things we can do it for a role play. But we can't use it for the invasive procedures or anything. But overall, it was very nice presentation.
Thank you so much. Thank you so much, ma'am. I think big round of applause to all the participants. Very well done. Thank you so much. Over to...
How we are getting feedbacks and learning from our mistakes.
Thank you. And we would now be at the end of the session, at the end of the day, getting a formal feedback in a written format as well as a Google form. So we value your feedback. Definitely, your feedback will help us to improvise our program. Thank you very much. Over to Dr. Jyoti now.
Thank you, ma'am. Good afternoon, everyone. So we will be now going to see what is this mentoring about. We are all mentors, isn't it? We have all been allotted mentees, but sometimes we don't know what to do in the mentor-mentee program. So we'll just see how it can be done, what is mentoring, and why is the necessity for this mentoring, okay? So at the end of the session, the participants should know about the principles of mentoring, why it is necessary in medical education, and few tips on how to implement this program. Now you all almost finished the program. Can you tell what is wrong in how I put this? Is there some mistake? If this is a competency, how I framed it? There's no action verb, isn't it? Action verb has not been used. Okay. So we will first see where this word mentor originated from. So it comes from Greek mythology. So the word mentor means trusted advisor. So the story goes like this. In Homer's Odyssey, Odyssey is a famous book written by Homer. So in this book, which is about the king Odysseus, Odysseus' son was Telemachus, and once this king had to go on a war with Troy. And when he went for this war with Troy, he left his son with his friend so that his friend could take care of his son. And that friend's name was Mentor. So this Mentor, he took care of his son, he took care of his palace in the absence of this king. And it turned out that this person, Mentor, was actually the Greek goddess of wisdom, Athena. So that's how the word originated. So we'll see about what is mentoring, why it is needed, and how it can be done. So let us answer some what questions now. How many of you have had a mentor or mentor figure in your life? Please raise your hands. And each group, can you please write about the qualities of a mentor? If you have had a mentor, or if you have not had a mentor, can you think of some qualities which you would want your mentor to have? You can use the flip boards, the flip charts. Why is everybody reluctant? You can discuss for 2 minutes and then write. Somebody should write. If you have had a mentor, you can write about that qualities, or if you don't have, what quality your mentor should have, or meeku already unnunte, what qualities he had. So 2 minutes, you can please write on the flip chart. Just 2 or 3 qualities will be enough. No need to write a big list. One word is enough. No need to write sentences. Just one quality or one word. Okay, now you're ready? You need not write 100. That's enough. Okay, group. This is group yellow, huh? Yeah, group yellow. Can you please read out?
So, okay, good afternoon. So, like the qualities of mentor, like it should be expertise and having good communication skills and empathy, patience, positive attitude, good listener, flexibility, and mentee friendly.
Thank you. Now, blue.
For us, a mentor should be reliable, resourceful, friendly, easily approachable, patient, inspiring, puts us in the right path, corrects our mistakes, and there should be mutual induction.
Thank you so much. I think most of you have written almost the same things, no? Okay.
So a mentor should be approachable. So he should be knowledgeable and calm and composed, and mainly he should be non-judgmental when somebody opens up to him. And he should guide us in a right path, so whether it is right or wrong, and give us a proper feedback.
Okay, thank you.
I think most of the qualities are already overlapping.
Yeah.
What is left is probably constructive criticism and ready to accept the criticism back.
Okay.
That,
Madam, mental should have good knowledge, should be a good guide, and who would criticize and correct us, and someone who simplifies the things. And, she should be able to support and encourage.
Okay, thank you. So all of you have told about many qualities of what a mentor should have, isn't it? Now if you look at these qualities, most of these are attitudinal qualities, how the behavior of the person or the attitudinal qualities rather than the expertise, isn't it? Expertise, of course it's necessary, but what is more striking is that attitudinal qualities of the mentor. So here, this is just a picture showing what all mentoring encompasses. So advice, providing motivation, you told encouragement, showing the right direction, showing mistakes and then giving constructive criticism, coaching, providing support, helping you move to your goal, and some training. So all these are different words that you will associate with mentoring. Now if you look at the definition, there is no one definition for mentorship. There are many different definitions. So the main thing would be that it's a process whereby an experienced, highly regarded, empathetic person will guide another young individual in their learning development and professional development, learning process and personal as well as professional development. So this mentoring, it blossoms from the desire of an experienced veteran to give and from the thirst of an inexperienced person to grow in his life. And it usually involves academic and psychological support. And mentee, you know, any person who is getting mentored will be the mentee. So if we draw some parallels to the ancient Gurukul system, we can compare it with the mentorship program. So in the Gurukuls, the pupils or the students would go stay with the Guru for a long period of time, grow in his life, and it's not only academic growth but also all-round growth of the individual. So this can be compared with what a mentoring is. So no prizes for guessing these people, isn't it? These are some famous examples for mentor-mentee relationship in the modern world. So you have Steve Jobs mentoring Mark Zuckerberg, and you have Warren Buffett mentoring Bill Gates. So these are some examples. So there are different types of mentoring. So again, that's a huge list. There are many different types of mentoring. The traditional mentoring, it involves what we told before, academic support, personal support and professional development. But there are some other types of mentoring. One is formal mentoring, which will happen in academic institutions like ours. So what is formal mentoring? It is where there is a systematic and planned match between the mentors and mentee. There are one-on-one mentoring sessions, face-to-face meetings between the mentor and the mentee. And there will be conducting individualized activities such as leisure activities. Inputs via online modalities, and there's no face-to-face meetings in case of e-mentoring. There's something called as group mentoring. Again, it's a style of mentoring where multiple learners and multiple mentors will conduct meetings and they will solve the problems, and this is basically done so that there is saving of time and not much of, so that there's efficient use of time in the program. And again, there are some types called as co-mentoring and reverse mentoring. Co-mentoring, like the name itself says, the two people who are involved act both as mentee and mentors. Both will be mentor. Now there are different stages in mentoring. So the first stage will be the initiation stage, where the mentee and mentor will just come to know about each other. They'll be starting to build a relationship with each other. The second stage is most important, setting of goal stage. What is the purpose of this mentoring? They will think of what goals to achieve. They will, the mentor will help the mentee in identifying certain goals. The third stage is the growth stage, where both the mentee and the mentor will work together towards achieving those goals. And finally, you have the closure stage, where when the goals are over, when the goals are achieved, the relationship will be over. Now, this can be taken as that goal can be achieved and the cycle can start over again. So, for example, if one mentee wants to finish a particular chapter, for example, if that goal is achieved, then the cycle can start over again. It does not necessarily mean the end of the mentor-mentee relationship. So while we know, you told so many things about what a mentee or what a mentor should be, isn't it? So while it is important to know what is mentoring about, it is more important to know what is mentoring not about. So we told mentoring is about being a role model, providing challenges, providing advice, counseling, being a critical friend, facilitator, so many things we have told. But what should a mentor not do? What is it not about? Doing the mentee's work for them is not mentoring. Just supervising their attendance and marks is not mentoring. Overcoming basic skills deficit. For example, if there's an internee who doesn't know how to suture and you're helping that person to learn suturing, that is not mentoring. And providing therapy is definitely not mentoring. There are people, assigned people, psychological counselor available within the campus who would be doing the therapy, and that part should not be taken over by the mentor. Mentor is not expected to do therapy for the mentee. And again, we've told there are many qualities for the good mentor. One of the most important quality is being a good listener. You have to listen while you are at the sort of hierarchically at a higher position, better position. The mentee would be a new person, but still your role is to listen to the mentee. You have to be respectful. You cannot be disrespectful. Just because it's a younger student, you cannot afford to be disrespectful to the person. You have to be available. You have to be available in the sense you have to provide time for the mentee. Then all of you have told all this, it's an experienced person. And networking, I think Kishore sir took a class about networking. So when it comes to the mentor will also, should also provide networking opportunities for the students. Like for example, a postgraduate student is in your unit, you have to able to network, you have to be able to network with your friends if there is some course or some other skill that your student can learn from that person. So you have to do that networking for your mentee. Then another important thing, confidentiality should be maintained. In mentor-mentee relationship, it is important that confidentiality should be maintained. A mentee, on the other hand, should be respectful, should be responsive, and should be accountable regarding mentee's work. Now, how many of you have read Harry Potter? So can you, who is the mentor here? Who is the Dumbledore? So Dumbledore is one of the best examples for a mentor in the literary world. He has helped Harry in many situations. He had given criticism. He had put Harry through certain tough situations and always helped and provided support to Harry. So one of the best examples for mentor would be Dumbledore. Now, can you think of some challenges in mentoring? Can anybody, if you tell, some challenges in mentoring? Communication gap. Okay. Okay, language problem. Everybody knows English, no? But okay, so if there's a language barrier, anything, any other challenges? Time constraints. One of the very important problems in mentoring is time constraint. Not all the time we can give time to the mentee.
Some we are like same mind, they can understand what we are saying and we are good with them, and other we are not matching frequencies, and it requires an effort from both the parties, both the mentor and mentee. unintentionally we stop giving our support without knowing to the person who is not able, we are not able to meet the frequency.
Some important points Dr. Maunika has told. One is halo effect she has told. So there are two important challenges when it comes to mentoring. One is unconscious bias. How many of us are guilty of unconscious bias? What is unconscious bias? She's told one, isn't it? One is affinity bias. Some new student comes in and this student is from your place and you automatically feel certain affinity to the student because she or he is from your own native place. You feel some connection. So what happens in such a situation? You might probably not criticize. You will be scared to be honest. You don't want to hurt that person, isn't it? What about perception bias? This happens very frequently. Some person is talking in some particular dialect or is from some part of the country which, there are stereotypes, isn't it? So what happens? You automatically form judgments. So this unconscious bias happens out of our control. It is not happening because we wantedly do it, but the brain does it. So it happens out of our control. It is an involuntary thing and there is a bias towards the student. It may be a positive bias or it may be negative. So perception bias is based on certain stereotypes. You think this person is speaking some way and you automatically don't like the student, isn't it? Then what is halo effect? Maunika told there's halo effect. What is halo effect? On the first day, first meeting, the person is nicely dressed and is talking nicely, you will automatically attribute positive qualities to that person. And whatever next the person is doing, we will fail to see the negative aspects and we will fail to give constructive criticism to that person. And what is confirmation bias? Again, it's a type of bias. What happens is, you see a person, you think this student is not good, and then you look for signs in that student that will confirm your thoughts or confirm your bias. That is confirmation bias. And what is to be done in case of this unconscious bias? You have to be aware that this bias is possible and you have to consciously come out of it because it happens out of our control. We just have to be aware that this is possible and we have to ignore this bias. And the next thing, Maunika again told correctly, intention deficit. What do I as a mentor get from mentoring? Why am I putting so much effort? I don't receive anything extra, so why should I do it? So that is intention deficit. You don't want to do it. You think it is a waste of time because you have to put time also into mentoring. But the thing is, you have to find value in mentoring. It will help you grow your managerial skills. It will help you become a better leader and will give you self-satisfaction along the way. Some other challenges, already told time, somebody told incompatibility between the mentor and the mentee. Either the mentor or most commonly mentee would breach the confidentiality and then the mentor doesn't want to do anything with that mentee again, isn't it? This is one important thing, problem, challenge in mentoring, crossing the boundaries, especially in case of personal issues and in matters of the opposite gender. So they say that mentor and the mentee should be of the same gender, that is preferable, but since it's not always possible, you should know where to draw the limit. It might be the mentee who is crossing the line or it may be the mentor who is crossing the line. But remember that you cannot cross certain boundaries. And last thing is, all students are not the same. I think Dr. Ranganath sir told about the garden analogy. So students are like seeds and each seed will take different time to sprout. They will need nurturing. Whereas mentor's job is to inspire the students to educate themselves. A teacher will have a well-planned syllabus, but when it comes to mentoring, we are often at a loss at what to do in a session. So every time the mentor and mentee interacts, there will be some learning that is happening. For a teacher, there is a time limitation. It's a 1 hour lecture or a half an hour lecture, whatever it is, but time should be more generously given when it comes to mentoring. A teacher will give the same information to all the students, but when it comes to a mentor, will decide what each student needs and will give that information. Who is this? Okay, that is Sachin Tendulkar, no doubt. That's Achrekar. He is Ramakant Acharekar, Sachin's coach. So how is a coach different from a mentor? They listen, support, inspire, encourage. But coaching is mostly a short-term goal, a short-term program. It's based on skill. It's based on growing some particular skill. Whereas in case of mentors, the mentor should be role model. It's a long-term goal, long-term program, and the mentors will advise direction. A coach need not be a role model, but a mentor should be a role model. Now, why do we need mentoring? Can anybody answer? Why is mentoring needed? We didn't have mentors, no? Formal mentoring we didn't have when we did our MBBS. Why is it required now? What is the importance? Okay. More distractions. Support students, but we also need it. Okay, to identify slow learners, okay. But that even teachers can do. Okay. Okay, a mentor will do more motivation when compared to what a teacher will do. Okay, we'll just see few reasons why mentoring is needed. What are the key objectives of this mentor-mentee program or mentoring, why it is needed? One is to create an environment of mutual trust among the students and faculty. There's a lot of trust deficit and that's seen nowadays, but to create an environment of mutual trust, it is needed. To encourage interaction and to reduce peer pressure. To help students manage personal issues, if any, and mainly to reduce the stress and depression and mental health ailments among the medicos, which seems to be on the rise. Now we see that before coming to a medical college, the students are all at their schools under the parental guidance and in a very safe environment, and suddenly they come to a medical college where they're overwhelmed by the sheer number of students in the class. There are 150 students in the class who are coming from different backgrounds, and they have to deal with peer pressure, lot of emotional immaturity at the age, and on top of all this is a stress of a very complicated medical curriculum. So that's why we need mentoring in our medical education. Now there was an NMC task force survey that was done. How many of you had done this survey? I think it happened 1 year back. We had given the responses. So after that survey was done, it was seen that mental health conditions were diagnosed in 7,115 medical students in the country, out of which 3,780 students had one condition, 1,851 had 2 mental health conditions, and 1,045 had 3 conditions diagnosed at the same time, and that's a staggering number, isn't it? So these might all be the causes. There are various causes for depression and mental health ailments among the medicos. We have seen failure to cope, or it may be the pressure to excel, lack of friends, multiple emotional issues, occasional disciplinary issues. All these would be the cause for the mental health issues. So the NMC task force has also given a 153-page report on how to tackle this problem in the country, and one important core regulation that they brought about was the mentor-mentee program, that it should be done in all the medical colleges throughout the country. Now when students were asked what they wanted from mentoring, they wanted honest feedback. Many of you told they wanted honest feedback, reliability and responsiveness from the mentor, networking opportunities where they can get a lot of opportunities by interacting with people of the other colleges, general career guidance, clinical and research expertise, and willingness to discuss the undiscussable topics. These were what the students wanted. Now, how do we conduct this mentoring? So what does the Graduate Medical Education Rules Regulations 2024, what does it say about mentoring? How many of you have mentees allotted to you? All of you have, isn't it? And what was the kind of mentor-mentee program that was happening till now? How was it happening? Was it phase-wise, or did it ever happen? It was phase-wise, isn't it? Students from your phase were allotted for you. You didn't have students from the other phase, isn't it? So now, what the GMER 2024 says is that the mentor-mentee program should be carried out judiciously with the ratio of 1 mentor to 3 mentees. Only 3 mentees. Mentors will be selected from all the disciplines and from the level of professor to assistant professors. When will the mentees be allotted to you? Not when the mentees come to your phase alone, but when the students join their foundation course in the phase 1, that is when the mentees will be allotted to you. 3 mentees will be allotted at that time. And these mentees will be connected to the mentors till they complete their internship. And each year, new 3 mentees will be added to you. So one batch of mentees, they joined phase 1. Then when they come to phase 2, another group of students will join phase 1. So from that group also, 3 will be added. So under one mentor, there will be mentees of different phases. So what is the idea behind that? So the senior batch students shall support the junior students and create a healthy environment, healthy sibling environment instead of ragging. These are the exact words from the GMER. That is the idea. Okay? So it should happen, and as mentors, we should ensure that the environment is very healthy and there is no toxic behavior among any part. So most of the time, we don't know what to do in mentor-mentee sessions, isn't it? They come, we ask them, what are your problems? How is your mess? How did you study? And everything. But there can be other interesting activities that can be done in a mentor-mentee session. So when the new mentees get allotted to you, you can do icebreaker sessions just like how we did icebreaker session at the beginning of this program. So different questions can be written down and they can pick up chits and answer those questions. That can be done. Goal setting sessions can be done for the mentees where they can be actually asked to write down a short-term goal probably in the next 1 month till the next mentor-mentee meeting happens, to write down the goals and what are the steps that you should do, or what are your objectives to achieve those goals, and to make a list of everything. So goal setting sessions can be done in a mentor-mentee program. You can have a virtual coffee chat with your mentees. You need not actually meet in person. You can just have a virtual coffee with your mentees where you get your cup, the mentee gets the cup there, wherever they are sitting, and have a chat over some online platform, isn't it? Another interesting session that you can have with your mentees is medical Pictionary. So can we play one round of medical Pictionary? Or you don't want to play? Enough tired? So from each group, so who draws well from your group? Who draws well in this group? Hmm? So we'll play one round of medical Pictionary, okay? You can implement the same with your mentees. One of you please come. So you will be given one term and you have to just draw it out and the other team members will have to guess. It's as simple as that. Then you have to come. Okay. So I'll give you one card. You should not show, I'll just show you that. Okay. You have to draw a diagram. You can't write anything. No, he can't speak also. Only draw. Temple. It's medical Pictionary. Bell's phenomenon. Okay. So who will play the next? I'll show you the word. Babinski's sign. We'll draw more. Not very sure. Easy though.
lateral side.
Balloon. Balloon.
She drew correctly only.
Name.
Draw here. No.
Name.
Okay. Correct. Lipoma. Hemant. Hey, you're not supposed to talk. Come. No, another one. No. Okay.
Alien. Pushing out faces. Moon faces.
Told her? Oh, yeah, correct. Cushing syndrome. Who will draw here? Will draw? Come. Okay, the last one. Wrist drop, correct. So all of you have done. So you can have some interesting sessions like these. And also a monthly reflection. Every month when the Mentor-Mentee program happens, you can have a monthly reflection session and ask them to reflect on the past month, what their goals were they able to achieve the goals, or if they were not able to achieve, what was the possible reasons. And the last thing, at an institutional level, we can have alumni network. Our own alumni can be allowed to interact with our mentees, and so that the alumni can help guide the students. Of course, this we as mentors alone can't do. We need institutional support to conduct this program. So we'll be giving you handouts to identify your style of mentoring. So in mentoring, there are different styles. Your approach can be different as individuals. So you can give the scoring, you can answer the questions and give the score so that you can understand your style of mentoring. One questionnaire that's given in the second page. Third page, there are questions. So you can see the question. First question is, when I deeply go into the problems of the mentee, this evokes new problems. I prefer to avoid that. So you can answer that question based on the points. If you strongly disagree, you can give 1. If you disagree, you can give 2 points. If you agree or not disagree, you can give 3. Similarly, you can answer all the questions and give points, and at the end you will be able to derive your style of mentoring. Everybody should do.
ఇది సార్ ఈ 5లో ఏదో ఒక రేటింగ్ ఇవ్వాలి మీరు ఏ కేటగిరీ కింద వస్తారో
ఫస్ట్ ఇవి చదువుకోవాలి కదా
అవేం అవసరం లేదు సార్, అవన్నీ మళ్ళీ లాస్ట్లో వస్తాయి. ఆ క్వశ్చన్ మీరు అగ్రీడా, డిసగ్రీడా, స్ట్రాంగ్లీ అగ్రీడా,
నేను ఏం చేయాలో తెలుసుకోవాలి.
అదంతా ఎందుకు చూస్తున్నావు? అవన్నీ చూడొద్దు. క్వశ్చన్స్ చూడి ఆన్సర్ చేయి అంతే. బర్త్డే బాయ్ ఇక
So do you want a tea break or you want tea to be served on the table and we'll continue the last session for today? continue and we'll serve the tea onto the table. Is that okay? Thank you so much.
లేదు ఎట్లనే కానీ అదే టైం చేస్తారు మీకు అర్థం కావట్లేదు వాళ్ళు మోసం చేస్తారు మమ్మల్ని.
Anybody has done, finished putting the marks? So what, you've derived your style? You put the marks, no? So now you have to, no. You have to put these marks here as per the question. For first question, if you have got what mark, you have to put number wise, question number wise, what marks you've got here, what points you have given, you put those here. And you add up vertically.
Okay.
And which one has got the maximum number, your style will be that.
Oh.
You put, now you have to add these up. Add these up once. Yeah. You have to add up vertically. 2 plus 6, yeah. Okay. So you've got maximum points for the last line, no? So that means your style is cooperation style, and you can go and read about that style. Marks ante ikkada veyali, ikkada question numbers unnai kada. So for first question what marks, for second question what marks, you put all those marks here and then you add up vertically, and for the line which has got the maximum mark, your style will be that. See, because if this marks is more, you will be letting go style. If this one is more, yours will be active listening style, and so on. And you go back and see those styles if it's matching with what would be suiting. You've put, no, now you added up, and which line has got the maximum marks? 15, no? 11, 14, 15, 11, 14. So 15 is the maximum, no? So what is the third letting go style? Active listening style, advising. So yours would be, no, active listening is 1. Letting go is 1, active listening is 1. Third one is advising. So yours would be advising style. And you can read about that. No. Okay. You can take this. This would be the major style, but you also prefer this style. So I think you have all done, no? Okay. So this is just a study that was done. So studies were done regarding mentor-mentee program, and many benefits were identified. Mostly students liked about discussion of problems, they learnt about time management, extracurricular activities, the confidence to participate in extracurricular activities, they felt motivated. So all these positive points were seen about the mentor-mentee program. Some found work-life balance and all these things they learned from this program from the mentors. So the conclusion is, each student is different. There will be unconscious bias come out of it. Have a strong intention to do mentoring. Build relationship of trust. That's the heart of mentoring. And don't provide just support to the mentees. Also give them small challenges which they can overcome. And always respect the boundaries when it comes to the mentee relationship, mentor-mentee relationship. Thank you.
Same. Split personality. Same highest.
So when I took a class, madam, probably some 6 months ago, I had this question. I had put up a poll on the board, and I asked the students. This is little counterintuitive. Some may reject it, but I yet asked them, how many of you think that your professors are successful? So less than 50% of said it that they are successful. If they see the teachers as not as successful, they cannot take us as the mentors. So the problem would be not us taking the students, but students accepting us as the mentors.
The choice for the students will be there only if it's an informal mentoring. Ours is a formal mentoring activity that's going on, and it's a mandatory part of the curriculum, just like how the different aspects of the curriculum is, this is also a mandatory part. So there's no way, there's no choice for the mentors. Maybe ma'am can throw some light about how it is done in ma'am's institute.
We have it by lots. We don't select anyone. So by random you are allotted a person and they have to be with you. And success, it depends. Maybe a person who is an extrovert, who can talk to them very well, they might like it. Whereas another person who's moody, but he is a very skilled person, clinically very skilled, they may not see them as very successful. As the days goes on in mentoring, maybe you will become more influential person than the other person whom they thought it was successful. So it depends how we interact, how much we get connected. And as it is now like 3 people each year, for us it has been going on for a long time. We have a fostering system. We invite them for a dinner or something. And the senior who is finishing that final year, they give the opinion to the junior ones. And after some time, they become mentors for the junior one. You don't need to tell many things to that. So actually, it's a good experience. It's not as difficult as you think. It's only that we have to allot some time. Now that media and all is so much into it, you can have a WhatsApp group. There will be some birthday, one person's birthday. You can wish them, tell them that we'll all have a coffee in canteen today. Get them all together. Actually, the food is the best thing. Give them a coffee. You don't need to give a great meal in a big 5-star hotel. Just give them a coffee. I still remember my surgery professor who used to take us when he is taking the clinics to a canteen. That was on Ola Kotai those days. And it was only the vada. But still I remember and I do the same when I do it. That is what I carried from him. So these things will make an impact. Just small gestures. Get them together, talk to them. Definitely it makes, actually if you have, there's one other study saying that it's a case study where a person has written how she felt that she had a suicidal tendency, and at the hour she called at the mentor, and just the talk with the mentor was helped her to prevent it. It's written in a blog, I think. So those things definitely matters. That too when they are new to the college, where they didn't know whom to talk, who's better, definitely one person will be very helpful.
Thank you so much, ma'am, for your valuable inputs.
No. Before allotting mentor, such questions can be given to all the students. Depending on the thought process, we can allot the mentor.
Thank you. Difficult. Mentors. Now I'll hand over the mic to Dr. Ramya.
Thank you, Dr. Jyoti. Good afternoon, everyone. I know this is the last session on the last day, so I know what precautions to take. So anyway, my topic is drafting a schedule for a phase based on competencies. It's very important. So I'll straight away start with the objectives of the session. We have to understand the steps in drafting timetable for an academic year. How many of you have drafted a timetable for the whole year? Yes, phase 2. A timetable for the whole year. Yes, phase 2 you have done. They have also done. Any others? Yes, sir. Kishore, sir. Phase 2 again. Okay. So for the others, there are a few important points which you have to know when you are drafting a timetable. It's like a phase-wise timetable. In a week, all the subjects across a phase, what topic they are teaching, and in that you have to incorporate all the competencies and all the learning domains, all the teaching learning methods into the weekly timetable, make it for a whole year. How much we stick to it, we don't know, but at least making it for a year will give us some idea about how and when to approach the syllabus. So what do you mean by drafting? What do you mean by a draft? We use that word regularly in our day-to-day basis. When do we say draft? A rough copy. A rough copy or a rough sketch of something or anything, a rough copy. If somebody say, you give some work to somebody, you say, give me a draft. Let me edit it and then finalize. So drafting means preparing a preliminary sketch or outline a plan for action. Drafting in a stepwise manner is an essential component for the preparation of CBME timetable phase-wise. It's not an easy thing. Okay. What was the traditional method in which a timetable was set? A weekly timetable, maybe just a subject here and there, no topics, no different types of teaching learning methods, nothing. It was just a simple weekly timetable, and every week it used to change depending on the availability of the faculty members. Timetable used in CBME is more complex and it requires meticulous planning. But if it is done, it is really effective. We have seen the results of that. So departments, so what is required for this? Departments across a phase need to sit together and finalize the topics. Focus should also be given to competencies and sub-competencies, and also some amount of alignment has to happen. Integration, that is next level, it comes in a whole different context. At least when we are doing a timetable phase-wise, some amount of alignment has to be made. So what do you mean by alignment? It implies you teach a subject that occurs under a particular whatever context. It occurs in the same phase, but sometimes there can be repetition. Same topic in different subjects. For example, in phase 1, when anatomy is doing dissection in thorax, we can teach cardiovascular system or respiratory system in physiology. So that is what you mean by alignment in this context. Why is this required? Okay, at this juncture we'll have a small activity for just 2 minutes. Only 2 minutes as you are having tea. Who are the group leaders? Can all the group leaders come here? No, there's no performance and all. I just want the group leaders to come here. Please come quickly. Just 2 minutes. So each of you is given a task. It is written in this. Form a huddle. Just form a huddle. So don't talk among the groups. It has to be secretive, only within the group. Very quickly. Two minutes for individual groups, 4 minutes for the group leaders. Time up. Quickly.
Write only one sentence regarding friendship. Your sentence will be used as a part of 5 sentences.
No, don't be loud, don't be loud.
To create a small story. Friends మెంటర్షిప్ మీద ఒక లైన్ రాయాలి.
Over?
ఫార్మల్, ఇన్ఫార్మల్.
Individual groups, finished? Thank you.
Non-genetically related, non-genetical relationship.
Anything that comes to your mind, you don't have to check Google. Done? Yeah. You have to write it on that piece of paper. I'll take it back. Only one sentence.
దీంట్లో కోఆపరేట్.
Okay, group leaders, are you done? Over.
Actually, no, let me go stay there.
So you can have tea while we wait for your group leaders to do the activity.
Cooperative and advisory, no idea.
కోఆపరేటివ్ క్రిస్టియన్ కోఆపరేటివ్
ఫస్ట్ అయితే ఫస్ట్ ఎవరికి రాలేదు, లెట్టింగ్ వస్తాయి. లెట్టింగ్ అంటే ఏది
దాన్ని గ్రూప్లో పోస్ట్ చేసేవా టెంప్లెట్?
Yes, ma'am. Yes, ma'am.
చెప్పలేదు. ఇప్పుడు నీకు ప్రమోషన్ కావాలంటే ఎందుకు వైర్లు లేవా, మాకు బ్లూటూత్ లేవా, ఏం మాట్లాడుతున్నావు? టెక్నాలజీ పెంచుతున్నావు, ఏతో మాట్లాడుతున్నావు. ఏ వరల్డ్ లేదు వీళ్ళు ప్రమోట్ చేస్తే వాళ్ళు మామూలుగా ఇచ్చేస్తారు. వాళ్ళు ఇచ్చేస్తారు. వీళ్ళు గవర్నమెంట్ ఇచ్చిన ప్రమోషన్. ఓహో
Very good. So, another group has written, it is a ship which carries spears to a joyful destiny. Another group, never-ending relationship. Another group, no end for a true friendship. So two things are similar. One was informal, and we had two other points. Can you make a story out of this? Can you make a story out of these 5 sentences? You can't make. I asked all the group leaders to write a 5-sentence story regarding friendship. So very nice story has come up. They were all very actively discussing. I'll read it. I found my friend during my 4th standard days. I became more close to my friend during playing cricket. During my college days, I was hit by a cricket bat. You hit him with a cricket bat and then felt bad remembering those memories. Okay. It's chronological. During his marriage, I was not able to be present there and I felt very guilty. So to compensate, after 5 years, I attended his son's first birthday party. He gave a gift. Okay. So this story came up when all the group leaders were discussing. He hit his friend with a cricket bat. Gift. I don't know what, surprise gift. I don't know what gift. Okay, see the whole point of this exercise. Can you make out something out of this? Not about friendship. It's not about friendship. It's
people are there.
exactly. See, if you work together, there is an alignment of ideas and something meaningful can come out. You can avoid a lot of repetition. See, 2 people wrote the same thing about friendship. You didn't know what was going on in the other group. So it was a repetition. Now, okay, putting this into the actual topic, if faculty members across a phase sit and decide. You can plan the curriculum in such a way that you can avoid maximum repetition. That saves a lot of time. You can use that precious time for other methods of learning. That was the whole purpose of this activity, and also to keep you awake. I think I have achieved it. Okay, next we'll move on to integration. So what is integration? Topics of a single concept are merged into a single session, and the subject boundaries are removed here. Again, this will save us a lot of time. So what is a teaching schedule? It is a list of, formally if we have to tell what is a teaching schedule, it's a list of times when particular activities or academic activities or events will happen. It is a proper schedule of events that organizes teaching activities. It can be throughout the day, for a week, a term, a month, or a whole year for that matter. Same thing. What is the need now? Again, like you all said, we all know what is the need of a teaching schedule. Planning. It saves time. It is more systematic. Okay. To inform the teachers and to inform the students what will be taught when. Okay. So what are the steps in drafting a timetable? What is the first step in drafting a timetable? How much? Time. First thing, how much time you have. Another important thing. Your syllabus. Syllabus. You should know what syllabus you have to cover and how much time you have. These are the two important things you have to remember when you are drafting a teaching schedule, a timetable. So if you take, this is the phase 1. Okay, this is for the phase 1 according to the CBME regulations. For first MBBS, these are all the things which have to be covered in one professional year. We have a foundational course. Earlier it was 1 week over 6 months, but this year it was 2 weeks and 80 hours. Okay. Then you have all these the subjects and community medicine, ECE, family adoption program, EdCom modules. All these things you have to go through. Next, how many number of hours for what particular type of teaching learning method? For example, anatomy has got overall 620 hours of teaching. Among that, 180 are lectures, 430 are small group teaching, 10 are self-directed learning. So we have to split up the types of teaching learning methods for each subject across the phase. Then, what is the total time allotted? So we all know for first professional MBBS year it is 13 months. But how many weeks are 13 months? 57 approximately. So in that if we remove 15 weeks, not 15 weeks, we will get only 42 weeks, ideally speaking. Remove all the Sundays and public holidays and festivals and summer vacation, internal exams, final exams, all that. Approximately we will get 42 weeks. So 42 weeks per week, how many hours we have? 6 into 7 hours per week, that is 42 hours. So totally approximately 1764 teaching hours. So now we have calculated the time and we know our syllabus. Now we have to draft the timetable. So this is the calculation. Then we have to prepare the master time schedule. That is the weekly timetable with the timings. What time the day starts, what time the day ends, and what time is the lunch break. So then we have to discuss with all the concerned HODs and the leadership and everyone. Prepare a weekly timetable, then make a monthly timetable, and then make a yearly schedule. So all these aspects we have to demonstrate or we have to show in the CBME timetable. How many lectures, how many small group teachings, how many tutorials, practicals, etc. We have to also include family adoption program, skill lab schedule, clinical postings, time allotted for sports, and also time allotted for examinations. Now this is the master timetable for phase 1. So each subject has been given a different color. So if you see, all aspects of the CBME are there. There are lectures, there's large group teaching, there are small group teaching, tutorials, formative assessment. There is also time included for formative assessments and EdCom. Now a similar template has been shared in the WhatsApp group. What we want to do, you to do in the next 15 minutes, you have already chosen one competency, isn't it? What was the competency with shock? Shock. What was yours? Routes of drug administration. So with that competency as core, okay, supposing shock, you want to do a phase 1 timetable or a phase 3 part 2? Phase 2, okay. Do a phase 2 timetable. Try to align your competency with the other subjects across the phase. If you want to add a point about integration, you can add. So make a weekly timetable. So group yellow will do a per 1 week timetable for phase 2. You will also do for phase 2 because it's routes of drug administration. A template has been shared. You can edit that template if you want to edit the timings. That's why I thought it's a leprosy procedure. Okay, you take another competency, and which phase you want? Phase 2. Okay. So this group is nicely relaxing. So what was the competency? Pleural fluid. So you want to do a phase 3 part 2. You do any topic, but just decide the phase. Phase 3 part 2. Okay. Phase 3 part 2, make a weekly timetable and align that competency with the subjects.
Weekly for 1 year, madam?
For 1 week. No. Now you can do it for 1 week. We'll be very happy. Madam will be even happy if you do for 1 year. So 15 minutes time is enough?
Main pediatric surgery, general medicine.
ఈ మధ్య తీసేస్తున్నారు ఆర్థోకి క్లాస్
ఆర్థో ఒకటి, రేడియాలజీ ఒకటి. ఆర్థో రేడియాలజీ ఒక క్లాస్.
ఇప్పుడు మనకి ఏ ఇయర్ డిసైడ్ అయ్యింది, ఏదో ఒకటి ఏమన్నారు, ఏదైనా వీళ్ళు థైరాయిడ్.
So all of you have the UG curriculum, soft copy, isn't it? All of you have got the UG curriculum, the soft copy of the UG curriculum. You can copy and paste the competencies. For example, see they are doing shock, okay, and they want to do phase 2. So in pathology, when they are teaching shock, they will want the pharmacology department to teach drugs related to that. They will want microbiology people to teach something relating septic shock or something. That is what we mean. And you can copy and paste the competencies from the alignment is a must. Integration is optional. Yes, that they will do. That they will do. We will judge them later. We want to create like this for 1 week. Like 1 week. 1 week. All subjects. Yes. I'll just show you. See, all the subjects have to be mentioned. All the subjects in that phase have to be mentioned. I'll just show you an example.
లివర్ కొట్టేసి లేదు, లివర్లో కూడా ఆటో వాళ్ళు వస్తారు, ఏమనుకుంటున్నారు రోజు ఏంటి మాది కాదు.
Okay. So this is an example of an integrated timetable for first MBBS. So we have to write the topic concerned for each subject. See, for example, in physiology, if they are teaching functional anatomy of respiratory tract, anatomy is teaching introduction to CVS and blood vessels, dissection, upper limb, eventually they will go to thorax. Supposing we are teaching something in CNS, in anatomy department simultaneously, they will teach about glial cells or structure of a neuron or topics like that. So you have to choose topics from the list of UG competencies, align it across the phase.
కార్తో లివర్ అనాటమీ వల్ల అవసరం లేదే మేడం, ఫైనల్ ఇయర్ కదా, సో సర్జరీ వల్లే చెప్పేస్తారు అదే.
దేంట్లో ఇచ్చినారు? గ్రూప్లో పంపించారా? ఎక్కడ?
కరికులం ఫస్ట్లో వచ్చేసారు, కరికులం 1, 2, 3.
చూపి ఎక్కడ కరికులం ఉంది?
ఫస్ట్లో కరికులం ఫస్ట్ సార్, ఫస్ట్ మనం రాకముందే పంపించినారు.
అవునా?
సెషన్ ఫస్ట్ డే సెషన్ స్టార్ట్ అయ్యే ముందు వచ్చినాయి కరికులం మనం వస్తాయి. దీంట్లో ఏదో దాంట్లో ఉంటుంది సార్ సర్జరీ.
అవునా? నువ్వు ఏం చూస్తున్నావు? అదే తీస్తున్నాను, ఒక్క నిమిషం ఉండు, నీకు వచ్చేసాను.
నేను మైక్రోబయాలజీ ఎదుగుతాను, హెపటైటిస్.
దీంట్లో కాదు, దీంట్లో.
సో అయితే మేమేం చెప్పాల్సిన అవసరం మేమేం అవసరం లేదు. ఫైనల్ ఇయర్ వాళ్ళే మెడిసిన్ వాళ్ళు కవర్ చేసేయచ్చు ఏమన్నా హెపటైటిస్ వైరసెస్.
అదే కరికులంలో లివర్ ఉన్నది.
అంటే మేము ఫైనల్ ఇయర్
ఏదో
అదే జనరల్ మెడిసిన్ వాళ్ళే కవర్ చేసేస్తారు ఆ టాపిక్.
మీరు హత్య కావద్దండి. కరికులం కరికులంలో పై నేను చదువుకుంటాంటే లివర్ ఎక్కడ ఉన్నారు? దీంట్లో సెర్చ్ లేదా? సెర్చ్ ఎక్కడ ఉంది?
కంట్రోల్ ఎఫ్ కొడితే వస్తుంది.
కంట్రోల్ ఎఫ్
లివర్ అన్ని లివర్లో వస్తాయి సార్ జనరల్ మెడిసిన్.
ఏదైనా రండి, అన్నీ కావాలి కదా. ఏ లివర్?
Once the weekly timetable is done, you can share it. We can project it.
ఇది క్లినికల్ కావాలా మీకు? క్లినికల్లో కాంపిటెన్సీనా?
అది బయోకెమికల్ వస్తాయి, అవన్నీ జనరల్ మెడిసిన్ వాళ్ళే చెప్పేస్తారు మేడం. అవన్నీ ఇంటర్ప్రెట్ లివర్ పారామీటర్స్ అవన్నీ ఇంకా మెడిసిన్ వాళ్ళే కవర్ చేసేస్తాం. మేము ఓన్లీ సెకండ్ ఇయర్ వరకే వస్తాం.
ఉన్నాయి చూడు.
లివర్లో ఏమైనా బోన్స్ ఉన్నాయి.
మొత్తం ఇక్కడ అన్నీ ఉన్నాయి చూడు. లివర్లో నీకు ఏమి ఈడియాలజీ అవన్నీ కావాలా?
వేరేవి కూడా వేసేయచ్చు మేడం, లివర్ కానీ కూడా ఆర్తో వల్ల ఏదో టాపిక్ వేయచ్చు. ఇప్పుడు సెకండ్ ఇయర్ ఒకవేళ కోఆర్డినేట్ చేయాల్సి ఉంటే చేయొచ్చు, లేకోకుంటే వాళ్ళు ఊరికే వేసేయచ్చు. లివర్ కింద కవరేట్ చేసేయచ్చు, లేకున్నప్పుడు వేరే వేసేయచ్చు. మోస్ట్లీ మెడిసిన్, సర్జరీ, పీడియాట్రిక్స్ ఎక్కువ వచ్చేస్తాం. రేడియాలజీ కూడా
అసలు ఏం లేదు, అది రాసేసండి. ఏది ఉందో ఫస్ట్ మీరు టైం టేబుల్ అవుట్లైన్ రాసేదండి, మళ్ళీ చూసుకోండి. ఏం ప్రాబ్లం లేదు. ఏది ఇయర్
అప్పుడు ఫైనల్ ఇయర్లో 5 క్లాసెస్ ఏమి ఉంటాను అనుకుంటా సార్, ఆర్థోకి, రేడియాలజీ.
అవును, రేడియాలజీ రేడియాలజీ ఎక్కువ ఉంటాయి, ఆర్థో తక్కువ ఉంటుంది. ఆర్థో 1, రేడియాలజీ 2, 3 అయిపోయినాయి. మైక్రోబయాలజీ 1.
మైక్రో ఉండదు సార్, మేము రాము కదా, సెకండ్ ఇయర్ అయిపోయినాక రాము. అవి జనరల్ మెడిసిన్ వల్లే చెప్పేసుకోవాలి. పీడియాట్రిక్ అదే మేడం, మీరు అన్నీ మీకు ఆల్మోస్ట్ అన్నీ వస్తాయి కదా.
కావాలి మళ్ళీ వస్తాయి.
మీకు ఇన్ఫెక్షన్స్ డిసీజెస్ కూడా అన్ని టాపిక్
ఓపెన్ చేసి పెట్టిండు ఒక 5 నిమిషాలు.
మీ సెకండ్ ఇయర్ నుంచి స్టార్ట్ అవుతాయి కదా క్లాస్.
మనకి ఏదో అంతా వచ్చినప్పుడు లాస్ట్లో క్లోజ్ సెరమనీ అప్పుడు ఎందుకు చెప్పు, మనం ఏదో చేస్తున్నట్టు ఉన్నామనుకో అయిపోతుంది కదా. ఇదంతవరకు చేసి ఈరోజు చూస్తే
Are we done?
మనకి క్లాస్ లేదు, ఇదేదో మనకి చేసి చూపించాలంటే ఏదో ఒక చేసి ఇచ్చేస్తే అయిపోతుంది కదా. యాక్చువల్లీ ఆ డన్ అని కూడా పెట్టేశారు, మీరు ఇంకా డిస్కషన్లోనే ఉన్నారు. సో ఈ గర్ల్స్ ఆర్ వెరీ బ్యాడ్.
That's always a problem. That is why, see, all the group leaders were HODs. It always happens. It always happens. It always happens. So that is why now we have 30 people who can do the integrated timetable. It will make your easy. Yes.
అది గ్రౌండ్ ఉండే సార్ పొద్దున్నే.
అవును మేడం, అసలు దేనికి ఇచ్చారు అది? అది ఏమి
ఇక్కడ ఉంది సార్, ఇది
అన్నెమ్ముడు మేడం రాసము. ఒక నిమిషం ఉండు, అన్నెమ్ముడికి టిక్ చేయాలి. ఏంటి టిక్ చేస్తున్నాను అక్కడ రాసి కూర్చొని ఫాస్ట్గా ఏదో ఒకటి రాసేయి, ఏదో ఒకటి రాసి ఇచ్చేసేయి. నేను చెప్తాను.
అలాగంటే పేపర్ పోయిందనే చెప్పిండి.
కదా
కంట్రోల్
కంట్రోల్ లెఫ్ట్ అంటే ఏం రాలేదా
సరిగ్గా కొట్టలేదు కంట్రోల్ పట్టుకొని కొట్టాలా
ఓకే కంట్రోల్
అక్కడ టైప్ అవుతాను లేదు ఎనేబుల్ ఎడిటింగ్ కొట్టాలి
ఎడిటింగ్ మోడ్లో పెట్టిన అదుగు
ఓకే
నేను రీడ్ మోడ్ కాకుండా ఎడిటింగ్ మోడ్లో పెట్టుకున్నాను కాపీ పేస్ట్ చేయాల్సి వస్తుంది అది ఎనేబుల్ మోడ్ ఇప్పుడు యాక్టివేట్ చేశాను అవసరం లేదు
అది కాకుండా అవసరం లేదు సార్ సర్చ్కి ఏమి ఎనేబుల్ ఎడిటింగ్ అవసరం లేదు
వస్తుంది తిరుగుతావు ఓకే కొట్టు అది లివర్ కొట్టేసాయి లివర్ సెర్చ్ కిందకి వచ్చేసాడు ఇక్కడ చూస్తాం సరే అట్లా పో ఆఫ్టర్లో ఇది అన్ని సర్జరీ
3.5 years పొద్దున్న నుంచి డైలీ 10-12 hours సిస్టమ్ ముందు కూర్చున్నాను
అవునా
ఫస్ట్లో జాయిన్ అయితే 17 hours కూడా చేయించారు కోవిడ్ టైంలో సార్ వర్క్ ఎక్కువ ఉండేది కదా కోవిడ్లో మెగా ట్రయల్స్ జరుగుతూ ఉన్నాయి కదా డేటా ఎక్కువ వచ్చేది వర్క్ వాంచి పడేది వాళ్ళు మామూలుగా 2-3 months ఇయ్యారు సార్ ఆ కంపెనీలో వర్క్ మేము ఆ టైంలో చేరడం వల్ల ఒక 3 daysకే స్టార్ట్ చేశారు కూడా మామూలుగా 2 months ట్రైనింగ్స్ ఉంటాయి కోవిడ్ డిమాండ్ వల్ల 3 days to 15 days
చేంజ్
మొత్తం మార్చేసింది మాది యాక్చువల్లీ ఆఫీస్కి పోయే రోల్ సార్ అదే ముందు కోవిడ్ టైంలో వర్క్ ఫ్రమ్ హోమ్ చేసేసినారు దాన్ని కోవిడ్ దెబ్బ
మనకి రాసేసావా మేడం వస్తుంది
మైక్రోబయాలజీ ల్యాబ్లో ప్రెజర్ తట్టుకోలేక అక్కడికి పోతే అక్కడ మళ్ళీ ప్రెజర్ ఇక్కడ పొలిటీషియన్లు మా రిపోర్ట్ అర్జెంట్ అని చెప్పి మాది ఎందుకు పాజిటివ్ ఇచ్చినామని చెప్పి ప్రెజర్ ఒకరేమో మాది పాజిటివ్ ఇచ్చా మా ఇన్స్టిట్యూట్ ఫెన్స్ వేస్తున్నారు అని చెప్పి బెంగళూరు
అప్పుడు పాజిటివ్ ఇస్తే
సార్ మా స్టాఫ్ వాళ్ళదే మాది ఏదో పాజిటివ్ వచ్చిందంట మా ఇంటి చుట్టూ ఫెన్స్ వేస్తా అన్నారు వాళ్ళు ఆయన యాక్చువల్లీ నెగిటివ్ ఇచ్చిందాము ఆయన వేసే ఆయన కూడా మున్సిపాలిటీ ఆయన మాకు తెలిసిన ఆయన అని చెప్పి ఇట్లా కాల్స్ అన్నీ ఒకసారి ఎవరో రాంగ్ రిపోర్ట్స్ ఇచ్చినాము ఎవరో మినిస్ట్రల్ డ్రైవర్స్ అంట వాళ్ళు మీ మీద కేసు పెట్టామని చెప్పి ఇంట్రెస్ట్ మాకు టైం ఓపిక లేదంటే గవర్నమెంట్ వాళ్ళు వచ్చి 2000 samples అట్లా వేసేసి వెళ్ళిపోయేవాళ్ళు సార్ గవర్నమెంట్ కూడా ఇచ్చేవాళ్ళు ప్రైవేట్లో
లివర్ మేడం
So once you finish, please send it to the email so that we can project it and you can explain briefly.
Do it faster.
క్లినికల్ పోస్టింగ్స్ కూడా వేయాలి మేము టైం టేబుల్
ఓపెన్ లేదు దాంట్లో చూసి రాసుకుంటారు దీంట్లో చూసి రాసుకుంటారు
నెక్స్ట్ కొడితే సర్జరీ వస్తుంది
నెక్స్ట్ సర్జరీ
82 రిజల్ట్స్ ఉన్నాయి
అంటే సర్జరీ రాసి టాపిక్స్ రాసేసినాక మళ్ళీ రేడియోలో చూసి ఇట్లా చూసి అది రాసేసి ఇచ్చేస్తే అయిపోతుంది.
So last 5 minutes. Let's finish early. Now it's up to you. So the quicker you are, the quicker it will get over.
హలో
అంటే దీనికి ఇది ఓన్లీ వాయిస్ బేస్డ్ అనుకుంటా.
ఓకే, వాయిస్ రికగ్నైజ్ చేస్తే
వాయిస్ బేస్డ్
క్లినికల్ $440 మనం 5 minutesలో కంప్లీట్ చేస్తాం. ఫీడ్బ్యాక్ ఫామ్ ఫిల్ చేయాలా, రిపోర్ట్ ట్రీ అది చెప్పేపిస్తాం. ఏం లేదు సార్, రిపోర్ట్ ట్రీలో అదేందో లాస్ట్లో
లేదు టెస్ట్
ఫీడ్బ్యాక్ అవన్నీ
టెస్ట్ ఉందా?
ఫీడ్బ్యాక్ ఫామ్ పోస్ట్ టెస్ట్ ఉంది. అదే రిపోర్ట్ ఓట్ ఆఫ్ థ్యాంక్స్ ఇంకా చాలా ఉన్నాయి సార్. ఈరోజు కూడా 520 గ్యారెంటీ.
నేను అదే చెప్పాను. టేబుల్ ఏమన్నా
సర్టిఫికేట్ మాకు ఇస్తే 5:30 అవుతుంది సార్. ఈరోజు సర్టిఫికేట్స్ అన్నీ ఇచ్చి ఫొటోస్ తీసుకుంటాం.
పోస్ట్ టెస్ట్ తర్వాత ఫెయిల్ పోస్ట్ టెస్ట్ దాన్ని చూసేవారు ఫిక్స్డ్ అంటే ఏబిసిడి
2 చేపిస్తాను. ఓన్లీ సర్జరీ అంటే మెడిసిన్ మాదంటే ఒక టైమింగ్ ఇస్తారు. మైక్రోబయాలజీకి మండే మొన్న 8 to 9 అవి ఆ టైంకి మా టాపిక్ చేసేసుకుంటాం అంతే. కోఆర్డినేషన్ అవన్నీ ముందు మా స్టూడెంట్ చేసుకునేవాళ్ళు సార్. ఊరికే అన్నీ ఇప్పుడు మైక్రోది మెడిసిన్ది కలపాలంటే అయ్యేం లేదు. మెడిసిన్ బయోకెమో అనాటమీ కలపాలంటే అనాటమీ ఆఫ్ లివర్, బయోకెమిస్ట్రీ ఆఫ్ లివర్, ఫిజియాలజీ ఆఫ్ లివర్ అన్నీ
లేదు. ఇప్పుడు ఫైనల్ ఇయర్లో కూడా మీరు ఎందుకు రారు? ఇప్పుడు ఇండియన్ మెడిసిన్ వీళ్ళు మెడిసిన్ వాళ్ళు ఇచ్చేస్తారు కదా.
అంటే దాంట్లో రేడియలాజికల్ ఫైండింగ్స్, ల్యాబొరేటరీ ఫైండింగ్స్ అన్నీ, బయోకెమికల్ ఫైండింగ్స్ అన్నీ వస్తాయి కదా. ఫర్ ఎగ్జాంపుల్ మీరు సిఎస్ఎఫ్ మెనింజైటిస్, సిఎస్ఎఫ్ అనాలిసిస్ ఏముంటుంది, వైరల్ కాజెస్, బ్యాక్టీరియల్ కాజెస్ వస్తాయి. సో బయోకెమికల్ పారామీటర్స్ అన్నీ వస్తాయి. సో అవన్నీ కలిపి చూస్తే రేడియలాజికల్ ఫైండింగ్స్ ఏముండొచ్చు అన్నీ కలిపి చెప్పాలి కాబట్టి జనరల్ మెడిసిన్ అదే చెప్పేస్తాను. ఏదైనా సిఎంఈ లాగా మెనింజైటిస్ అని ఒక 2 days పెడితే అప్పుడు మైక్రోబయాలజిస్ట్ పోయి వైరసెస్, కామన్ వైరసెస్, కామన్ బ్యాక్టీరియా అని దాంట్లో ఒక 1 hour 2 hours చెప్తారు. మేము చెప్పినా ఓన్లీ బ్యాక్టీరియా, వైరసెస్ కొంచెం చెప్పి వెళ్ళిపోవాలి బయటికి. దానికోసం మళ్ళీ ఇంకొకరు పోవడం ఎందుకు వాళ్ళే
అంతే.
అప్పుడు మా మైక్రోబయాలజిస్ట్ కూడా ఎన్ఎంసీ ప్రకారం
Are we done? Done, please send the email. Vijay. వాళ్ళు మెయిల్ పంపించారు, వాళ్ళు పెడతారా? వాళ్ళు పెట్టు. సెండింగ్. ఒక నిమిషం. Let me know if you've sent. Just very brief.
మీకు మ్యారేజ్ వచ్చిందా? మేడం ఏం చేశారు సార్? వాళ్ళు అక్కడ
బెంగళూరులో
అక్కడ
వాడికి మా వైఫ్కి ఇక్కడ ఏమి ఇంట్రెస్ట్ లేదు. చిత్తూరు ఎవరు తెలియదు సార్. బెంగళూరులో ఫుల్ రిలేటివ్స్ అందరూ బెంగళూరులో ఉన్నారు. అనంతపూర్లో మెజారిటీ బెంగళూరులో ఉంటారు సార్. చిత్తూరులో కూడా మోస్ట్లీ ఎట్లే ఉండొచ్చు నాకు తెలిసి. మామూలు హైదరాబాద్ పోరు సార్, జాబులు అన్నీ ఫస్ట్ ప్రిఫరెన్స్ బెంగళూరు. సో అందరు రిలేటివ్స్ ఆడే ఉంటారు. ఫ్రెండ్స్ మా ఆడే చదువుకున్నది కొన్ని ఇయర్స్. సో అందరు ఫ్రెండ్స్ అందరూ ఆడే ఉన్నారు. ఒక క్లోజ్ ఫ్రెండ్ మా ఇంటి దగ్గర వచ్చి సెటిల్ అయినారు. సో అందుకు మా వాడికి అక్కడే బాగుంది సార్ ఆడుకునేకి. ఫ్రెండ్స్
ఒకసారి సెట్
వాళ్ళకి స్కూల్ ఫ్రెండ్స్, అపార్ట్మెంట్లో ఫ్రెండ్స్ సెట్ అయినారు. వాడు నేను రాను అంటాడు ఇక్కడికి.
Over. Last 2 minutes. How much ever you have made, you can send. Even if you have made half for half a week.
అన్నీ ఉన్నాయి పిల్లలకి, అవన్నీ అవన్నీ ఉండాలి సార్. బ్యాడ్మింటన్ స్పోర్ట్స్ అన్నీ, క్రికెట్ కోచింగ్ సెంటర్ అన్నీ ఉన్నాయి. అపార్ట్మెంట్కి మ్యూజిక్ టీచర్స్, డ్యాన్స్ టీచర్లు కూడా వస్తారు.
దూరం ఫ్రీ రావాలి. వాడు వాళ్ళు ఇండివిజువల్గా వాళ్ళే ఇచ్చేసి జనరల్ అవేర్నెస్ కోసం
అందుకే నాకు కూడా ప్రశాంతంగా ఉంటుంది. క్లినికల్ పోస్టింగ్స్ పెట్టేసాయి. టైం సేవ్ అవుతుంది మనకు. అవి కూడా కాంపిటీషన్.
So group yellow is ready. Briefly, can you tell?
So, good evening. So, like our topic is like shock. It is PA 5.3 pathology. So, we are describing definition, physiology of shock. So, for physiology of shock, we are inviting for vertical integration with physiology department, that is PY 5.13. And meanwhile, at the same time, in pharmacology department, the fluids and cardiovascular drugs was going on for alignment. And microbiology, the bacteriology topic was going on. And second day, it was so it is only on pharmacology and microbiology classes. And third day, we are doing the pathology, that is etiopathogenesis of shock, and we are inviting vertical integration with general surgery department, that is SU 2.1. So please so, and next day we are saying that pathology, clinical features and stages of shock, that is PA 5.3.3, and on 5th day, like we are going for pathology, like how the treatment, after going the treatment, so how to counsel the patient. So we are making the small group teaching, and we are inviting vertical integration with general surgery department so that they can help us in that one, that is SU 2.3. At the same, and for finally, for assessment, we are keeping in pathology department tutorial, that is SDL assessment, short answer questions and MCQs for them.
I think that was very well done.
Any comments? Okay, they have put competency number essentially for pathology, general medicine, pharmacology and microbiology. Maybe want of time they have not put it, but you have to put it. That's a good point. Whatever bacteriology, anything specific, that competency you should put there. Okay. Can you just scroll up a little bit? Okay, so this is from Monday to Saturday. He's okay. So pharmacology revision, microbiology revision. What is that? Okay, so instead of just putting revision, we don't know revision with regarding to antibiotics or revision with regarding to the previous block, whatever drugs they have chosen. You have to be very specific, because if you are going to give the timetable and say please follow it, they'll be kind of lost. So you are concentrated on your pathology competency always. You can see that focus. Yellow group, yellow. Okay, but good. You have put that integration. Again, I want to, this is a totally different FDP on integration. For integration, you don't need general surgery people coming there. You can teach little bit of general surgery component along with your topic. That's what you meant maybe, correct? Yeah. Anything else? Yeah, you have put family adoption program. They go every Saturday in the afternoon. So he's covered that or uncovered that very beautifully. Huh? Anything? Sent. Yeah, I have got a SDL, short answer, that yellow last. So at the end of this topic, you are giving a small assessment. Very good. I think excellent. Please share it in the BCME group so that we can use it for the next batch of phase 2 students. Very good. Which is the next group? Okay, I think I think the birthday boy has done the best. Happy birthday to you. Your birthday? Many, many happy returns to Dr. Govardhan, and I think he's earned the best gift by doing the best timetable in the BCME maybe. We'll see the others also. Happy birthday to you. Wish you a great year. Okay, thank you. Who is the next group who is going to do? Blue group. Who is going to present? Oh, red has come already. Sorry. Dharani, you want to come here?
Madam, the table has not been prepared because obviously I was not able to find all the competencies in different subjects at the limited time frame. But I understood the concept. So we are from the anatomy, the student would already have the knowledge of coronary circulation, and from the physiology, the student would have already the knowledge of phase 2. So now we are integrating pathology, pharmacology, and medicine. So from pathology, we'll include the competencies in regard to the ischemic heart disease and atherosclerosis. From pharmacology, we'll include the topics from drugs that are used in ischemic heart disease and angina and unstable angina. From medicine, we'll add the topics of ECG, ischemic heart disease, myocardial infarction. Again, the clinical presentation and how do we manage using the drugs which have been taught in pharmacology. That is the total approach there. Microbiology in regard to MI, I don't find any correlation. Cardiovascular diseases can be trophiema vipelli, endocarditis can also be included, but it is not directly related to ischemic heart disease. That's what I meant to say. Yes, community medicine, lifestyle management can be added. Cardiovascular system. Yes, 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 ma'am. Okay. So on day one, the microbiology class I have not included. It has been kept as microbiology only. Yes, yes. So again, the schedule I had to change from 9 to 10 a.m. It is from pharmacology. Describe the mechanism of action, types, doses, side effects, indications and contraindications of drugs used in ischemic heart disease. This is from pharmacology lecture. And then from general medicine, the next class is distinguish and differentiate between stable and unstable angina and acute myocardial infarction based on the clinical presentation. Yes, madam. So initially there will be a lecture, and after that there can be a small group discussion. Lecture. Discussion. Yes. Yes, I should have. Yes, yes. 9 to 10 was. Yes, yes. No. So at the end of the class we can do some, yes, MCQs, we can do that. Yes.
Next group. Next group. You have sent. Blue group has sent. Actually, it's second MBBS, ma'am, not first MBBS. So, yes. Yes. For alignment, we've taken the topics of tuberculosis and cervical carcinoma. So, first day, that's on Monday, we've aligned the topic of TB, that's tuberculosis, with general medicine, pharmacology, and pathology. And on the second day, we've aligned the topic of cervical carcinoma, where in OBG, they'll be explaining about cervical carcinoma, followed by microbiology, then in pathology again. So on the third day, it's on the beta-lactam antibiotics and, sorry, that's pharmacology, ma'am. And for microbiology, it's supposed to be streptococci and staphylococci. And on Thursday, it's on general surgery, DVT, that we've integrated with pharmacology with various anticoagulants which can be used. And those are the practical sessions of pathology, microbiology, and pharmacology.
At the end of each of the classes, we'll be having a formative assessment. So.
The thing is, it's nicely done, but only thing is, you think you will be able to finish teaching TB in just one day? Okay, so it is okay if you had just stuck to TB, you could have brought more elements of TB and one or two non-aligned topics you can add, whichever subject it is. So one day, general medicine, pharmacology, pathology, and there is no microbiology at all here on TB. So if you want to align, it has to be the topic or the competency has to be completed. So please give at least 2 days, 3 days, then you switch to the next one. Otherwise, it will be too much for the teachers and then it will be too much for the students to assimilate everything. So spread it out. No need to show one new topic every day. But otherwise, a concept you have got it nicely. Assessment, it's better to show it somewhere as an assessment session, or at the end of it, I will do a formative assessment or whatever it is, because that has to come. And in this again, you have to include some elements of SDL, ATCOM somewhere, not every week, but at least in 1 month's timetable, it should be reflected somewhere. Okay, thank you very much. Good job. Big round of applause. Next, quickly, 2 more groups, I think. Orange. Nobody wants to come. Hurry. Then we are staying till 6 o'clock here. Okay, go green is ready?
Yes,
yes. Come. Green, pa. Come. Sridhar sir is presenting, I know.
Always lazy.
Poor girl. She's my target since morning.
Our timetable is for MBBS part 2, ma'am, phase 2. Phase 2, sorry. So morning sections 8 to 9, one class will be around for surgery, for applied anatomy. Then 9 to 12, it's for clinical posting. So they're divided into pediatrics, general surgery and general. So based on normal postings they do. And 1 to 2 class, pediatric class, they discuss about acute hepatitis in babies, newborn babies, ma'am. Then 2 to 4, it's divided again into batches, surgery, medicine and pediatrics. So based on the topic they discuss, ma'am. If it's related to, because surgery is related to liver, so we tell them about per abdomen examinations. Then in medicine, they teach about pathophysiology of drug-induced liver injuries. Then in pediatrics, they ask the students to take about history taking. So depending upon the subject. And then Tuesday morning, next medicine, they talk about physiology and biochemical basis on hyperbilirubinemia. And again 9 to 12, they have clinical postings. 1 to 2 class pediatrics, they tell about neonatal hyperbilirubinemia. And again 2 to 4, it's divided into medicine, pediatrics and surgery class. Next morning section, again one pediatric class. Then clinics from 9 to 12. And again 1 to 2, it's a surgery class about clinical investigations and management of liver abscess. Then again 2 to 4, they are divided into 3 batches, ma'am. And one radiology class on liver diseases, ma'am. So investigations on liver diseases are placed. One clinical postings, normal from 9 to 12. Then in this medicine, they teach about alcohol liver disease. In surgery, we can, 2 to 4, we can give them small group discussions or MCQs, ma'am. No, ma'am. Even MCQs, quiz, all not only MCQs, ma'am. Yeah, 2 to 4 will teach on that. Then Thursday and Friday we'll give them on small group discussion, tutorials and quiz. Last Saturday we'll place them on skill lab, ma'am.
Very well done. So phase 3 part 2 final MBBS timetable she has done. Final MBBS timetable. She has done alignment mostly. They have not done vertical integration. Except for that, maybe the first class applied anatomy of liver is vertical integration, basically. Right, Joshna? I think they have done an excellent timetable for phase 3 part 2. Please use it in your actual practice. Okay? And everything you realize, everything even in pediatrics, medicine, surgery, radiology, the whole week is around liver. Till the students get a toxic level of liver failure, we are pushing liver. But then, you know, it is such an in-depth coverage or uncoverage of the competencies on liver diseases for the final year students. I think it's a very good timetable. Thank you very much. Big round of applause, and we'll go to the last group. Last but not the least. I'm sure they're going to be the best. Here, Mike.
Good evening all. We prepared a week schedule for phase 3 part 2, and it mostly covers fractures. In depth. So we included 8 to 9 class on the first day, on Monday, ortho, which covers polytrauma. Then the students will have a clinical posting. Then in 1 to 2 session we'll have introduction to BLS and definition, indications and importance of BLS. In 2 to 4 class we included general surgery, polytrauma, covering polytrauma. And in on Tuesday we included dermatology class, which covers burns, and 1 to 2 session which covers obstetrics and gynecology, which is covering maternal cardiac arrest, its incidents, causes and pathophysiology. 2 to 4 we included pediatrics, introduction to pediatric BLS, difference between adult and pediatric BLS in small group teachings sessions. On Wednesday we have a radiology covering about fractures. On 1 to 2 session, which includes general medicine class of shock management, and OBG covering about maternal cardiac arrest management in 2 to 4. On Thursday we have psychiatry class, which covers post-traumatic stress disorders, and in the afternoon session pediatrics will cover about pediatric BLS, and in 2 to 4 session we provide a demo for students for observation and description of BLS. On Friday, anesthesia class, which includes steps in BLS. On Friday afternoon 2 to 4 we have a dope session on BLS. Saturday is AdCom session dealing with death, and in the afternoon we have OBG, which includes birth trauma, and finally is the assessment.
Okay, very good. So what are the two new things you noticed in this timetable? Audience. AdCom and assessment, everybody said no. What is the other one? Learner-doctor method. So at least twice a week they should be posted in the clinics as a learner-doctor method. That's what the NMC mandates in our CBME curriculum. And AdCom, I said somewhere in that month timetable, so he's included in this week's timetable itself, and very aptly it's dealing with death, breaking bad news, because we are dealing with, what is the thing? Polytrauma, BLS. So very aptly placed AdCom session. I congratulate the group. Very good. Everybody has done so well. I wish you will go back to your departments and tell your colleagues and HODs, please follow this timetable so that it makes life easy for the teachers as well as the students. Excellent. Any other comment before we close? Okay, excellent. Big round of applause to all of you. Thank you. Okay, we'll have a brief repertoire session by Dr. Srinivasa. As he is talking, kindly fill the feedback forms, but listen to him also, please. Feedback form has got 2 pages, back and front. You have to fill it. Day 3 will come in a Google form WhatsApp, and you have to sign your name and sign and write your name in capital. Otherwise, certificate won't be issued. Because this I have to submit to ma'am now. NMC, I have to submit this feedback form.
So, thank you, madam. So, good evening, one and all. So, coming to day 3 review or report here. So, it's okay. So, at the start, post our breakfast, it was a very good and very simple breakfast. At the start, Dr. Lasya madam, assistant professor from India department, she provided a very short and lucrative way about the yesterday's review, day 2's. And second, Dr. Subhadra Devi ma'am, professor anatomy department, she initially appreciated all participants for their good involvement and successfulness in completing the pre-section activity assigned overnight with great humbleness and sense of humor. Then madam clearly outlined the importance of designing lesson plan in a very lucrative and effective way, and by also giving 2 intra-session activities like comments on various plans, on various examples, preparing lesson plan from previous competencies. These were activities done by, conducted by madam. And third session, Dr. Ramya R ma'am, professor Pathology department, she clearly, and physiology ma'am, Ramya R ma'am. So, and effectively described how to conduct OSCE and OSPI with good examples and in stepwise and systematic approach. And the session was also involved activity in the form of creating OSCE stations followed by demo as well as from participants from all groups, which was very interactive and lively. And Dr. Ramya Ramakrishnan ma'am, Associate Dean Professor of Surgery, she described OSLER, that is Objective Structured Long Essay Record, CEX and DOPS with good demonstration by utilizing Dr. Swaroop, second year PG Surgery, and Dr. Gayatri ma'am, AP from Surgery Department. In role play for CX, the session was very interactive as well as interesting. And then coming to afternoon, Dr. Kishore sir from Department of Microbiology, he presented about networking in medical education and healthcare very elaborately, and he also emphasized on the role of MEU and role of faculty in MEU. And there was a very small interactive activity conducted post lunch by all faculty regarding right assignment of assessment tool for previous competencies, competence rating assignment. Dr. Kanakalakshmi ma'am, NMC nodal officer, she gave her key inputs for slight improvement regarding the activity, which was very received humbly from all participants. In future, Dr. Jyoti Brahmaya ma'am, pathology department professor, she described effectively about the need for mentoring students, medical students, and how to apply the principles in UG and PG curriculum. And last session, Dr. Ramya R ma'am, she described the steps involved in drafting timetable for an academic year very lucratively. And the final day of BCME session was concluded with post-test by participants. And last overall, it was a very great, lively and interactive BCME session, which will be having a significant impact on our professional growth in medical teaching and learning, which in turn provides good output for very skilled, knowledgeable doctors with great empathy to the society. With this, I'll conclude my report here.
Kindly fill the day 3 feedback form and also the post test which has been just sent into your WhatsApp group. The link for post test is just posted. Please check, there are 2 Google forms you have to submit today. Day 3 feedback and the post test for BCME. Thank you.
ఒకటి ఫీడ్బ్యాక్ ఫామ్ ఒకటి పోస్ట్
ఫస్ట్ పర్సెంట్ నా ముగించింది టైం మేనేజ్మెంట్ టైం మేనేజ్మెంట్ ఇంకెవరు వేస్తున్నారు వర్కింగ్ పేరు
సైన్ చేశాను పైన కూడా చేయాలి
పెట్టినారు
పైన
ఓకే రైట్ దీంట్లో 2 ఫామ్స్లు ఉన్నాయి 2 ఫిల్అప్ ఓకే ఏది ఫీడ్బ్యాక్ ఫామ్ ఇది ఫీడ్బ్యాక్ ఫామా
అన్ని డాట్స్ 4, 5 సెలెక్ట్ చేసేది ఫీడ్బ్యాక్
ఫస్ట్ డే రాస్తాను ఇది ఫీడ్బ్యాక్ ఫామ్ కదా ఇది ఫీడ్బ్యాక్ ఫామ్ వచ్చేసి జస్ట్ ఫీడ్బ్యాక్ ఈరోజు 4
పోస్ట్ టెస్ట్ ఉంది చూడండి సార్ లాస్ట్లో
లాస్ట్ వీక్ అన్ని ట్రై కూడా రాస్తాను కోఆర్డినేషన్
knowledge or whatever you had about the topic before the start of the BCME, 1 being below average and 5 being excellent. At the end of 3 days, has there been any change in the positive way or on the negative way? Whichever way you can write. You're free to write whichever number you want. But you should introspect and please fill that number.
Statement of what learning would be able to
గోల్ అని పెట్టాను సార్
learning experience.
గోల్ అని పెట్టాను
సెకండ్ క్వశ్చన్ ఏంటి మేడం చేయండి మేడం సెకండ్ ఏది పెట్టా అందరూ ఏది పెట్టారు
నేనేమో గోల్ అని పెట్టాను
సార్ నేను గోల్ పెట్టేసాను
థర్డ్ వన్ ఏమో నాకు తెలిసి సో ఫస్ట్ OSPI అంటే ఫస్ట్ అనుకుంటా ఫస్ట్ కదా OSPI థర్డ్ వన్ ఫస్ట్ సార్ వాట్ ఈస్ ద మెయిన్ అడ్వాంటేజ్ ఆఫ్ యూజింగ్ OSCE ఓవర్ ట్రెడిషనల్ ప్రాక్టికల్ ఎగ్జామ్స్ సో సెకండ్ అనుకుంటాను OSCE ఫోర్త్ ఇట్ మినిమైజెస్ ద ఎగ్జామినర్ బయాస్ బై యూజింగ్ స్ట్రక్చర్డ్ స్టేటమెంట్స్ 4 ఏమో నేను బి పెట్టాను సార్
I request Dr. Dharani sir to please come and give a verbal feedback.
Which of the following best defines self-directed learning?
Thank you, Dean sir, Associate Dean ma'am. Thank you, Kanaklakshmi ma'am. Thank you for all the facilitators as well as my participants for making this quite interactive. I have learned not only from the teachers, facilitators, as well as I have learned definitely from all the participants. So this session was definitely quite interactive. It was fun, as well as elaborate and also to the point. So I definitely have learned a lot, and I have also experienced from the teaching methods that you have incorporated in this learning experience as well. Then, so previously, when I teach the students, I usually bang my head when they don't engage. Now I think I have a lot of options and answers for at least certain questions. If I have some doubts, then I may again come back to you. And everything has been extremely nice because I have not ever experienced so much interactive session. Though previously I have been to multiple workshops. One thing that I would like to add up, I would like to suggest to this workshop is, that is from CMC. Recently I have been to a neurology conference as well as a hematology conference, where the food was only working lunch. So it used to be very limited, though your interaction as well as the teaching methods didn't let us sleep. Even if the sleep comes to us, if the limited lunch would be very helpful. Thank you everyone, thank you so much.
Thank you so much, sir. Anyone else? Request Dr. Ashish to please give his feedback.
Good evening, everyone. It was a very interactive session today, and we had a very good opportunity to attend this program, that too in our own medical college in Chittoor itself. All the 3 days, I have learned something new. So I'm eager to apply this thing when I go back and teach the students. That's it. Thank you.
Thank you so much, Dr. Ashish. I request Dr. Kavya to give her feedback.
Good evening, everyone. Actually, before attending the session, as soon as I've heard the dates of the session, I was actually dreading to attend the session because I was very scared, because as such I'm an introvert. So I don't like to work in a team. But after attending the session, now I'm confident that I can work in a team, as well as I've learned many new things in the session over the last 3 days, where each and every facilitator and the faculty, they were very helpful in putting things into our heads rather than us finding things ourselves. So overall, it was a very pleasant learning experience. I would like to thank each and every one of you. Thank you.
Thank you so much, Dr. Kavya. Can I ask Dr. Shweta to please come and give her feedback?
Good evening all. Thank you everyone, Ramakrishnan ma'am, Kanika Lakshmi ma'am, all facilitators, dean sir, for giving me this opportunity. The session was very structured and clear, making us easy to follow. And the discussion on teaching learning methods was very comprehensive, offering practical examples. Speakers engaged audience well with interactive sessions and discussions. And the session mainly highlighted the actionable strategies like learner-doctor method, which make us to follow in our clinical postings. Overall, the session was very informative, well-structured, and it provided us essential tools which makes us enhance our teaching qualities. Thank you. Thank you.
Thank you, Dr. Shweta. Can we get a word from any of the facilitators? Sir?
Good evening all. I think we are in the closing session. So probably a few of people might be very happy to go back to your departments and go to your routine works after this 3-day long session, right? So very enthusiastic teams, all the teams are very much enthusiastic. We have seen, because in some of the BCME programs or RBCW programs, we see much less interaction because of the age groups where madam was telling. Probably some senior professors will be there, they will be sitting and then they will be just listening and no interaction, sometimes not happening there. But all assistants, much enthusiastic team as being seen. And one thing actually, we are here always, the MU team and then the curriculum committee team is always here for you to help in your routine things. So whenever you want to approach us, we are always here for you to approach. So for anything, you are always welcome. That's what I just wanted to tell from this side. Thank you.
Thank you, sir. I now request our Dean, sir, to please come on to the dais. I also request Dr. Kanalakshmi ma'am to please come on to the dais. Ma'am, can you speak a few words regarding the session?
Good evening, everyone. Actually, it was a wonderful experience last 3 days. It was a wonderful MEU team, I should say. Those who took the sessions really did a great job. It was a very interactive, and the participants, they were very patient. Even some days I was very restless. Once it crossed 5 o'clock, I will be looking into my watch and thinking, when is it going to get over? But I didn't see that restlessness in the participants. You were all very patient, though most of you are clinicians. That is the thing in the list. So it was very nice to watch you all. And this is a wonderful platform, actually. I always used to think I am double blessed to be a teacher. When I joined my medical college, I never felt that I will be a teacher. Most of you would have been the same. We would have got into intention with a big high aim that we are going to serve the society, but we are in a much better position now, and it's the best thing which we can all do. Being a teacher is the best part. You can be with the younger generation, you can express your views, you will have a lot of. Today ma'am was saying she went to US and she found that one of her students in US who's found her in the park and came and said that you are my teacher. That's how we are all. So please enjoy it, and this BCME definitely would have given you some insight into you, some forms. Right from taking an attendance, you can just engage with your students. Tell them only when you finish this, when you walk out, when you finish that 5 take-home messages you give, I'll give you an attendance. You can see another 5 more students listening to your class. Ma'am was saying, I am a failure. Someone didn't turn up for an month. Students are students, ma'am. Even if we were students, we would have been the same. But still, we can make a difference. They all will change. May not be now. When they go back, after a few years, they might think, this is what they told me in the class. This is how they connected me. Small things, if we can change it into us, create some innovation. We can't always rely on the simulation lab. There was one ma'am who came from government medical college, said that she used papaya to teach them how to insert a IUD. So make small innovative things. Ma'am was saying that they use wool and all to show the artery, nerve supply and all. Such simple things you can ask them. They are all very creative. Though they are all with the technology, they are all very creative. You can get it from them. You can involve them and publish them. Lots of papers can be published. Try and make one publication with your medical education. You can all become a very successful teacher. I am sure, like ma'am, we will all have a big crowd behind us, and you have a supportive medical team. Get help from ma'am. So many of them are there. So they are, even if you have small techniques, get help from them, and you can all come up with good papers, and you can have an impact in the society. All the best, and thank you, ma'am. Thanks.
Thank you so much for your kind words, ma'am. We really enjoyed with you. Now I request Dean sir to give away the certificates to the participants.
Dr. Rachakonda Shweta. Dr. T. Govardhan. Anna fast. Dr. Kavya J. Dr. Kavya. Dr. Ravikant. Dr. Geeta Anusha. Dr. Hemant Kumar. Dr. Mauna. Dr. Guru Sridhar. Dr. Adur Pavan Kumar. Dr. Anil Babu Swarna. Dr. Rosanna Sirisha. Dr. S. Ramya. Dr. Shweta P. Dr. Srinivasa B. Dr. G. Karthik. Thank you, sir. Now I request our Associate Dean Ma'am, Dr. Ramya Ramakrishnan Ma'am, to please distribute certificates. Dr. N. Sindhuja. Dr. Lasya Raj. Dr. Mahendra Reddy B. Dr. Subramanyam Gayatri. Dr. V.S. Joshna. Dr. I. Pallavi. Dr. Rajesh P. Dr. K. Maunika Jyoti. Dr. M. Sairam. Dr. Ashish Mohammed. Dr. Noble Rao. Dr. Y. Tejasri. Dr. Sunanda. Dr. A. Dharanidhar. Dr. Gona Priyanka. Thank you, ma'am. Now I request Dr. Kanakalakshmi ma'am to please distribute the certificates for resource faculty, ma'am.
Registration number తప్పేసారు. చేంజ్ చేసుకోవాలా? 619 అనేది సార్ 61836. 619 సార్ 619.
Dr. Ranganath sir. Dr. V. Subhadra Devi ma'am. Dr. Kishore sir. Dr. Ramya Ramakrishnan ma'am. Dr. Ramya R ma'am. Dr. Jyoti.
వైట్ పేపర్ వేసుకుంటే సరిపోతుంది. వైట్ 9 ఎక్స్ట్రా పడింది సార్ 61836 61983.
Thank you very much, sir. Thank you, ma'am. I request Ramya Ramakrishnan ma'am to propose the vote of thanks.
Post test to be submitted by 2 more people. Please submit it now itself. And feedback also, 9 members are yet to submit day 3 feedback. Please submit it immediately.
Okay, whoever has not submitted, submit it. But okay, it's my proud privilege and honor to propose a vote of thanks at the end of 3 days of very intense but I think happy learning that happened. I thank first of all the participants who came on time the first day and were so punctual and so diligent in their work, and I think it was very easy to get our sessions done because all of you were so enthusiastic, and really I thank all the participants. I hope the learning you apply in your own practice. Thank you very much to each one of you who attended the BCME as participants. And next, I wish to thank all the resource persons, both MU members as well as the curriculum committee members who were acted as facilitators, and the MU members took the main sessions. I think we did a lot of planning into it, and each one of them was very proud of their own session. They did so much of last minute games, jigsaw puzzles, and activities to make it very interesting. I think they have really gone out of their way to do this so that it has become enjoyable for you. So I thank each one of them of the MU and CC, and also Dr. Sachidananda Adiga, who is very good at facilitating sessions. I thank all of you. I wish to thank our Dean, Dr. Alfred J. Augustine, who is very, very keen that we should get the BCME going on again after a gap of almost 2 years. we have got the chance, thanks to the Nodal Center, that we have done this BCME, and I'm happy to say that I think I'm very satisfied with it. So it is very exciting and nice. Thank you very much, Dr. Alfred. I wish to thank the management, our COO, Naresh Kumar, for helping us organize everything, all the IT department, the support staff, Mr. Apura, facility manager, our photographer. You see how enthusiastic he is. From 8:15 on 3rd to say 5:30 on 5th, he is ever active. So is Mr. Vijay, our IT support, and the housekeeping, and everybody who made this, and the catering, now Hotel Sinduri Enterprises, for their excellent food. As Dharani said, we did want to have a working lunch, but like any function, the first feedback comes on the food. So if I go a little low on the food, then the feedback will be bad. So we decided to give you sumptuous lunches, but I think it worked anyway. I thank. And last but not the least, I thank Dr. Kanakalakshmi ma'am, our observer from the NMC Nodal at CMC Vellore, for very patiently sitting through every day. It's not easy to sit through somebody else's lecture, somebody else's workshop, very patiently, and she was kind enough to give comments and suggestions to improvise our own work that we exhibited here. And thank you very much, ma'am, for your inputs. We really cherish it. And thanks again. If I missed anybody, I'm sorry about it. But who?
Yeah, we thank actually the entire team, the MEU team and curriculum team, Dr. Ramya Ramakrishnan madam. So she's very much enthusiastic. She made us to stand on our toes to work from the day one. Right. Thank you, madam.
Thank you, one and all. Okay, we'll have the national anthem. I request everybody to stand and sing, please.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Thank you.
Participants, before leaving, if you just can stay for a while. Our birthday boy is there. We have a small cake. We'll just do a cake cutting. Please bring the cake.
ఇక్కడ వేరే డిపార్ట్మెంట్స్ ఎవరు తెలియదు మన గ్రూప్ అది గ్రూప్లో పోస్ట్ చేద్దాం.